네, 개회사로 오늘 순서를 시작하도록 하겠습니다. 네, 회장님 부탁드립니다.
예, 이른 아침부터 와주신 회장 회원님들께 감사드립니다. 그러면 지금으로부터 제75회 대한비뇨의학회 정기학술대회를 시작하도록 하겠습니다. 감사합니다.
네, 지금부터 KUA 2023 슬로건 선포를 하겠습니다. 이번 제75차 대한비뇨의학회 학술대회는 전문, 혁신, 그리고 열정으로 발전하는 비뇨의학과라는 뜻으로 Enhancing Urology with Expertise, Innovation and Passion 이라는 슬로건 아래 2023년 11월 1일부터 4일까지 4일간 서울 코엑스에서 개최됩니다. 여러 학술 프로그램과 소셜 이벤트를 즐길 수 있습니다. 개회식을 마치며 이어서 9시 30분부터 플래너리 세션이 진행될 예정입니다. 진행되는 세션에 많은 참여 부탁드립니다.
네, 안녕하십니까. 다시 한번 인사드립니다.
Good morning, everyone. Very good to see all of you. My name is Kang Seok-ho from Korea University. We are going to begin the second day, the plenary session. Sorry that we are going to begin earlier than the schedule. Hope you don't mind. And during the plenary session, I believe that there are some kind of new elements from Wednesday. We started the plenary session much earlier than before, and simultaneous interpretation services provided to boost or encourage discussion, active discussion. And Vice President will talk about the history of our society, and it's going to be something special. And to begin with, let me introduce my co-chair, Dr. Hong. Very honored to moderate session with you, Dr. Hong Sung-gyu. I'm honored to co-chair with you too. We have speakers from abroad today, and I believe that it's going to be a very informative session. And yesterday we had a lot of presentations, and Dr. Bob will summarize the presentations that we had yesterday. Thank you.
네, 소개 감사합니다.
Thank you for the introduction. So we are having this event starting from yesterday, and in all these sessions we could enjoy heated discussions and the exchange of opinions. It was my pleasure to see all the scholars and doctors share their research and get feedbacks. All the abstracts were wonderful, but because of the time constraints, we would like to share some of the award-receiving papers here on this location. And first, this was the Best Presentation Award paper. And this was titled Dementia Associated with Anticholinergic Monotherapy or Beta-3 Agonist Monotherapy or Combination Therapy Used for Overactive Bladder. The study used insurance data to see its career implications. The study wanted to take a look at the combination therapy of mirabegron and the anticholinergic therapy and compare this against anticholinergic monotherapy. The population was 3.45 million, and 45% was anticollagen only, and 20% was beta-3 agonist only, and about 25% were in the combination therapy group. And the result goes like this. The proportion of dementia development was higher in the anticholinergic and combination therapy than mirabegron group alone. What's confusing is that we thought the mirabegron was not related to cognitive functions or dementia, but it turned out that depending on the dosage period, when we classify them into the low dose and high dose and medium dose, when compared to low dose group, and high dose group, the dementia development rate was different depending on how much dosage the patient was exposed to. So mirabegron showed dose-dependent changes in the probability of the development of dementia. Also, when it comes to anticholinergic as well, we also have classified them into different drugs, and the result shows a slightly different result than our previous understanding. Relatively, Dystrospium and fesoterodine, which are known as relatively safe drugs, had a relatively higher hazard ratio, and the abstract results will be subject to the discussion going forward, looking at the paper itself. Next is the Best Presentation Award from the Cancer Prostate section. The NCCN guidelines says that for patients who undergo active surveillance, the guideline recommends confirmative biopsy in 6 to 12 months. The study looked at the actual need for this confirmative biopsy and what happens and what is the result and the effect of confirmative biopsy. There is the active surveillance cohort group participated by 12 agencies and starting from 2016. The group is taking in diverse data, and currently 558 patients are enrolled in that group. And in 6 to 12 months, these patients undergo confirmatory biopsy, and we checked if the confirmative biopsy are actually needed. As I told you, the patient was 558 in number, and in this specific study, 30 of them enrolled, and 246 patients were included in the study. So 85 of them conducted pre-biopsy MRI, and 65% of the patients took post-biopsy MRI. And as for the pre-biopsy MRI group, 54 of them took systematic biopsy, and 31 of them took MR fusion biopsy. And as for the post-biopsy MRI, 79 of them took systematic biopsy, and 15 and 70 of them took transperineal and MR fusion biopsy, respectively. MR fusion biopsy and active surveillance group and conventional biopsy and active surveillance group did not show significantly meaningful differences. And when we conduct confirmatory biopsy, the glycine 6 group was classified into glycine 3+4 and 3+3. As this is the pathological reclassification. In most cases, they were glycine 6 score group, and only 3% of them was 3.4. But in the confirmative biopsy, the percentage increased to about 35%, and in 3%, the glycine score increased to 4+4. And by group, we looked at the difference between the conventional biopsy group and MR fusion group, and we could see that the reclassification was higher in the MR fusion biopsy. And we have looked at if lesions are visible in MR fusion biopsy or not. And after initial biopsy, if lesions were visible in the MR fusion biopsy, pathological upgrading was a more noticeable trend. In 6 to 12 months, so the data confirmed that we need confirmatory biopsy in 6 to 12 months. Next is the Best Presentation Award receiving paper from the kidney cancer. Small renal cell carcinoma under the 4 centimeters can happen late recurrence in synchronous metastasis, and we wanted to identify the biomarkers of these patients. Prospective cohort RCC database included 4 aggressive CCRCC group and 4 cases of non-aggressive CCRCC group. And monoclonal cells were extracted, and we conducted sequencing, specifically RNA sequencing. And we identified 22 target genes, and HLNADQ gene was 21 times more expressive in aggressive small cell carcinoma than non-aggressive ones. This is not saying anything clearly, but we have checked the biomarker for this aggressive small cell RCC, which means we have a great potential of using this biomarker going forward. Next is the paper related to basic research. As you are well aware, spinal cord injury and butt microbiota dysbiosis are closely linked to the bladder function. This basic research looked at how dysbiosis of the microbiota after spine injury affects blood function. Mice with spine injury got transplanted and saw how this can improve the bladder function of the injured mice. After the spinal cord injury on day 3, gut microbiota dysbiosis gets aggravated significantly. This is one thing we could find out. In a nutshell, after the spinal cord injury, if the gut microbiota gets decreased and disappears a lot, if we transplant healthy microbiota into the mice, this helps restore the bladder function of the injured mice. And we do not see any clinical application of this research yet, but this might provide us with a hint as to how we can maintain and restore the bladder function of the spine-injured patients. Next is the research from the pediatric session. When it comes to fecal incontinence and chronic constipation, transnasal irrigation is known as a very effective treatment. We conducted a survey, the researchers conducted a survey on transnasal irrigation patients. They already had about 21 active users, and 12 said that they are non-users. So under the survey, we could identify why they were not using the irrigation device and so on and so forth. And fecal incontinence is the case where involuntary fecal loss takes place at least once a week. And when the patients get about 10 to 13 years old, they tend to withdraw from the study. In a nutshell, after 12 years usage, TAI has been proven as a safe treatment method with no significant complication. But users, depending on whether they want to use TAI or not, and depending on these use cases, fecal incontinence and life quality do not actually portray significant difference. So TAI is known as a safe method, and patients can opt for this treatment. This is what we could confirm from the survey. Next is the Best Presentation Award from the Endourology and Stone Disease session. When we do uteral access sheath, using a thicker one helps. We saw 7-day tamsulosin administration before the surgery helps patient or not. For the 1-week pre-op, 83 patients administered 0.4 grams of tamsulosin, and we could see that preoperative administration of tamsulosin 0.4 milligram for a week increased the insertion rates, and there was no significant difference in periop administration of tamsulosin. the administration of the tamsulosin did not significantly alleviate symptoms related to stents. However, the overall time spent decreased. So before surgery, we think hard about how we can safely insert the UAS, and I believe that this study provided us with a help in finding out a potential solution to this. And next is a best presentation award from the cancer bladder, pelvis, and uterus cancer. When it comes to bladder cancer recurrence, to prevent this, we conduct PC induction and PCD injection. And after that, some patients fail. And in this regard, utilizing chemical material, we do intravesical therapy. And this study, gemcitabine, doxycycline, and mixed intravesical therapy was used. Indeed, 153 people failed induction therapy, and targeting these population, 5 people were put to reinduction group, and 6 got gemcitabine, doxycycline, and intravesical administration, and this is the result table. If you look at the treatment outcome, gemcitabine doxycycline group did not have high-grade recurrence, and intravesical therapy did not give any significant complications. And the paper said that BCG treatment failed patients might benefit from using gemcitabine doxycycline intravesical therapy as a salvage therapy. Next is the best presentation award from the video session. And due to time constraint, I will just show you some of the screenshots from the video. This is the process of creating vagina in the transsexual people. And so they had penis, but the vagina was created here in this video presentation file we took a look at. So this is how the surgeon would mark this, and this triangle area would be the spot where the vagina would be created. When doing surgery, corpse carbonism is dissected, and urethra is first marked. And after size reduction, this corpse carbonism is made into clitoris, and the penile skin serves as the wall of the vagina. As you can see, utilizing the full lap, utilizing the anterior flap, we turn it around to make it the outside wall of the vagina to create a blind pouch, basically. Neovagina space is secured like this, and canal dilator are put inside to secure some space. And with lateral extension, we conduct dissection, and after that, we can see that the surgeon is trying to create a space for a pouch. And here in the sewn area, this is the inverted penile skin area. Actually, there is an inverted hole, and here, by suturing it with a peritoneal flap, this area can serve as a blind pouch. We suture this area so that this space can serve as vagina. Regarding the application of the robotic surgery, we are still keen to know. In the surgeries which require very complicated suture, and in surgeries which require us to think about cosmetic aspects such as M2F, the robotic surgeries are showing us some promises, and I believe that we could share some of the promising results. Thank you for listening.
예.
Thank you so much. Sorry that we have asked you too much, summarizing what we did yesterday, but you did a wonderful job. You did a wonderful job. And let's move on to the next presentation. And we have done our best to upgrade our conference. And I believe that this will be a good presentation for us to look back on what we have done till today. And he's serving as a vice president of our association, and she will talk about the history of our society. And as for the history of the society, we have senior members who have been with us for long, and you are aware of that. But we have young members and members from abroad, and I believe that it's a good chance for them to share our history together. Thank you so much. I am from the Jeonnam National University, and my name is Seonho Kim. I am very honored to make a presentation on the history of KUA. So I'm going to talk about the milestones of KUA, but not all of them, because I am given only like a short period of time. We are having 75th annual meeting, which means that we have a long history. So allow me to explain or talk about the story in like 10 minutes. It was back in 1945, Korean Society of Dermatology and Urology was founded. And the first academic conference was held in 1947. And dermatology and urology hosted the conference together. And later in 1954, we were separated from dermatology department. And we have the first president of Lee Hak-sung to lead the Society of Urology. It was later in 1959 that we held the first conference of the Korean Society of Urology. It was a photo taken in 1930s. It's one of the oldest photos that we have, and it's a derma urology class held in Daegu Medical School. And this is a conference that we had in 1969. As you see, we have a lot of members who joined the conference, and they have taken this picture. Later in 1972, they had a conference and took this picture. And in 1978, we had the conference too. From 1982, we have color photo, no longer black and white. 1983 conference, 1987 conference. Back in 1937, when we were the colony of Japan, there were doctors who came to or have went to Japan and Europe to study, and they have taught what they have learned from other countries to our juniors. They were the president of the organization. The incumbent president is Dr. Lee. Besides the president, we have a chairman of the board of directors. KUS, in 2012, it was first introduced. Back then, we had the honorary chairman system was installed, and Dr. Liu was the first honorary chairperson. This is a history of active interaction with other society abroad. In 1984, the Korea-Japan Urological Association meeting was held in Japan, Kobe, and we decided to host the conferences every year, once in Korea and once in Japan. We had joint symposiums along with EAU and other society, ICS, SIU, and ISM, These are the international conferences we have hosted in Korea. The photo was taken when we had Korea-Japan Urological Congress. And this year, it was about 1 or 2 weeks ago, we had the conference in Japan. Next year, we are gonna host it next year, and that's gonna be the last conference we are gonna have between Korea and Japan. Back in 1996, Asian Congress of Urology took place. And this is a group photo that we have taken this year. Dr. Bach, our chairperson, are in the photo. In 2001, the 31st ICS annual meeting took place, but it was when the 9/11 took place. Later in 2013, KAU and AUA signed the MOU, and Newsender and KUA signed MOU in 2010. In 2018, we had a conference, SIU in Seoul, commemorating 70th anniversary of the association. Dr. Song was a vice chairman of that conference. We had APAP held in 2020. Pediatric Urology Society we hosted in hybrid, online and offline combined. So let me have a look at the history of our association. Back in 1982, we had the board of directors system installed. And a very important milestone is the publication of the journal. As you see, the 50th anniversary saw the publication of our journal. And later in 1999, our website was opened. In 2005, the English version or English website was open too. We also started to publish a Korea Urology Today. It's kind of a newsletter. And later in 2009, we introduced a chairman system. In 1998, we had a general booklet. A comprehensive survey book was published, and all the history of the organization was described, and the activities that we have had in 16 subsectors were described. An updated version was published in 2018. This was the first book published, and second to the right. In 1996, the Association of Korean Urologists was set up. Actually, we have gone through a series of renaming. First, it was named Association of the Clinicians who practice on their own, and then changed it into the Association of the Korean Urologists in 2018. And this is a first paper published in our journal. And we have continued to progress. And in 2009, we started to publish a English version of Korean Journal of Urology. And the journal has been renamed into Investigative and Clinical Urology in 2016. And we were listed on the ICU, Urology, ICIE. And as you see here, the impact factor has continued to improve, as you see on the slide. This is the cover of the journals. As you see here, we have investigative and clinical urology, and this is a current cover of the journal. In 2018, we were listed on the SCIE, and in 2019, we had the ceremony to celebrate the 60th anniversary. Then let me have a look at the textbooks that we have published, or the covers of the textbooks published. And the version 6 or edition 6 was published in 2019. And it was shown on the right side on the slide, and website was opened in 1999. And then it was upgraded in 2003, and in 2005 we also had the English version, English homepage open. We had portal site which continued to develop, and now we have a interactive type of homepage. This is the current homepage. And the logo has changed from this to this, as you see at the bottom. We also publish Korea Urology today, and first version was published in 2005. Right now, as of today, we can read it online. Back in 1993, we introduced a training system for the resident. Then we have different academic programs such as etc. Symposium, KUA Dinner, launched in 2008. Later in 2009, we hosted Forum for the Nurses for the first time. In 2011, KUS was introduced, and then we introduced KUA app in 2012. Our conference was held in the K Hotel, but in 2019 we decided to change the venue to host this conference in COEX. And in 2020 we had online conference, and in 2021 we have introduced a metaverse. In 2021, UDS workshop was introduced or launched. In 2000, there was a strike to resist against the introduction of the new system of separating the prescribing and dispensing the drugs. So 52nd conference was cancelled. And in 2015, we were hit by MERS and later by COVID-19 in 2020. This is the conference that we have held in COEX, and he was holding the textbook published. This is the online conference that we had in 2020. In 2013, we also established a foundation, and through the foundation, we were able to offer active social services at home and abroad. Cambodia and Swaziland are the countries where we provided our services. And the handbook was published for the resident in 2014. A special handbook for the urology resident was published. In 2017, the name of the association has been renamed the Association for the Department of Urology. In 2012, we had Kim Se-chul Academic Award introduced. So every year we appoint awardee. And last year we celebrated its 10th anniversary, and foundation was established in 2013. And we launched a diverse campaigns to educate the general public on the prostate cancer and to prevent urologic diseases. Cambodia ESWL instrument, we donated one of them to the state hospital in Cambodia. We signed the MOU with the Swaziland and provide a diverse services to them. You can have a look at the activities that we are doing on homepage. So refer to the homepage for the detailed information. So ESWL room was open and they were having ceremony there. Dr. Kim and others were on the photo. We have hosted and implemented different kind of campaigns for the general public. Back in 2003, we launched the campaign to educate the prostate. And Blue Ribbon campaign was launched in 2004. And Blue Apple campaign was launched in 2011. And in 2013, we started to implement our Active Life campaign. When you go to the homepage, you can have a look at the history of the campaigns that we have implemented. So this is a campaign that we have implemented in 2003, 2004, and 2011. Gold Ribbon campaign is about the urinary incontinence. And in 2008, we launched this campaign to educate the incontinence on the general public. And our society has been renamed in 2017. Shin Dong-yeop, a famous entertainer of Korea, was designated as a promotional ambassador of our society. We joined the Korean Society of Medicine, and in 2004 we received the Best Member Award. So they were the photos taken back then. We share expertise and know-how with experts of different specialties of urology, and we try to achieve a balanced development of different regions using a JUMP program. In order to improve the endoscope, we introduced a certificate system of the urology endoscope. And last year, we have created a character for our association. He is a promotional ambassador who created the character, and it has been adapted to different kind of products. And we have a surgical cap with the characters on stickers. So when we make gift or souvenirs for the societies, we use that characters too. Last year in 2020, Eurofund Run was launched to help those patients who suffer from Lou Gehrig's disease. We are going to have the same run marathon session tomorrow or on weekend. And last year, Shun, the entertainer, was with us. And to the right, we have a announcer, Park Ji-ae. Park will join us tomorrow, and Shun, maybe not. It's not confirmed. The office of our society, it was opened in 1956 in Seoul National University. The first office was there, and then it was relocated to Jamsil. And current office is located in Park Tower in Yongsan. They are the members or staff of the association. In total, we have 5 members. One of them is missing in the photo. Currently, this is the organization of the association, the chairman and the members. and they are very active. Thank you for your support and efforts. And with the name change it in 2017. We have updated or upgraded our signboard too. We were told that the font was created by the mother of a professor who is in the photo. For the resident and specialist of a KUA in 1980, the period of resident training was reduced to 3 years. But back in 1986, it was increased to 4 years again. In 1994, 69 doctors applied for the urology license board exam, and only 15.9% of them passed. And in 2005, we have more than 100 new urologists joining the board. We have a quota of 120 for the urology, and 111 passed the license exam. And in 2018, we see a drastic decline in the number of new residents. Our quota is 50, but only 19 has passed the exam to join the Department of Urology as a resident. So this is the number of specialists. In total, more than 3,000 specialist urologists that we have, but the new urologist joining the board every year has declined. So last year, only 29 joined the board, and 37 joined the board in 2023. This is the number of residents. The quota of the new residents is as you see in the table. But as you see here, the number of interns who apply to become the resident of urology have declined, as you see here. Even though the quota has declined, the number of interns who apply for the urology department has declined much faster. However, it has been reversed in 2022. We have 54 who apply for the Department of Urology, which is good. At that time, we felt that we were in crisis. How come we do not have enough number of interns applying for the urology? We tried to overcome the crisis, and we launched some campaign, and the photos were taken back then. And we had a press conference for the geriatric medicine and pediatric medicine. And this is the number of a female resident. We have 4 female residents joining us this year. Last year it was 6, and as of this year we have 17 female residents. And in total we have about 50 female. It was back in 1999 when we had the first female urologist. In 2007 and 2010, we had 5 urologists joining the board. Can you speed up? Sorry. Are we behind the schedule? Okay, let me speed up. We have a e-learning system to educate the resident. We have very active resident trainings implemented in place. Eurokids 1 contest, we are going to have it this year too. Resident, please join as much as possible. We have a brochures published for the interns so that they can understand what they do once they become the resident for the urologist. We have a subspecialty conferences or societies quite active too. We have study groups, 2 of them, and we have chapters or branches, 9 chapters across Korea. Our slogan was introduced in 2013, and for the further advancement of the association, we have done our best. I have covered the history of the association or society. Sorry that I have not touched upon all the important milestones, but I'm going to wrap up my presentation with this. Thank you for listening. Thank you. Thank you so much. This is the first time for us to talk about the history of the society and association. And I thought that it was not easy for you to prepare this kind of presentation. You did a wonderful job. Thank you for your contribution. We have 1406 specialists and about 270 people join us from abroad. So for this conference, more than 1,400 people or doctors joined this conference this year. Thank you for your active participation. Thanks to all the efforts that you have made, the senior members and all the mentors. Thanks to you, we have made such a progress up to now. And I believe that it was a good chance for us to look back on what we have gone through and show our respect to the senior members. We have a long way to go, and some of you might believe that some important milestones have been missing here. So let us know if you have any kind of good data to share our history. Let us know and share them with us so that we can make a presentation next time. On behalf of our members, we are gonna have a special session to show our respect. And now, would you please stand up and please give a big hand to our senior members. Thank you so much.
With that, we would like to begin the academic leg of today's plenary session. The first session is men's health. Dr. Lee Won-gi from Hallym University would talk about management of non-responders to PDE5 inhibitors. And Professor Lee, please mind your time limit. Thank you. Hello, I'm Lee Won-gi from Hallym University. I would like to talk about management of non-responders to PDE5 inhibitors and how we can manage these cases. As you are well aware, regardless of the types or the cause of the ED or erectile dysfunction, oral administration of drugs, including PDE5 inhibitor, is the first-line treatment. However, in clinical practices, when using PDE5, 30 to 35% of the patients do not respond, and the reasons might vary. But overall, sometimes the inappropriate use of the drug is the problem, or the ineffective drug itself can be the cause of this non-responders. So based on the literature, I have looked at the cases of non-responders, and before we get to invasive steps like ICI or penile prosthesis, I would like to talk about what we can do in the meantime. First of all, we have to see if we have made multiple attempts regardless of the type and the dosage. Like I said before, 30 to 35% of the patients are non-responders to PDE5 inhibitors. But if we try more, the success rate is proved to creep up to 80%. Indeed, the International Society for Sexual Medicine and European Association of Urology suggest that we make at least 6 attempts. So even if we fail after 1 or 2 attempts, I believe that we can try more before moving on to the next step. The next thing we can try is to increase the dose of the PDE5 inhibitor. If we increase the dosage, although not directly proportional, we can expect an improvement in erectile function with enhanced dosage. So if the PDE5 inhibitor-related adverse event risks are not high, rather than starting from the low level, starting from the highest level approved dose and doing down titrating can actually be an option. Next, when we use PDE5 inhibitor, we sometimes use on-demand regimen. However, some patients do not respond to on-demand regimen. In this case, daily use of low dosage can be helpful for some of these patients. So if patients do not respond to on-demand regimen, they can shift to daily use of the PDE5 inhibitor and vice versa. This can be one way around. I believe that you are very familiar with this table and I don't think you need any further explanation. But even when they are categorized as PDE5 inhibitor, their dosage, their use, and their characteristics are all different. So even when the patient does not respond to one specific type of PDE5 inhibitor, we can move and try another PDE5 inhibitor. We can also consider the combined regimen, trying daily use of long-acting medicine and on-demand use of high-dosage medicine at the same time. This can boost the impact of the PDE5 inhibitor usage, but then, in this case, we have to fully consider the possibility of adverse event and side effect, and it is better to start with a low dosage. After considering all these different types of drugs, still we can consider relatively less invasive methods before moving on to fully invasive options. One example is for vacuum device. It is a classic device known to a lot of us, but still, if PDE5 inhibitors are not working to non-responders, vacuum device usage along with the PDE5 can boost up the impact. And also, low-intensity SWT is getting a highlight these days as well. This is considered as a viable option along with the vacuum device, and sometimes it is even included in the guideline flow chart, so we can see that the LISWT usage is growing these days. And there are some the psychoactive and antidepressant agents like trazodone, and it is believed that trazodone can inhibit serotonin reuptake in the central nervous system and the activity of alpha-adrenaline receptor in penis. With that, trazodone can help improve erectile function. So, improvements in the ED, especially if the ED is from psychological reasons, can be helpful when we use antidepressants like trazodone. Interestingly, the cure to ED might not only be drugs. Utilizing cognitive interventions and the psychological interventions can be of a big help according to diverse meta-analysis. Rather than just sending them officially or referring them officially to the psychiatrist, just like pat on the back or the mindfulness therapy can be of a great help. So I would like to say the key to curing ED is partly the empathy with the patients, and also, although difficult to implement in reality, but if possible, providing counseling and education to partners can also be helpful. Plus, there are diverse diseases and drugs that can dampen the erectile function, and if there are any, we have to work to minimize these negative factors. And urologists consider male hormones or testosterone as an indispensable element when it comes to ED. And in theory, male hormone and PDE5 inhibitors are complementary based on the animal studies. But if you look at the meta-analysis results, I believe that testosterone does have an impact to the ED, but not that much. Actually, the impact is not greater than is commonly expected, but despite everything, based on diverse research and guidelines, it is clear that testosterone replacement therapy is an option to try when PDE5 inhibitors are ineffective or insufficient. However, it should be noted that it is applicable if the patient is under andropause, and it is not recommended if that's not the case. And recently, several studies have shown that combination of antioxidants like carotene and arginine with PDE5 inhibitor has a synergistic effect on erectile dysfunction. And these are drugs that can be easily accessed by everyone. So I believe that utilizing this along with the PDE5 inhibitors can be of help. And last but not least, what's often overlooked is lifestyle changes. So we have to make sure that the patients stay on the healthy habit to fix ED problem at least for about 3 to 6 months. And if we are still failing to improve the ED despite everything, we can think about moving on to second-line or third-line therapy. In summary, if a PD inhibitor is ineffective or insufficient, the first thing we have to think about is whether the PDE5 inhibitor is being used properly and whether there is a way to increase its effectiveness. And when considering all the psychological aspects and the lifestyle habits and the antidepressant comorbidities, we can then move on to second-line or third-line therapy. Thank you, Professor Lee. We do not have Q&A or discussion session in the plenary session. Just please note that. And with that, we would like to move on to the next presentation. The next presenter is Professor Park Hyun-jun from Busan University, and the title is "Which TRT option is most appropriate for my patient with low testosterone?"
박현준입니다.
Thank you. As said, I'm going to talk about which treatment is optimal for the patient with low testosterone. We have a testosterone deficiency syndrome. How is it defined? What is the diagnosis criteria? We have to know in order to provide good treatment. As you see here, testosterone syndrome can be diagnosed as a condition with the low testosterone, and the patient should have relevant symptoms in order to be diagnosed with the syndrome. Instead, we have the patient suffering from the symptoms but normal testosterone. In such cases, no treatment should be given. And testosterone level declines with age. Why? Because the Leydig gas cell function declines. And second reason is the LH stimulation reduces. And along with age, testosterone receptor function declines. And then sex hormone binding level increases. That's one of the reasons why the testosterone declines. So the increase in SHBG leads to the decline in the testosterone, and all leads to the syndrome in the end. And treatment will be given when the following requirements are met. These are the guidelines updated by different organizations, and you are seeing the different organizations who come up with the different criteria. They present or offer a certain cutoff point or criteria based on which we can prescribe medications. So the figure or the level of testosterone may vary from an organization to another, but it's around 230 to 330 or 50. Then where it began, the testosterone therapy, where did it begin? In 1998, Brown reported an increase in physical and mental energy after injecting a liquid extracted from the testicles of pigs and dogs. It was found to be exaggerated, but it was a starting point of the therapy. What about in the world? What are the treatments available? This is the most recently released one, nasal gel and nasal gel. And we had a different agent, and low-acting injection was made available in 2004. And 1% testosterone gel was released in 2002 and 2008. And testo patch was introduced in 1998. And before that, in 2003, actually, androgel was renovated or upgraded and presented as a oral medication. The oldest approach is a subcutaneous implant. One of the strengths is that it has a long-term effect. However, it's not used anymore in Korea because the surgical is required to remove it. Injection is most widely used one. There are two types. One of them is a short-acting injection. You need to take it every 2 to 3 weeks, and the active ingredient is testosterone enanthate. It's very cheap and affordable. However, you need to get the injection very often. And one of the downsides is that testosterone level rises too rapidly and decline. And we have a long-acting agent, which is released into the market in the brand name of Nebido. You get the injection every 12 weeks, which is good, but the price is rather high. This is an injection of the enanthate that I talked about. As you see here, the blood concentration level increases quite dramatically after injection, followed by a subsequent drop. And it is called a roller coaster effect, and has the disadvantage of not staying at the physiologically effective concentrate. And we have these kind of side effects when the peak is maintained for a certain period of time. And this is the other drug that I told you before. And as you see here, the physiological concentration has been maintained best out of all the different medications. We had a capsule medication, 40 milligram one, which is no longer available today. From 2022, it was stopped. Maybe because the pharmaceutical company, couldn't make a profit out of this medication anymore. And in 2019, FDA approved this drug, Jatenjo oral medication. Maybe it has replaced the previous drug that I shown you. Korea has not imported this medication yet. It has a 238 milligram. It was taken twice daily, once in the morning and in the evening. The previous drug should be taken 4 tablets, whereas this one requires only 2 tablets, which is much simpler and easier to take. We have transdermal formulations too. It can administered on the skin, but it can lead to the skin rash or irritation. Once it rubs with the skin of the woman, the testosterone can spread to the partner. In Korea, in winter, we have underwear. Especially the senior citizens wear the underwear, and this kind of transdermal medication may cause some inconvenience in winter. We have 2%, and then we have another version which is applied on the nasal mucosa is available. This is 2% gel version. And depending on the concentration in the blood, you can adjust the dose. This is not testo. It was released into the Korean market recently in 2016. When we have a look at the phase 4 clinical trial, it has an impact on the LH. And as you see here, LH and FSH, it declines, but remains in the normal range. Spermatogenesis can be interrupted. Sperm quality decline is much lower than that of other treatment. So, if we have to choose one of the medications, the best one should be in the closest to the physiological state. And it's better to start with the short-acting before you move on to the long-acting one. When you make a decision, you have to think of the PK properties and after adverse effects and target serum level. And also consider the symptoms of the patient and before you make a treatment strategy. When should we start treatment? Short-acting is better. And what is the target? Dose 450 or 600 testosterone level is the target suggested by societies and associations. If the young man is not married yet, who want a baby, clinicians may use aromatase inhibitor, human chronic gonadotropin, and others, or combination thereof in men with testosterone deficiency desiring to maintain fertility. And if you have to use in such population, Nazagal is recommended. And in the elderly patients, you have to consider comorbidity. And short-acting should be avoided in the elderly patients. What about those patients with ED? Erectile dysfunction, resistant to the PDE or doesn't respond to PDE inhibitor, then use the short-acting agent first. Once they gain confidence, you may switch to long-acting injectables. What about the lifelong treatment? Glaflila, Kalman, and in patients with the diseases, it's recommended to use long-acting agents such as Nebido. This is a 10-year study data which was released not long ago. Out of 640 patients, 76% continued treatment for 1 year after starting, and they had a good benefits once they are maintained on a long-term basis. What are the conclusions? The guidelines are being updated on a regular basis, and treatment should start with a short acting, and if the treatment is stable, switch it to the long term. And it is important to select the patient who needs treatment and choose the appropriate treatment for each patient and provide counseling and good information on the treatment before you administer any treatment to the patient. Thank you. This concludes my presentation. Thank you, Dr. Ba. Let's move on to the next presentation.
The next speaker is Professor Hossein Sadeghi Nihad from the USA. Let me briefly introduce our speaker. He graduated from McGill University in Canada and is for resident training, UCSF and Boston Tufts University and Boston Medical University Medical Center were the schools where he finished his residence, and currently he is in NYU Langone Hospital and NYU Grossman School of Medicine. He is an expert in andrology in the United States, and he made a visit to our conference despite his very busy schedule. The title of the presentation is The Difficult Penile Prosthesis Strategies for Safety and Success. Please welcome our speaker with a big hand.
Thank you very much for the introduction. It's an honor to be here. Thanks to KUA, and it's an honor to represent the AUA in your beautiful city, and it's wonderful to see how Seoul gets better and better. I've been here once before, and it's absolutely wonderful to be here. Let me just see this. The slides, I think they start from the very end, actually. Let me just go to the very beginning. That's what they've, okay, there we go. I think they set it up at the beginning. All right. So I have no disclosures, and I'm not going to talk to you about anything new today. I'm hopefully going to share my experiences over the last 25 years about things that can make a difficult implant surgery a bit easier. I'm sure many in the audience are fantastic surgeons with vast experience. They'll probably do an implant better than I do, but there are things that you learn with time that hopefully will be helpful. I also wanted to take the time to recognize a few important milestones. Of course, 25 years ago, we had the first government-approved safe and effective oral therapy for erectile dysfunction. It was a very special time. This paper from Irwin Goldstein, my mentor, came out. This was a time where I was actually a resident at BU, and then my fellowship year, actually your own Kwang Sung Park, who's a very dear friend, was with us then, and again, that led to this very important paper. It was also a time where these beautiful cartoons that I'm sure the implant companies would have loved to come up with this design themselves, but it was, of course, part of the Viagra advertisement at the time. Other important milestones. It is actually 50 years ago when Scott came up with the penile prosthesis. So it's really not that long that these penile implants have been around. Soon after his paper and invention, of course, we know that Small Carry-On came up with the first silicone implant, the malleable device that was shortly after this. But it was also a time in the 70s where my mentor, Robert Crane, started at BU, the Male Reproductive Center in Boston, where a lot of important neurourology work was done. And then lastly, I wanted to say that no matter how hard I try, I will not be able to do as good a job as another milestone. This was 40 years ago at the AUA in Las Vegas when Giles Brindley, of course, went behind the scene and he injected himself and he came and he showed that intracavernosal injections work. So this talk will not be as interesting, but hopefully we can cover a few interesting things. So I'm going to start with something that may not seem like a difficult implant, but how many in the audience, just a quick show of hands, how many of you do penile implants? So a few in the audience do penile implants. So if you start doing penile implant surgery, one of the things that you realize is that if you ever have to take it out, taking out a reservoir can be a big challenge. My good friend Dr. Ron Wang had worked on laparoscopic removal of reservoirs, but a reservoir removal can actually be very challenging. We of course remove reservoirs in malfunction cases, and sometimes when there are urgent problems, for example, an implant that's been placed in and the patient has lower extremity swelling because of pressure of the reservoir on the iliac vessels. And of course, you may be seeing cases where you have an infected implant. So if you don't take away anything else from this talk, the one talk is if you do implants, if you do any kind of a revision implant for an infection, never ever leave anything behind, right? So this is a case where every component must absolutely come out. Now, when you do penile implant surgery, it's important to remember a few important principles. Yesterday, as part of the KUA President's Dinner, we were taught how to do the Korean love sign, which is about 3 centimeters, right? So this is actually the distance you are when you put these reservoirs in the retropubic space where you are from the iliac vessel. So you really are not very far, and the bladder, especially in the compressed mode, can also be very close. So it's very important to decompress the bladder before you put the reservoir in. Now, why is removing the reservoir a challenge, and why have I even included it in this talk on difficult implants? Well, you're working in a very narrow space and you have poor visibility. You have scar tissue around the tubing. You're operating remotely, right, because that space is far away from you. And there's often a lot of scarring around the reservoir neck and the lockout valve. So this is something that I've used in a previous presentation on the implant. If you are removing a reservoir, if you're operating to remove a reservoir, a few things will help you. I think a headlamp will help you. If you have operating loops, use them. They will bring everything closer and make things brighter. On the top right, you see a retractor. That's a lighted retractor. Most operating rooms do have lighted retractors, and it took me about 10 years of doing implants before realizing, well, wait a minute, why am I not asking for the lighted retractor? It'll really help you when you're digging up that reservoir from the space of retzius. Of course, nowadays, many implant surgeons are putting the reservoirs in ectopic spaces. They're not necessarily in the space of retzius, but the principles are the same. A long tip bovie is also very helpful because you're, again, reaching very deep to get that reservoir out. And then you may wonder, well, what is that water skier doing? The water skier is there just to remind us that these are cases that are best done with an assistant, preferably a resident, and we sometimes jokingly call them the water skiers because they're just retracting, and retraction is very important to be able to get to that deep reservoir. And then the principle is that you use coagulating current on the tubing. We did these experiments when I was training at BU, where if you're using coagulating current, you will not cut that tubing. If you end up cutting that tubing, you make the procedure significantly more complicated because then you have to make separate incisions and go and dig out that reservoir. So when we wrote the paper, I used an illustrator to show again the concept. You see the finger underneath the tubing. You're using the coagulating current, and you have to be patient. You just use coag, keep going until you open up the space. And then the most important part of this operation is that you do not pull too much and you do not use your Kelly clamp to remove that reservoir until you are in what I call the fat part of the tubing. And in this illustration, I'm trying to show you, and this Kelly is now grabbing the fat part, and this is a better representation. You can just see the subtle difference in the thickness of the tubing. So that Kelly is right now on the fat part. Once you get to that fat part, you can sort of aggressively pull it out. Of course, you've emptied the reservoir, and you could pull more forcefully. If your Kelly is on the thin part, that tubing will give, and then you have to make a separate incision. And the other thing that the residents have popularized is, they call it the SIFT or the Sadegi index flexion technique, where if you're really struggling and things aren't happening, you could put your finger underneath the tubing, as we illustrate here, and sort of push up. Of course, this illustration is not perfect because in reality, if your finger is on that lockout valve part, by then things are already easy. It's basically you want to be pushing up on the tubing, and then you could just make a very small incision on your finger right in the peripubic area and go right down through that second incision, grab the tubing and pull it up. So that was the first pearl. The second one is that if you are having an implant practice, and again, I know that there are not many of you here that currently are doing implant surgery, but if you have an implant practice, always beware of the referred patient. because you don't really know what was done, the original surgery. And if you are in doubt, obtain imaging. We don't routinely obtain imaging for any penile implant case, but here I illustrate a case that was referred to me. We actually wrote this up with some of my residents. This patient was referred to me, and you could see when I examined him, there was something feeling a little bit abnormal in the base of the penis, and I said, well, let's get a CAT scan, and this is what we got, right? So the person who took out the original implant, which was an infected implant, in the rush to take everything out, they left the rear tip extenders, and there were 2 rear tip extenders with purulent fluid between the extenders, and again, this would have been a disaster. So get the imaging if in doubt, and take it out. The third point is the Peyronie's patient. And again, this is a little bit controversial. So for Peyronie's patients who have erectile dysfunction, the AUA guideline recommendation and the general recommendation is a penile prosthesis surgery with adjunctive procedure to straighten out the implant, right? So the idea about using the implant actually came from Scott. At the same time that he devised the inflatable implant, he had the idea that you could use the implant to straighten out the penis. The problem is that the original implant did not really have adequate rigidity to do this. Nowadays, the implants, the Bioflex Coloplast, as well as the CX AMS devices have adequate rigidity for you to be able to do modeling. Some of my own colleagues, including my friend Toby Kohler at the Mayo Clinic, they are not fans of the modeling procedure. And in his own words, he has seen cylinders torpedo out of the penis. And I think the reason is that it's a very, very technique-specific procedure. And when you do this procedure, it's very important that your bending hand be on the shaft and not on the glands. Otherwise, you will be putting too much pressure on this, on the tip of the penis, and the cylinders can pop through. The other hand is at the base with pressure over the corpora. You do this for 90 seconds, sort of pressure with all the tubing clamped. You do the counter pressure for 90 seconds, you let go, and then you repeat. And if you end up with a curvature of 30 degrees or less, you could leave it. The device itself with time will straighten it out. If you ever have to incise the dorsal or lateral prax, which I pretty much never have to do, I strongly recommend that you elevate the neurovascular bundle of the buccal fascia prior to incising this. Now, the next lesson is about, and this is really the last one, is to remember that not all deformities are created equal. And this one is actually, in some ways, the most challenging part. This is really the challenge for the implant surgeon. So these 2 cases that I'm going to show you right now are not the same. In other words, the Peyronie's disease and the post-priapism fibrosis, which can present with this picture, are entirely different, right? A Peyronie's implant, a virgin implant, is actually relatively easy to do if you have an hourglass, because the implant will do the job of pushing that scarring out and straightening things out. On the other hand, a post-priapism fibrosis is a very, very difficult operation. Fibrosis after priapism is typically worse distally. Fibrosis is worse proximally, typically after infection and implant removal. And over time, a number of different procedures have been proposed for dealing with these patients, but as I said, this is one of the most difficult challenges in prosthetic urology, and those who do few implants have very low chance of success. Now, multiple surgical techniques have been described for dealing with this: multiple incisions, multiple scar excisions, extensive corporotomy with variety of graft coverage, which again, they have problems, right? Because any additional material that you use in an implant case, you risk infection and additional problems. You can also excavate the scar, and even endoscopic resection of the scar has been described, but I'm really not a fan of any of these. One of my mentors early on in my career was Steve Wilson, who is really one of the pioneers and fathers of modern prosthetic surgery. And Steve Wilson actually came up with a tunnel technique, which was described in 1995. And after excision and grafting, you can see some disaster cases. And this is actually one of Steve's slides, which shows some of the problem cases that you could see after these grafting and excision procedures. And to me, some of them, like the one you see on the top right, these are never events, right? you should never, ever see glands necrosis in a penile implant case. Sadly, they are seen, but these are never events. And these are problems that are typically not seen with it. So if you're going to use the tunnel technique, it's very important that you follow certain guidelines. Intraoperative problems with the tunnel technique can include proximal perforation, which is common. One of the pointers that I use when talking about this is to say that if you do have this proximal perforation, is often because you were using some of the narrower cavernotomes going proximally. So I would go not all the way down to the bone with the narrowest cavernotome, and only when you get to the larger cavernotomes, I would go all the way down to the bone. And then if you do have the problem, of course, you could use a rear tip extender suture sling to fix the device in place. Another very quick point here is that you need to have the buildup of the base with rear tip extenders, because they're actually narrower and they will allow the implant to fit in that tight space. So this is a case where you should have a very low threshold for using rear tip extenders. And the exit tubing comes out from the corporotomy because, as I said, it's often very difficult to dilate beyond size 10 or 11, especially in infection cases. I personally like the transverse incision. Again, this is something I learned from Steve Wilson, and I think that image is actually from him, just because you can get all the way down when you need to. You can have excellent exposure, and then you use the cavernotomes. You can use it in an oscillating motion with stay sutures, and you can enlarge the tract backwards using cutting scissors, a large cramp, or an Otis urethrotome. If you are still struggling, it's okay to make a second incision. And lastly, it's very important to be comfortable using the cavernotomes. These are, as you know, dilators that have sharp edges that can excise the scar tissue. The one on the right is the Rosello cavernotome. The one on the left is the Morville or Uramix. The term cavernotome was actually coined by Rosello, and this is a very, very important part of this operation. And again, this is not for occasional implanters. So the take-home message is: know your landmarks, know your equipment and the cavernotome, follow a routine, be prepared to improvise, make an enlarged incision to have better exposure if needed, and your hard work will eventually pay off. Again, it's an honor to be here, and I hope to see you in New York in the near future. Thank you very much.
Thank you, Dr. Sadeghi Nehad. It's not often that we have an expert andrology surgeon from the U.S. come to Korea to speak. Thank you so much for a great talk. 네, 다음 강의로 넘어가겠습니다.
Thank you. We would like to move on to the next presentation. The next presentation is also an international speaker. And we have Jens Schenksen. I believe some of you already know him. He is a high-ranking official in EAU. I would say he's a number 3 figure, actually. So after president and vice presidents, the treasurer is the third important figure in the organization, and representing EAU, he has paid a visit to KUA2023, which is a great honor for us. He is currently serving as a professor at Copenhagen University, and he's serving as a doctor in Herlev and Gentofte Hospital in Denmark. The title of the presentation is The Use of Spermatogoneal Stem Cells to Restore Male Fertility After Childhood Gonodoxic Therapy. We would like to...
Thank you.
For your kind introduction. It's an honor for me to be here today on behalf of EAU, and I would like to thank the organization here, KUA, for the nice collaboration we have had during many, many years. And this is the latest pictures from our meeting in Milan. And I would also like to thank you for all your hospitalities here in Korea. I have been here before. This is amazing. Thank you so much. This is the EAU executive, and I'm bringing this picture just to bring the warm regards from, in the middle, our Secretary General Arnold Stenzel from Germany, and on the left, Professor James Endow from Scotland. So let us get started. I have no disclosure today, and I am very honored to present our results from Herlev University Hospital and University of Copenhagen. And please notice, this is about my research group. I'm just the presenter, and I'm the proud father, but not doing all this. My young guys are really in front of this, and I'm so happy to share our knowledge in this field with you. So what I'm going to talk about is the spermatogonial stem cells, and as you may recall from early days that we learned that the stem cells develop in the postnatal testis, and the meiosis begins in puberty, and that's very important because there are no haploid sperm cells in young boys, and that's where we are going to look at this today. They do not produce haploid cells, which are useful later on for fertility. So they are important for fertility preservation, and this is what I'm going to talk about. I have some figures just to let you know. If you look here from US, there are more than 17,000 cases of cancer in patients below the age of 20 years. So today, more than 80% of individuals diagnosed with childhood cancer will survive. If we look into cancer therapy, when we are meeting a young boy, 7 years old, facing Hodgkin's disease or whatever, then we know that the chemotherapy and the radiation therapy will have a very, very negative impact on the spermatogenesis. It will, first of all, hit the Leydig cells, but also the spermatogonial stem cells. And again, in the circle, the Leydig cell will not promote testosterone for the Sertoli cells, which might be one of the most important things for development of spermatogenesis. So let's have the definition first. Fertility preservation is about saving the oocytes, the spermatozoa, and reproductive tissue for the future use of parenthood. Today, clinically implemented in females, they are able to cryopreservate the oocytes. And in males, we are only able to cryopreservate the ejaculated semen successfully. And that is very important. And therefore, what is possible then for the small guys? An inspiration for us has been working together with the lab in Copenhagen, which are the world leaders in advancing fertility preservation in girls. And I will just show you some slides about this because this is really inspirational. Fertility preservation is about cryopreservation of the ovarian tissue. So we are working with the goal of cryopreservation of testicular tissue for later use for those small guys. I'm showing those pictures here because this is very important to understand that in females, the ovary, they are born with primordial follicles, so they are ready for fertility later on. That's not the same in boys who only have the stem cells. So we can take out the primordial follicles and save them and freeze them, and we can thaw them and put them back into the place where the ovary was before. And we have had pregnancies, also natural pregnancies, because they are restarting the process. If this is not possible, we can also make heterotopic or autotransplantation, and then by ultrasound take out the eggs. And again, we have a proof here also for restoring the ovarian function with the estrogen production and the lower level of FSH, so it's working. We are far away from that in the boys. So that is the question, and that is what my group is working very hard on together with a lot of lab people around Copenhagen. So the idea is, of course, when we are called, it's an emergency, we only have 1 day, and then we should talk to the parents and then give them the chance of freezing the testicular tissue by taking a biopsy. But we cannot guarantee anything right now. So fertility restoration strategy is right now that we can maybe grow them in the lab, or we can use them later on for autotransplantation. But you have to realize that this is experimental. So in our lab, we were able to show that the prepubertal spermatogonia or stem cells from a frozen to a thawed was intact after a culture period of 2 weeks. That's the first step. They are surviving. However, many of the studies are from animals. And in 2018, there came a study for the first time in humans where they were able to grow spermatogonial stem cells and see on the right side that there was nothing when they started, but by using in situ hybridization, they were able to show haploid cells with a lot of numbers within 2 weeks. And that's another step we can think about for the future if we can grow them. Then there has been a lot of animal studies. This study is just showing that they were able to transplant into infertile recipients in the rhesus macaque monkey, and the spermatogenesis was restored from these spermatogonial stem cells, both in adult and prepubertal donors. And you can see the blue colored, that was the tissue, and it spread out to the tubules. It was injected into the reeded testis. So in 2019, Kyle Orwick from Pennsylvania came with, I will call it a revolution. This was baby Grady, I will come back to that. But they showed that they were able to take testicular tissue and take it from the first freezing and then thaw it and then put it back into pubertal rhesus macaque monkeys in 5 monkeys. They put the tissue under the skin on the back and under the skin on the scrotum. And most importantly, after an observation period of 8 to 12 months, they saw graft was growing, production of testosterone, complete spermatogenesis in all grafts. That was really a break into what we can do. So therefore, this little boy was coming out and it was a world sensation. We took the next step, and I am very proud to tell you that I this morning got the message that we are going to have this published in Human Reproduction, the first trial in humans. And my resident, Christian Fuglsang, will guide you for the next couple of minutes through the procedure we did.
This is Christian Jensen with the presentation of an autologous grafting of testis tissue in a man with non-obstructive azoospermia. And the idea behind the surgery came from the fact that we for some years have frozen down testis tissue in boys who are about to undergo gonadotoxic therapy. The idea is that we can use this tissue to restore fertility later, but we don't know how. In a monkey, it was shown that the testis tissue can be sutured underneath the cutis to generate spermatozoa that was used to produce the offspring, baby Grady. However, the boars that we have frozen down testis tissue from are still boars, but instead we have the option to use men with azoospermia. Azoospermia is defined as the absence of spermatozoa in the ejaculate and is divided into obstructive and non-obstructive azoospermia. In the latter, surgery is used to retrieve sperm cells that can be used for assisted reproduction. In a randomized clinical trial, we investigated what method was the best to retrieve sperm cells from men with non-obstructive azoospermia. And during the trial, we froze down testis tissue from these men and created a large biobank. One of these men had 3 pieces frozen down in 2019, and the pieces can be seen here. This man was selected for autotransplantation both to help him restore spermatogenesis and to provide a proof of concept for autotransplantation of testis tissue for fertility, preservation and restoration. The study was performed according to the study published in Science in 2019 on baby Grady, where we created a skin flap. Then the testis tissue was sutured to the underside of the scrotal skin as seen here, and by passing the needle through the tissue, we created a small trauma that should stimulate angiogenesis. 3 pieces were inserted, 2 on the left side, 1 on the right side, and the idea is then that the man is followed with ultrasound examination, blood testing, and physical examination for 6 months, and then after 6 months, the same tissue is extracted to look for sperm cells. Our hope is that after 6 months, the tissue will have grown to produce sperm cells that can be used for assisted reproduction to help this man become a biological father. Here you see the end result with the tissue sutured and the skin flap closed. And this is the surgical team that performed the operation. And with that, I want to say thank you for listening to this presentation.
So now we are coming to the result. Maybe I can move. Can you help me moving? Yep. And here we have the ultrasound we did during the way, 2 months and 6 months after. And we were very happy to see that there was some blood flow. So in the end of the day, we were taking the whole piece out en bloc. It was a huge piece to go through the histology. And here's the result. From the undilated inactive areas where there were no spermatogenesis, there was nothing surviving here. But the active pieces showed a very normal cell structure, even though that we are not able to see the haploid cells, but that is maybe because we have a non-obstructive azoospermia. But the conclusion from this one is going to be published in Human Reproduction. That was, we saw for the first time, graft survival, which will give us a lot of hope for the future. We have then been doing some few studies extra because we are focusing very much on the Sertoli cells. And in men with non-obstructive azoospermia, we were successful comparing them, the tissue, to normal fertile controls. And what we saw there was that there was an increased anti-Mullerian hormone level in those cells or around the cells. And that is indicating that the Sertoli cells are immature, which give us hope for those men to work on what is the problem. Is that a part of the problem since the spermatogenesis is not working? So we were so lucky 2 weeks ago to show a successful culture of Sertoli cells in the lab. So the next step, and that is coming up, it's going very fast right now, we are going to have a comparison where we are adding the major Sertoli cells to the tissue of non-obstructive azoospermia. And if we can find a way here, we might also be able to find a way for the young boys. But we cannot do those studies because we cannot have the approval from the ethical committee because they are so young. So, in the end of the day, our take-home messages at this stage is fertility preservation is an essential part of cancer survivorship care. And we have to think about that when we are talking also pediatric urology. So in prepubertal boys, we are now knowing that we can cryopreservate the stem cells, and that's good when we are talking to the parents and the boy themselves, and we have a good survival. In vitro generation, which is one of the future parts, is also possible. We saw that from the first human study ever 2-3 years ago. And graft survival now after autotransplantation is also possible. So we will continue, and next step, and we just got the approval for that, is to have a proof of principle by taking normal tissue from healthy men and see if we can grow the spermatogenesis under the skin. Also, autotransplantation of frozen thawed prepubertal human tissue is the way forward. And then in vitro maturation experiments, which are leading also to the help of the men with non-obstructive azoospermia, we are looking very much forward to that. But in my view right now, the most important is the counseling of the patient and the parents. If there's a risk of gonadal damage and fertility loss, patients should be referred to reproduction specialists before initiating treatment. And as I'm saying, there's no andrology without humor, so please, when you feel small, useless, harassed, and depressed, remember that once you were the fastest and most successful sperm cell in your group. Thank you very much. Hope to see you in Paris.
Thank you so much for a really
첨단 강의라고 하는데 정말 걸맞는 강의였다고 생각을 합니다. 저희 인사 안부도 전해주시고요. 이렇게 와서 강의해 주셔서 감사합니다. 그리고 논문도 수락이 되셨다니 또 축하드립니다.
프로스테이트 캔서 세션이 되겠습니다. 첫 번째.
Thank you. And we're going to move on to the prostate cancer lecture. And the first speaker here in this session is Mr. Peter Ka-Chiu. And to briefly introduce you to him, he graduated from the Chinese University of Hong Kong, where he won his MD. And currently, he's serving as associate professor at the Chinese University of Hong Kong. And Hong Kong Urological Association's president is Peter Ka-Chiu as well. So over to you, Peter.
I'm Peter Chiu from Hong Kong and representing Hong Kong Urological Association. And I'm very, very honored to be invited to the KUA meeting. And thank you, Professor Hong, and also on stage, another Professor Hong and Professor Kang. We'll switch the channel a bit. I felt the previous presentation was so exciting, and mine was much less exciting. But I hope, maybe men in this room would be slightly more interested in this topic because that might be a little bit more relevant. Current status of focal therapy for prostate cancer. Now, I have no conflict of interest, but in my practice, I do high-field cryo and some microwave ablation for localized prostate cancer. Focal therapy for prostate cancer to this date is still not the first-line recommended treatment. But however, it is emerging as a bridge between active surveillance and radical treatment, particularly for those that you don't want to put on active surveillance, or if they progress slightly from the stage where you want to do active surveillance. Do you want to do radical treatment, or you yourself or your family wants to receive radical treatment at that very point? Then that's a question. And focal treatment actually has changed or progressed from initially all whole gland treatment, whole gland high-field, whole gland cryotherapy, to recent years like partial gland ablation. So it can be zone ablation, hemiablation, or nowadays of a quadrant ablation. And when we do focal therapy, we must accept that we are treating the important lesion, the significant cancer, the index lesion. However, we need to accept that there must be some low-grade or low-volume diseases. Those Gleason 3+3, we call it ISUP grade group 1 disease, somewhere in the prostate, which is highly likely. If you do a saturation biopsy, you get those. But we are not chasing those low-grade cancers, and we're not treating them in fact. So the indication to date from a consensus statement in recent years would be actually intermediate risk disease, the 3+4, Gleason 3+4 being the sweet spot. We can treat up to 4+3. In expert hands, 4+4 is still possible for low volume 4+4, but this is not strongly recommended in most consensus. And definitely not for those low volume Gleason 3+3 as a substitute for active surveillance. Focal therapy is not a substitute for active surveillance. So we usually treat tumors that are visible on the MRI too. And the guidelines, first, of course, the AU guidelines, most Asians read that, of course, and the AUA guideline too. And in the AU guideline, the whole gland ablative therapy or focal ablative therapy should be done within clinical trials or registries. So this is not that you can do randomly in a patient. So we should be done. It can be done, but we need to audit them. We need to put them into a registry so that we can look at their outcomes. But when we look at the side effect profile, quality of life, and the feasibility of retreatment of focal therapy, for most men that I talk to, in fact, this is a very attractive treatment. So what do we have? We have high-field cryotherapy being the two most commonly done and used energy. But there are a lot of energies out there. I think the irreversible electroporation, IRE, is kind of emerging as one of the new and effective modality. I myself do the microwave ablation, but that is very much in a trial setting. So first, I'll just have a very quick go through with the common energies, like the high-field, high-intensity focused ultrasound. It causes coagulative necrosis by temperature up to like 90 degrees at the focal point of treatment, causing micro bubbles from the tissue, and with this collapsing process, disruption of cell membrane and cavitation, and causing cell death. So we actually have two different, most commonly used machines. These two are transrectal probes from the Sonicare company, which is a Sonoblade. The other would be the focal one from the French company, the EDAP. So for high-field, basically, we're a transrectal probe putting the rectum. So it is more like almost non-invasive. So we're treating like zone by zone from anterior to posterior. As you can see, this is not a whole gland treatment, not even a hemi-gland. This is kind of a quadrant treatment. So this is the typical tumor that we treat and the typical pattern that we do. So how about the cancer outcome? There is a very nice series as a collaborative effort from Professor Caroline Moore, Hashid Ahmed, and Mark Hamilton with a medium-term results. When we discuss focal therapy, we always say that, oh, there are only short-term outcomes. Nowadays, we actually have some medium-term outcomes, like for this paper, published actually a few years ago. It's 8-year data with a high field, with a large database. And looking at this, you can see the retreatment-free survival is only 50-something%. Then you would argue that what are we doing? This is cancer treatment. But when you look at the patients that can avoid a radical treatment, only about 90% of them need a radical treatment at 5 years, and actually 80% of them do not need radical treatment at 8 years' time. So what do the other recurrent patients do? They do a repeated focal treatment, so repeated ablation, and the patient can be put into observation again after the repeated focal therapy. And the higher the grade, like 4+3, the need of a retreatment will be higher than the 3+4 and the 3+3 as expected. And the good thing is, when we do focal ablation, the outcome is actually non-inferior to the hemiablation. So nowadays, when we have more accurate biopsy and targeting, we could afford to ablate less, and ablating less actually associate with lower morbidities and complications. So looking at the sexual function, there might be some effect on the sexual function deterioration in the first 3 months, but afterwards it usually goes back to the baseline. So this is never seen in radical prostatectomy, whether or not you do, how good you do a prostatectomy, or at least in my hands, I cannot have these sexual functions. The other would be the cryotherapy, using the freeze-thaw cycles, with the kill zone between -20 to -40 degrees. Usually given, require an argon gas, so we need to take care of not the needles, the machine, and also the argon gas that is required to provide this cold energy to eventually lead to coagulative necrosis and both extracellular and intracellular damage, causing cell death. We usually use a full grid, so it's transperineal insertion of the cryo needles, usually 3 to 4 needles per side or per case. And we also need a urethral warming catheter. So cryo, it is a little bit more equipment to do with. And when we look at that, the biochemical disease-free survival in some other series, ranging from 3 to 5 years of follow-up, is between 70 to 90%. So when we look at it, it's actually not too bad. And the side effect profile, not looking at the whole gland treatment, but looking at the partial gland treatment, most of the series report minimal incontinence, erectile dysfunction in some patients, but most of them can resume their erectile function with or without PDE5 inhibitors. And when we fear the rectal fistula risk in the past, like 1% up to 5% in the past, the evidence of those actually came from post-radiotherapy series, and also that in recent studies in the past 10 years, most studies, even after cryo, they report actually 0% rectal fistula in primary treatment. So I've talked about the IRE, irreversible electroporation, being one of the emerging treatment options at focal therapy, which uses a minimally thermal, with a high voltage, low energy electric pulses between the inserted needles, causing, as its names suggest, electroporation, causing pores, causing nanopores, and then cell death. So this is the typical setting of the IRE. I must confess that I've never used IRE before, but looking at the reported results and what my colleagues from other hospitals do, and it's actually impressive results without damage to the urethra, and it's actually having some advantage over cryotherapy, I think. So this is a 5-year median follow-up of these focal IRE cases, showing a failure-free survival of 84% at 5 years and 69% at 8 years. And many of them actually could be retreated with focal therapy. And erection, sufficient for intercourse, will be there's a slight drop in the erectile function, but actually most of them can retain. This is my friend from Shanghai, in which they are using not a nano-knife IRE, but another machine called a high-frequency IRE, which is produced in China. So this is photocourtesies from my friend, Professor Wang from Shanghai. And from his series published in JAMA Surgery last year, actually the 6-month significant cancer rate on repeat biopsy was only 6% in the first 100 patients that they do. So whether it is cost effective. Now, in fact, Professor Hashim Ahmed actually did a cost effective analysis and showed that focal therapy was associated actually with lower overall cost and higher quality adjusted life year quality gains compared with prostatectomy or radiotherapy. So despite the focal therapy, cost and so, but when we compare with radiotherapy and prostatectomy and the quality of life, in the UK, very frequently they talk about what is the cost per quality gain, and in that, in fact, focal therapy is actually pretty cost effective. So what are the recent advancements in focal therapy in recent years? Now, the evidence is talking about like the cases that has been done like more than 5, 8, or 10 years ago. So what are we doing? How do we do that differently in recent years? Firstly, when we do biopsy, in the past we do cognitive guided biopsy, even there is a positive MRI. We now do MRI ultrasound fusion biopsy, not to mention some centers doing MRI in bone biopsies. So we have moved to more accurate diagnosis, accurate mapping of the prostate before we really consider offering focal therapy. It's not like the 12-core trust biopsy that we do in the past. And I typically take more than 20, 25 cores when I consider a patient for focal therapy. So this is a 5 millimeter pyrethroid lesion. One of my patients, Gleason 4 pattern in that 5 millimeter lesion, and we actually could accurately map that, and all other cores in this tiny 20-gram prostates were negative. And nowadays, we actually in the past, when we do cryo or HIFU, it is actually cognitive guided. And nowadays, most of the machines, including the solid plate and EDAP, actually can incorporate the MRI ultrasound fusion. So we are actually looking at the lesion and planning, and we know the treatment zone before we even press the button. And that goes the same for HIFU, that we can actually see on the screen here. The pink color is the MRI lesion. The light blue color is the margin that we set for this particular tumor, and then this is during, in the middle of a treatment, having a glorious treatment effect that we've seen on the ultrasound. So also, nowadays, we have different modalities. Instead of embarking on only one energy, if we have the luxury of having more than one energy, we can actually choose the most suitable energy catered for the location of the tumor. For example, like HIFU is more like for mid-posterior tumors, cryo, IRE, a bit for anterior. I've never used brachy before, but there's a group in London which does a lot of focal brachytherapy, and this is quite a good modality for very apical tumors. And nowadays, we also have MRI real-time guided focal therapy. This is a transurethral ultrasound ablation, so not the transrectal HIFU that I've talked about. It's a transurethral setting. So this is called TULSA, which has been published in the past few years, and they already have systematic review, although this is only a 10 small studies of about 224 cases, showing PSA decline of 50 to 90-something percent, continence and potency preservation in most patients. And these prostates actually, after treatment, shrink to about 10 to 15 mils after transurethral treatment. And 85% improvement in LUTS too, and not to mention, most cases actually do not need treatment. But this is a new treatment, and follow-up time is short, so we'll see the longer-term outcome. How about for those focal therapy for more older than 70 years old? We know that the continence outcome after prostatectomy in 70-something years old is worse than those like below 70 years old. And when we do that 1 to 2 focal ablation, the failure-free survival at 5 years for these older men with a median age of 74 is 82% at 5 years. So think about that. You do not need a radical treatment for more than 80% of the cases. So the concept now have changed that we may do repeated 1 to 2 focal therapy treatments, and maybe for the rest of his life, we do not need another radical treatment when the patient advances to around 80 years old or 80-something years old. And there are actually we have pilot system for the MRI prostate diagnosis. We have the precise recommendation for active surveillance MRI. We also have the PIFAB, the prostate imaging after focal ablation. This is a very recently proposed, but this awaits external validation. But the message is we actually have more and more standardized scoring for these post-therapy cases. And this is hopefully to reduce routine rebiopsy after focal therapy and actually make focal therapy a more attractive option for patients. So I must highlight one of the KUA abstracts this year because of the IRE series of more than 178 cases done by Professor Li Jiu, and showing the excellent outcomes at 1 year biochemical-free survival and excellent functional outcomes. We have meta-analysis showing the failure-free survival at 8 years, a propensity score match study done in UK, showing that actually the failure-free survival of prostatectomy and focal therapy are actually the same at 8 years in well-selected cases. RCT, there are actually a number of RCTs going on comparing focal therapies and radical treatment. Like, for example, in this Chronos study, the Chronos A arm randomizing radical therapy, be it prostatectomy, external beam RT, brachytherapy versus either focal therapy with HIFU or cryotherapy, and the primary outcome being progression-free survival with a non-inferiority design. But this is ongoing. We don't have the results yet. Another RCT that we are waiting for the results is RCT from Norway by Professor Bakko with a primary outcome of treatment failure of 3 years. The recruitment has finished, and we're waiting for another 2 years for the results to come out. And this is a study randomizing.
Peter, please.
I'm sorry. So I'll go to the last slide. So focal therapy is actually an alternative for well-selected localized intermediate risk disease. And although a quarter of them need retreatment, most of them can do focal reablation. Only 10 to 15% of them need radical treatment in 5 to 8 years with excellent preservation of functional outcomes. So thank you very much. This is me and my team and my boss in Chinese University of Hong Kong, and we'll be very welcome for you to visit us. Thank you very much.
Thank you. I'm sorry we cannot give you sufficient time for you. Sorry. Thank you. 다음 연자분은 Jacob Pang.
On to the next presentation, which will be made by Dr. Pang, and he will be talking about the treatment of metastatic prostate cancer with androgen receptor axis targeted agent, exploring the prognostic factors. He's so well known that I do not think I need to introduce, but let me introduce him briefly. From Taiwan, he graduated from Chongzhen, and then he's now with the Changgun Memorial Hospital. He's a professor with that hospital. He is also serving as a president of a Taiwan Urological Association.
And I'm happy to come back to Korea again. Thanks to our good friends here for your invitation. It is really truly my honor to be present a small topic about prostate cancer treatment. I think after listening to what Peter has said, the local treatment is one of the challenging part. But when we come to metastatic prostate cancer treatment, I think we're also facing some challenging issue as well. So basically, my topic will be focusing how can we find prognostic factors for prostate cancer, metastatic prostate cancer treatment. So as we know that prostate cancer incidence and mortality has been increasing, I think it's a worldwide issue. Like in Taiwan, we are seeing more and more prostate cancer cases. Compare Taiwan to US, I think the challenging part of our prostate cancer incidence is that we tend to have a late diagnosis of our patients. So I believe that this scenario is quite similar among many Asia countries. So we tend to see more metastatic prostate cancer in Asia country. So throughout the years, we see the development of prostate cancer treatment. And what we heard from Peter, that's for very local primary treatment. But I mean, for another extreme, that when we have advanced or metastatic cases, we will continue one of our long-term effect of treatment is doing the androgen deprivation therapy. And this androgen deprivation therapy has been there for more than 80 years, so we are still count on this treatment modality. So now we are facing a lot of options when regarding prostate cancer treatment. Although we have many weapons now on our hands, but many times in clinical practice, when there is more choices, we will have our challenge to pinpoint which one is the best treatment that we can provide to our patient. So, and when look at the guideline, I think the metastatic prostate cancer treatment are becoming more complicated. I think this EAU guideline summary gives us a picture of how do we select our patients when we come to medical treatment. Basically, now we look at our patient when they are first diagnosed with metastatic prostate cancer. We tend to find out whether they are in the condition of low volume or high volume. And then the next question we will ask whether they are eligible for upfront use of chemotherapy. If not, then we will continue with this AR80, so-called androgen axis targeted agent that we can use. So now there's several options whether we want to use the triple or we go on for only the monotherapy with the AR80. And when we look at the NCCN guideline, I think they are stating the same criteria that which we can do to our patient. But yet, there are so many options. Is there any better prognostic factor or better marker that we can guide us to give the treatment, the proper treatment to our patient? Although many of these trials tell us that the selection of the patient is mainly based on the metastatic volume of the cancer. There is two criteria that we are familiar with. Either you look at the patient whether they is a low risk or high risk patient, or is high or low volume patient. But that, when we come to clinical practice, it is still not able to tell us which treatment is the best or which agent is the best for our patient. So in my following review of our literature and also our own data, I'll try to pinpoint some factors maybe we can refer to and try to use this kind of factors to choose which drug is the best for our patients. So, which I tend to review most of the literature, and I try to find the latest one and focus in Asia country. So, interestingly, I find a few literature that's coming from our Japan colleague. So, I think these papers are very interesting. So, basically, they the retrospective study, and then they look at the database and found that actually when we try to prescribe AR80 before even we start the ADT treatment, there's three risk factors that we can consider whether this patient is going to benefit from ADT plus AR80's agents. These three factors is a patient that is age less than 70.4 years old. It means that the older patient probably will not benefit from this treatment, and CRP that's higher than 0.16, and look at the bone metastatic marker, the ALP, there's higher than 548 international units per liter. So these three markers have a good prognostic factors when we come to whether deciding patients should be benefit from the ART. And when we think about this ART treatment in Asia, especially in Asia, we have to think of the economic burden that we will face in our medical system, health system. So I think with these three markers, if they do a Kaplan-Meier curve that separate them with 0 to 1 risk and to 2 to 3 risks, they can see a benefit of how to choose the patient that can really get a good result with ART treatments. And also, there's another advantage of this patient is that how about patients that already receive ADT for this probably this patient will go into mCRPC condition. Is there any marker that we can choose or we can look for, whether we should start ARAT or we can provide others treatment like chemo or radium-223, other type of treatment modality. So with this post-ADT risk factor, they found that the PSA nadir that's larger than 1 nanogram per microliter, time to PSA progression that's less than 8.9 months, and the PSA change rate in 3 months play a significant role in this prediction of ARAT efficacy. So with these 3 markers, I think together with another 3 markers that we have shown you in this paper, that suggests that probably in the clinical practice, we can use this as a guideline to choose which treatment that patient should go. Basically, when the patient come to us in a metastatic condition, and you can check how many pre-ADT risk factor they have. If they only have 0 or 1 risk factor, maybe these patients are safe to just go on with ADT alone or plus the O or more cheaper anti-androgen bicalutamide. And if the patient have a higher risk, then we should go directly for ARAT treatment. But if they are under ADT treatment before, then we can look at the PSA change rate in 3 months. And if it is more than 0.987, the change rate, then we look at 2 other factors again. Time to PSA progression that's less than 8.9 months. PSA nadir is higher than 1. Then we probably wouldn't go directly to ARAT. We will continue with the ADT treatment until it progresses into mCRPC. So I think this is probably one of the nice guidelines that we can think of when we come to our clinical practice. So beside that, I think I also look at other literature data. This is another study from Japan, and I think they also find a few markers that influence the survival of the patient when they come to receiving ARAT treatment in prostate, in hormone-naive, so-called CSPC patients. So these are the 3 risk factors. The Gleason saw patterns, there's 5, and also the BSI. BSI stands for bone metastatic index. This index is not calculated by the amount of or the spot of the site of the prostate metastasis, but it's look at the whole volume of the prostate metastatic to the bone. So, and also look at the LDH level. So you can see they can separate the patient into 3 groups based on the risk factor they have, and they finally come with a nomogram to predict 5-year overall survival of the patient with SHPC. So the other study also from Japan, and this study also looking at the factor that influence the prognostic of mCRPC, and they found that time to prostate nadir PSA less than 7 months, and PSA doubling time less than 5 months, and hemoglobin that is less than 11 grams per deciliter is the risk factor that we have to be aware of when we're looking for the treatment efficacy of the ARAT. And also in this study, the factor can be used in chemotherapy group and non-chemotherapy group as well. So it means that these risk factors are suitable for stratifying patients whether they should go for chemo or non-chemotherapy. And yet they come with a nomogram that we can use to predict the 3-year survival of patient with mCRPC. So this is a paper that's focused on CRPC. And this is data from Taiwan. I think our colleagues from National Taiwan University Hospital, they collect retrospectively 202 patients. And in the study, they explore to see whether, first they look at enzalutamide and abiraterone. The survival, it doesn't seem to have any difference when we choosing these two drugs. But in their multivariate model, they found out that these two factors, the one that time to PSA nadir, that's less than 7 months, similar to the one in Japan study, and the PSA nadir that's larger than 2 nanogram has associated with this worse overall survival in these patients. And you can see this is a nice curve that separates the two groups when we look at this using these two risk factors. And this is our own data from Chang'an. We collect 319 patients. It's, mainly we are looking at the mCRPC patients. And yet we also want to identify is there any clinical predictor that can tell us the response of the patient with AR-AT. So in our study, similar, we try to do univalent and multivariate analysis. And in this AR-AT failure survival, there's two factors that we found may be related to the survival is this SUP grade, recent score grade that's higher than 4. 5 is less effective and worse prognosis. And if the patient is chemo-naive, probably they tend to have a better result. And when we look at the overall survival, I think we found very similar data that the risk factors that that's relevant is nadir PSA that's less than 1 nanogram and nadir and the pathology grade that is less than 4 versus 5. So I think Grissom score group that is larger equal to 5 is worse prognosis factors. So with that, I think although our study is still very premature, but we can do we can make a nomogram to predict the probability of AR-AT response that can durate more than 1 year. So I think our study quite in line with many studies that I've shown you in Japan or in others Taiwan's database. So my small presentation just want to bring you some ideas that I think most patients, although they respond to ADT, but they eventually will develop a resistance. So we have several choices. So we have to find out which one is the best treatment for our patient, especially in Asia. So because we have the economic burden when we think of using this kind of a new agent. And so far, reviewing the literature and also based on our own study, we find that there is several risk factors that we can explore, like age, CRP, ALP, hemoglobin, PSA nadir, time to PSA nadir, and doubling time, and this ISUP grade, Grissom score pattern, bone scan index, and LDH. So there are more to explore, but in reality, whether this, which one of these marker can stand out as a universal risk factor that we all can be used, I think we need a more collaboration or in our future to use different cohort to verify these risk factors. So with that, thank you very much for your attention.
Thank you. Thank you, Professor Fang, for your nice and informative lecture. We are looking forward to a continuous collaboration with the Taiwan Urological Association. Thank you once again.
네, 다음 강의는 호주의 리밍웡 선.
The next presentation will be delivered by Mr. Lee Ming Wong from Australia. His association is in close relations and cooperation with our association as well. And Professor Lee Ming Wong will talk about how does PSMA PET-CT change our clinical practice in the management of prostate cancer. Indeed, PSMA PET-CT is growing in usage in Korea as well. Australia is the #1 country in terms of the PSMA PET-CT results and experts. So I believe that we are about to enjoy a very informative lecture. Over to you.
네, 주신 KUA 감사드립니다. 나의 논문 명예요 송효민 졸업. 저는 호주 멜번 출신이에요. 나는 이번이 조무.
This is my first time here in Korea. I am Lee Ming Wong and I'm from Australia. I am Associate Professor from St. Vincent Hospital. I'm sorry, I'm gonna have to speak in English because Korean is so difficult.
Hopefully I didn't say anything rude inadvertently, but I really enjoyed the invitation and spending some time in Seoul. I'm going to bring back my daughters and dress them up and visit the Secret Garden. And thank you to Professor Byon and Professor Hong for hosting me, introducing me and showing me some fantastic surgery at St. Mary's. And I think a lot of Koreans and Melburnians share a love of food and coffee. And my friend in this picture is a big fan of Korean men, and she asked me to pass on her contact for anyone who is single and available. So today I'm going to present some work on PSMA PET. Most of the data is predominantly Australian, so there is a little bit of bias. I was involved in an investigator-led trial. I didn't receive any direct money, so I have no direct conflict of interest. So I'm going to divide the talk into 3 parts: biochemical recurrence, staging for primary cancer, and potentially diagnosis of primary cancer. So this is some data looking at biochemical recurrence. This is a trial that was run by one of my radiation oncology colleagues, Professor Michael N.G. And as you know, before PSMA PET, the issue of giving salvage radiotherapy was based on essentially pathological variables and PSA kinetics. And it had varying success with, a 55% success rate at 5 years. And the issue was really, how do you select the right patients to give potential toxicity to? So this trial was run over 7 centres in Melbourne with a recruitment target of 100 men. I think the useful thing with this trial is the inclusion criteria is quite strict with the PSA. This PSA of very low, between 0.2 and 2.0, is really what we deal with in our day-to-day lives. So the patients were referred to salvage radiotherapy. They had a PSMA PET. So we have access to this 18F DCF PYL tracer, which is much more stable than 68 gallium. So they had a PSMA PET and a diagnostic CT chest abdo-pelvis. A management plan was made based on the CT, initially blinded to the PET, and then they saw the PET and had to make a post-PET management intent plan. And then there was long-term follow-up. The biochemical control at 3 years is still yet to be published. This is the baseline characteristics, and essentially you can see that the PSA is very low, and hopefully this is something hopefully all your PSA post-radical prostatectomy is undetectable, but if you do have patients for salvage, your PSA is very low. There's a mixed representation of biochemical recurrence and persistence. Most of it is intermediate risk disease. We don't tend to do pelvic nodal dissection in Australia, and a fair amount of extra prostatic extension, and about 1/3 with a positive margin in this cohort. And they reported the patterns of detection on the PSMA PET of recurrence. So in the 98 men that were recruited, nearly half of them had positive findings on the PSMA PET. And the distribution was approximately 27 or 30% locally, nodally another 30%, and then about 10% had bone lesions. Okay, let's move on. So the performance of the PET versus the diagnostic CT chest abdo-pelvis. So this is a 2x2 contingency table, and you can see when the PET when the PET is positive, it picks up a lot of negative CT scans, and the CT is positive, and very few are missed on the PET, which is not surprising, really. Here's some examples of where all the different sites of disease post-prostatectomy that were detected on PET, but were not detected on standard CT chest abdo-pelvis. The other outcome they looked at were, I guess, changes in management or changes of management intent. And essentially, if you had to change the dose of the radiotherapy, dose of the volume, or use ADT, this was considered a moderate change in your decision. And a major change is where you change the intent of treatment. For instance, if you thought you were going to be curative and now it's palliative, or you change the recommendation in having radiotherapy or not having radiotherapy. And obviously, if you have more information, you're more likely to make a change in your intent. And this is reflected in a similar trial reported by the Condor group. But you can see in this trial, the PSA range goes up to 98.4. So this is, I think, contaminated by patients that were never really suitable for salvage radiotherapy. This is a patient of mine who had a radical prostatectomy 5 years ago, negative surgical margins, and his PSA very slowly increased. 1 year ago, his PSA hit 0.2, and he had a negative PSMA PET, which is this image here. And then his PSA over the next 12 months crept up to 0.28, and then we sent him to have a new scan on the Siemens Quadra PSMA PET, which has a faster time of flight and has increased sensitivity. And they were able to detect this small little recurrence here that was not obviously seen on the standard PSMA. So the machines are continually evolving. This was a little spin-off trial that we did looking at the patients that had local recurrence detected on PSMA PET, post-radical prostatectomy, looking at those roughly 30 patients. And we found that positive margin didn't necessarily reflect where the local recurrence was. So we looked at where the local recurrence was on the CT, and then where the disease was on the histology, and we tried to match where the disease was and where the recurrence was. And we found that actually it's much more complicated than just a simple positive margin. It's really a pilot study, but it helps us better understand how we do the surgery and what's driving local recurrence. I'm going to move on to staging for prostate cancer now. St. Vincent's was part of the PRO-PSMA trial, which was led by Peter McCallum, another centre in Melbourne. This is Professor Michael Hoffman, who was the principal investigator. This study was published in The Lancet and has had over 1,000 citations. So this was looking at patients that had biopsy-proven prostate cancer with high-risk features. They were randomly assigned to either conventional CT and bone scan or gallium-68 PSMA PET. And the primary outcome was looking at accuracy of first-line imaging to identify nodal or distant metastatic disease. So overall, they found in this cohort of nearly 300 patients, 30% of the cohort had metastatic disease at diagnosis, and PSMA PET had overall a 27% greater accuracy than that of conventional imaging. So we're looking at 92% versus 65%. In particular, it's got much better sensitivity. So it picks up smaller lesions that are not detected on CT. So, sensitivity of CT and bone scans is only 38%. So it's missing a lot of lesions. They also looked at PSMA PET versus conventional imaging for pelvic lymph nodes, distant metastasis, and all of them has better sensitivity. I think the question, because the topic of the talk is how does PSMA PET change our management, the question is for me, how does pelvic lymph node dissection sit now in a PSMA era? We know that some studies show 50% of suspected lymph nodes metastasis actually fall outside the boundary of your template of your extended pelvic lymph node dissection. If the PET shows a single MET in, say, an iliac lymph node, do you do a template of that whole side, or do you just try and take out that node that's avid? What do you do if the PSMA PET shows that the primary cancer is non-PSMA avid? In our experience, we have been looking at doing FDG PET because a lot of these lesions are very undifferentiated and they tend to be positive on the FDG PET. And then there are some people looking at combining nomograms that predict metastatic disease with PSMA PET. There are some limitations of PSMA PET. You can get false positives, particularly small lesions in the kidney. Sorry, not really in the kidney, but really in the bone is where I've seen it. But these are all other areas that are reported. This was a patient of mine, a 68-year-old man who had 3 brothers with prostate cancer. His PSA was 3.8. His prostate felt benign. He was enrolled in my trial where we compared PSMA to MRI. His MRI was reported as normal, but on the PSMA PET, he had these 2 areas of avidity in his prostate, and this is quite avid, but it's symmetrical. But then he also had this really hot spot in his vertebra, and I thought for sure this man would have prostate cancer. His prostate biopsy was negative. There was no cancer, even with targeting of the PSMA lesion. And we still couldn't believe it, so we went and targeted and did a biopsy of his bone. It was also negative. So this demonstrated to me that there is some issues with specificity or false positives with PSMA PET. So now we're going to move to using PSMA PET to look at possible primary diagnosis of prostate cancer. So these are men referred to you with high risk, high PSA, family history, abnormal DRE. There are 2 trials in this space. One was the primary trial led by a nuclear medicine physician, Professor Louise Emmett, apologies, I spelled her name wrong, in Sydney. And then I have unpublished data where we're looking for a home for a publication still. And these are both trials comparing the diagnostic accuracy of MRI and PSMA PET to help detect cancer at biopsy. Essentially, these trials all involve multiple sites referring to a central site. There's a slight difference between the primary trial and our trial in the sense that the primary trial had MRI triaging, so all the patients had MRI first, and if you had PIRADS 2 and above, you were referred to have a PET. Whereas in my trial, all patients were referred for MRI, also got a PSMA PET. The other difference is the primary trial used a gallium tracer, and they only did a screening pelvic CT, whereas we did a chest to pelvis PSMA PET. All of the imaging is read by experienced radiologists blinded to the other modality, and then the biopsy is the outcome. The primary trial, all their patients had a biopsy, whereas in our trial, patients had the option of declining a biopsy. So really the key findings looking at diagnostic accuracy, which is measured by area under the curve, so under the receiver operating curve. So the top line is looking at detecting all prostate cancer, so any grade group. And in our trial, we found that MRI had an AUC of 0.76, and this was statistically higher than PSMA PET, which had an AUC of 0.6. In the primary trial, they were looking at clinically significant prostate cancer, so that's grade group 2 and above. And if you look at all the sensitivities, specificities comparing the primary trial and the PET trial, you can see that the PSMA PET sensitivity is actually not too bad. It's quite close to MRI, but the issue is really looking at the specificity. It has more false positives, and that is why the global diagnostic accuracy for PSMA PET is probably a little bit lower than MRI. One of the key findings for both the PEDAL and the primary trial was what happens if you combine the MRI and the PSMA PET together, so the patient has MRI and also PSMA PET. And you can see here that when you combine it statistically using the Boolean operator OR, the sensitivity and the negative predictive value is very high. So if you have 2 negative scans, the likelihood that you are missing a clinically significant prostate cancer is probably quite low. This is a patient from the PEDAL trial that had an MRI and a PSMA PET. And you can see here on the MRI, he has a small PIRADS 4 lesion here in the right PZPL, which is concordant on the PSMA PET. But on the PSMA PET, he also has this really avid lesion here at the left apex, which did not have an MRI lesion. So he ended up having a radical prostatectomy. And you can see that the lesion here is at the right PZPL, and there's no cancer here at the left apex. So again, a false positive. Similarly, on this case, this man has a very large infiltrative PIRADS 5 lesion in his prostate that was essentially non-avid on the PSMA PET. So that is also possible as well. The other finding for the PSMA PET, when you do a diagnostic, is that in our group of 236 patients, nearly 10% had findings suggestive of metastatic disease right at diagnosis. And we did a little bit of sub-analysis looking to see how you can select these men, and it tended to be older men, those with higher PSA density, or abnormal DRE. So potentially you could consider doing something like called a one-stop shop, where you have both diagnostic and staging imaging for these patients. So they just have one scan, one PSMA PET, rather than MRI, biopsy, and then staging PSMA PET. So to summarize in these three settings, biochemical recurrence. So PSMA PET, I think, clearly detects more metastasis, and this will definitely change your management. What do you do with these patients? Does it actually affect survival, long-term survival, by detecting these areas earlier? This still remains to be seen. For staging for high-risk prostate cancer, I think it's clear that PSMA PET is superior to conventional CT and bone scan. For us as urologists, we need to consider the role of pelvic lymph node dissection in this group of patients, but also to beware of false positives on the PSMA PET. Does Gleason 3+4 need a PSMA PET? Probably not. We are detecting small volume metastatic disease, which is driving management of oligometastatic disease, and how we manage this also remains to be analyzed. And finally, for primary diagnosis, I think our trials show that MRI remains the first line, but you could consider PSMA PET if the patient has a contraindication to MRI, if they have big bilateral hip replacements that's causing a lot of artifact, if they're at high risk for concurrent metastasis. Potentially some patients, they have negative MRI, but maybe strong family history, high PSA, but they still don't want a biopsy. You could potentially look at using PSMA PET to help get more reassurance to avoid biopsy. And also, I didn't present, but there is a trial where we looked at patients with MRI PIRADS 4-5 lesion with negative biopsy, which can cause a bit of anxiety, and using PSMA PET in that setting to help decide whether or not they should have another biopsy. So I'd like to thank you very much for your invitation and your time, and hopefully I can host any Korean urologists in Melbourne, and thank you very much.
Thank you. Thank you, Dr. Wong. Thank you for a great talk. 시간상 바로 다음 세션으로 넘어야 될 것 같습니다. 다음 세션은 urothelial cancer.
Let's move on to the next presentation or the session, urothelial cancer session. We will have two speakers. Let me introduce first speaker, who is from the US, and Dr. M. Ling will be making the presentation. Let me introduce him to you. He's from the Oregon Science University. He finished the residency at Nuke and fellowship at Mayo Clinic. He's currently with the Oregon Science University. Would you please welcome him with a big round of applause?
Well, thank you for the introduction and for the opportunity to be here. Thanks for the meeting organizers. I've never been to Seoul, Korea before, so it's my first trip. It's been great to be here. It's an honor, really, to be able to present and to represent the AUA in this regard. What I'm going to talk about today is something that I have been for many, many years sort of biased against. That is radiation therapy treatment for bladder cancer. Being trained many years ago as having a busy surgical practice, always biased in favor of radical cystoprostatectomy or cystectomy. But if you look at the data closely over the last 10 years or so, in the well-selected patients, I think it's something that we should open our minds to for sure. Now, radical cystectomy with lymph node dissection remains the gold standard, with a survival rate of approximately 60% at 5 years. That depends on clinical or pathologic stage, of course, but overall averaging about 60%. We know that neoadjuvant chemotherapy, cisplatin-based chemotherapy, confers a 5 to 8% overall survival benefit. and that there's significant risk to radical cystectomy and a decline in quality of life, although quality of life surveys comparing radiation-treated bladders versus cystectomy have failed to show any real significant difference, interestingly. Increasing life expectancy has led to an increasing number of elderly folks and frail patients who are unfit for radical prostatectomies, which sort of opens up the idea that perhaps these patients could be considered for chemoradiation treatment to the bladder. Now, it's been known for a long time that there's significant undertreatment of muscle-invasive bladder cancer, particularly in the elderly. This is a study that's somewhat dated from the National Cancer Database in the United States, showing that only 53% of folks receive aggressive therapy, and aggressive therapy defined as radical cystectomy, partial cystectomy, or chemoradiation therapy. And particularly in this group aged 81 to 90, only 35% received aggressive therapy. And you can see this is the observation, the blue hatched bar here is the observation group. And you see that goes up obviously as age goes up. But a significant number, 35%, did not receive aggressive therapy if you were between the age of 81 and 90. Now, bladder sparing strategies in select patients are guideline supported. This is the NCCN guidelines talking about treatment of muscle-invasive bladder cancer for those who are cystectomy candidates, neoadjuvant cisplatin-based combination chemotherapy followed by partial cystectomy, another bladder preservation strategy. Neoadjuvant chemo with radical cystectomy we all know about, and then cystectomy alone for those who can't receive cisplatin-based chemotherapy. But see down here, bladder preservation with concurrent chemoradiation therapy is another option to consider in these patients. Now we know that 30 to 40% of muscle-invasive bladder cancer patients can achieve a complete response to neoadjuvant chemotherapy, which sort of opens up the idea, well, if 34% can become pathologic T2, then perhaps they could benefit, this group of patients could benefit from radiation. Now it's important that we select patients correctly if we're going to advocate for radiation therapy to the bladder. Smaller tumors, no hydronephrosis. Hydronephrosis generally indicates a deeper muscle-invasive or even extravesical extension of the cancer, so hydronephrosis. Carcinoma in situ throughout the rest of the bladder needs to be ruled out. Complete TURBT is very important. And it's been estimated that only about 10 to 15% of patients meet these criteria presently. Now I'm going to talk a little bit about these bladder preserving options. TURBT, maximum TURBT, partial cystectomy in select patients, systemic therapy alone, not really recommended. Radiotherapy alone, definitely not recommended, and then chemo radiation or more contemporarily described as trimodal therapy. Now let's talk first about radiation therapy and chemosensitizing chemotherapy. This was a large study, the BC 2001 study, randomized, phase 3 randomized trial, really at that point one of the largest randomized trial in bladder cancer. 360 patients with muscle-invasive disease. They had radiation therapy. The radiosensitizing chemotherapy was 5-FU and mitomycin C. Survival at 2 years from local regional disease. So it was shown statistically to decrease the chance that you have persistent disease locally or regionally if you got the chemotherapy combined with the radiation compared to the radiation by itself. There was no statistically difference, however, in overall survival at the 5-year point. So let's talk a little bit about maximum TURBT. In the image on the right there, you can kind of see the perivesical fat. So that's a pretty radical maximum TURBT. But even with TURBT, 35 to 55% can have invasive relapse in the bladder if you're just doing TURBT alone. And that's in patients who have been selected as favorable for bladder sparing treatment. So the patients should be a solitary T2 tumor, resected to fat, negative re-resection. I think re-resection is really important if we're going to push somebody or plan to do a radiation therapy for bladder cancer, and then negative examination under anesthesia. Harry Herr wrote this paper and published it in the Journal of Clinical Oncology in the early 2000s, showing that TURBT alone in some cases can be very effective if the re-resection shows no tumor, pathologic T0. And in this population where he followed them for 10 years, 82% versus 57% survival if on re-resection you found tumor or you found T1 tumor. So the ones where T1 tumor was found on re-resection, did worse than those who were not found to have tumor. What about partial cystectomy? There's certainly a subset of patients who are candidates for this. Obviously, there's criteria: solitary tumor, feasible location, dome, or elsewhere in the bladder where you can do a complete resection with negative margins, no carcinoma in situ elsewhere in the bladder, and obviously bladder capacity can be an issue, and in some cases that can be the limiting factor. With partial cystectomy, there's about a 15 to 25% of muscle invasive recurrence, and that's when you select patients, again, carefully selected patients. So it's important to also consider, because I think that when we go to partial cystectomy for that well-selected patient, we often forget about the idea of neoadjuvant chemotherapy or lymphadenectomy, and those two things still apply in the partial cystectomy setting. What about systemic or chemotherapy alone? Neoadjuvant chemotherapy is a gold standard prior to cystectomy, and it should be cisplatin-based, assuming that cisplatin can be tolerated, and there are many patients who can't tolerate, particularly the elderly patients or those with renal insufficiency. This is a study from Moffitt Cancer Center where 332 patients received neoadjuvant chemotherapy. The complete response rates were documented, and it was significantly greater in those who received dose-dense MVAC as neoadjuvant chemotherapy compared to 24.5% in those who received gemcitabine and cisplatin, and quite low with gemcitabine carboplatin. And that's something that we know to be true, that carboplatin is not nearly as effective as cisplatin in the setting of urothelial carcinoma. Now, one of the problems is identifying the complete responses, because if we can identify, obviously, those who get chemotherapy and then are going to result in a pathologic T2 outcome, then we could select patients more appropriately. But unfortunately, it's hard to do that. It's hard to do that. This study showed that in 50% of those who went back and had re-resection prior to the radiation therapy, that they had residual cancer at the time. Well, they didn't get radiotherapy, but they re-resected, and there was no tumor on the re-resection. 50% had residual cancer at the time of cystectomy, and 25% were pathologic T2, so muscle invasive. So even though the re-resection suggests the absence of persistent disease, there can be persistent disease. So this is an example of clinical understaging, which we know to be true in bladder cancer particularly. Now, biomarkers are being investigated that might be able to predict these complete responders, but we haven't got there yet in terms of an adequate or useful biomarker. Now, radiation therapy alone is not guideline recommended. It could be offered to patients who aren't candidates for concurrent chemotherapy, but the response rates are minimal, and generally radiation alone is used in the palliative setting, so in patients who are having bleeding or such from the bladder, so not really recommended as a solitary treatment. Now, the real issue here and the real treatment that has made progress over the years is trimodal therapy. And trimodal therapy consists of radical TURBT, so an aggressive TURBT to CFAT, systemic chemotherapy, and I'm talking here about radiosensitizing chemotherapy, which is different than neoadjuvant chemotherapy. So neoadjuvant chemotherapy, of course, 3 or 4 cycles of cisplatin-based chemotherapy. This is radiosensitizing chemotherapy. It's given during the radiation to augment the effect of the radiotherapy. And some of the agents that are used for that are cisplatin, 5-FU, or mitomycin C. Can be used if there's renal insufficiency, and gemcitabine by itself is also a radiosensitizing chemotherapy. The radiotherapy given is generally in the range of 60 to 66 gray totally, and often there's some expansion to the pelvic nodes or focus on where the location of the tumor is. Salvage surgery, so at the end of that, assessment needs to be made about the response to this treatment, and salvage surgery should be considered. And that's the classic description of trimodal therapy. It's NCA and guideline compatible in select patients. Again, those who don't have hydronephrosis, have a complete TURP, no CIS, and relatively small tumors. And what gets radiated, well, it varies, but the whole bladder gets radiation therapy, but sometimes they concentrate on where the tumor is located with a boost there, and sometimes expand to the pelvic lymph nodes. The Massachusetts General Hospital were really the pioneers of this approach trimodal therapy, and they started to do this in the 1980s when we all didn't believe in it. Here's the data. The disease-free survival difference at 5 years were 66 to 59%. If you look at the graph on the right, these are some of the factors that predicted who would be successful at this or not. You know, T2, muscle invasive, but not T3, 4 patients. Those who had a complete response to the chemotherapy obviously did good in both disease-free survival and overall survival. And those who were thought to have a visually complete TURBT did better than those who had an incomplete treatment. And if they followed their data over the years, over the 3 treatment eras, the complete response rates improved pretty significantly from 66 to 88%, and 5-year disease-free survival rates increased from 60 to 84%, and the chance of needing a salvage cystectomy dropped significantly over this period of time, suggesting perhaps that the refining of treatment, better technology, better chemotherapy regimens, improving outcomes with this approach. Now, what are the types of regimens? The standard Massachusetts General Hospital regimen is what's called a split course radiation therapy. So you do your maximum TURBT and re-resection, and then the radiation is initiated, but you stop at 40 gray, not the 65 gray or so, and then you reassess at that time and re-biopsy the bladder with the idea that if there's tumor present at that point in time, so a partial response, then you go to immediate salvage cystectomy. The other approach is to complete the entire course of radiation therapy, do the same re-biopsy, and then again, if there's residual disease, go on to salvage cystectomy. What's the best radiation therapy protocol? Well, the BC 2001 suggested that, or investigated the difference between 55 gray and 20 fractions over 4 weeks versus 64 in 32 fractions over 6.5 weeks, and basically showed no significant difference. So you could give the lower dose of radiation therapy over 4 weeks without any significant difference. And if you looked at a meta-analysis of these 2 large randomized trials, 55 gray over 4 weeks also had a lower risk of invasive lower regional recurrence than the longer course of radiation therapy. You might think that the longer course would have increased toxicity, but there's no difference in toxicity. Now, evaluating the success is really important, right? So you put the patient on this protocol. Cystoscopy and repeat biopsy at the 6 or 12-week point of completion of this treatment is important, because about 30% will be positive for residual cancer, and whether they go on to cystectomy or not is decided at that point in time. Recurrence is seen in 24 to 43% of patients after initial complete response. So you have the complete response, and you go on to the TMT treatment, there's still a relatively high probability of recurrences. Most recurrences happen within the first 5 years, so surveillance long-term is recommended. Cystoscopy every 3 months for the first 2 years, every 6 months for years 3 to 5, and then yearly with CT scans every 6 months for 2 years, and then yearly. That would be a usual follow-up protocol. What about functional outcomes? We always talk about, well, if you radiate the bladder, it's going to destroy the bladder. There are going to be bladder cripples with irritative voiding symptoms and blood and radiation cystitis. And honestly, there hasn't been much in terms of looking at those things and bladder capacity or those kinds of things. It's really poorly studied in the literature. But the few studies that have used assessment questionnaires have actually showed that there may be very little difference between the quality of life after TMT and the quality of life after radical cystectomy. So that's the ultimate question, right? Is TMT comparable to radical cystectomy in select patients? Now, there's no randomized trials. That's the problem. One was started in the UK called the SPARE trial, but only 45 patients enrolled in that trial, so they closed that trial. So we were left with propensity matching studies that are observational, and the first one here is the National Cancer Database of 812 neoadjuvant chemotherapy patients with and radical cystectomy. So the idea here was to compare the standard of care for cystectomy, which is neoadjuvant chemotherapy plus radical cystectomy, compare that to the TMT, the most fair sort of comparison. And after propensity score matching, there was no difference in the 10-year overall survival between the two approaches, so 40% versus 33%. And important to note, there was improved overall survival in the neoadjuvant chemotherapy radical cystectomy group when you had clinical T3 disease. Goes back to selecting, right? So if you have a cancer that's deep in the, outside the bladder in the perivesical space, you're going to have worse overall survival outcomes with this approach, and you're going to have better outcomes with neoadjuvant chemotherapy and radical cystectomy. So another propensity score matching analysis showed, again, the same thing, no difference in disease-free survival at 5 years for this group that was looked at. And the ultimate, without randomized trials, right, the ultimate quality of evidence goes to reviews and meta-analyses. And this study, basically, of 12,000 patients, showed no difference overall between TNT and radical cystectomy. What about variant histologies? Again, no real data here to be able to say whether this approach is appropriate in those with various variant histologies. What about salvage cystectomy? What are the outcomes with salvage cystectomy? Basically, this particular study showed that the early complication rates were similar, but the long-term rates of complications with stomal stenosis and ureteral stricture were greater, so the late complications were rated higher in the radiation therapy group. And finally, immunotherapy with bladder preservation. So that's kind of a hot area of research right now. There's some evidence to suggest that radiation to the bladder can increase or overexpress the PD-L1 tumor cells and therefore become more responsive to checkpoint inhibitors. So the studies that have been done show that the complete response rate is significantly higher by adding this immunotherapy. So to conclude, properly selected TMT patients can indeed have outcomes comparable to radical prostatectomy, but it's all about patient selection. Toxicity and even salvage cystectomy are acceptable. It may have more of a role to play in those who are unfit for surgery. Immunotherapy is exciting in terms of adding to the role of the TMT, and biomarkers need to be developed so we can know about who indeed is responding to this treatment or who needs to go directly to cystectomy. I want to end by just putting in a plug for the AUA meeting. It's May 3rd to 6th this year in San Antonio. I hope all of you can attend. A great meeting, as you all know. Look forward to it in San Antonio. And thank you for your attention. Appreciate it.
Thank you. Thank you for an in-depth talk. Sorry for not being able to provide more time.
네, 다음은 이 세션의 마지막.
And next is the last speaker for this morning session, and we have Ms. Lars Andersen, who will talk about liquid biopsy. Mr. Andersen graduated from Aarhus University in Denmark and is serving as a professor in the same university. And in terms of bladder cancer research, he's a very active scholar. Over to you, Professor.
For the invitation here. So I'm going to talk about the circulating tumor DNA, how we can use it in muscle-invasive bladder cancer for guiding treatment decisions. These are my conflicts of interest. I'm going to highlight that I have collaborations with C2I Genomics, Natera, and AstraZeneca, and I'm going to show some data in this presentation also. So first of all, if you take a look about what is cell-free DNA and circulating tumor DNA, we know that all cells shed cell-free DNA into circulation. If we have inflamed tissue like here, then we have higher levels of cell-free DNA going out into circulation. And in tumor tissue, we will see DNA that is mutated or have other alterations being shed into circulation. And the idea is that we can use that as a molecular handle for guiding treatment decisions. The DNA that we see in plasma is highly fragmented, as we can see here. And interestingly, also for analysis for bladder cancer, we can see it in the urine also, where we have, we can see it in the urine from renal clearance also. One thing I would like to highlight here that's important when we talk about cell-free DNA and circulating tumor DNA is that the half-life of cell-free DNA in circulation is around 2 hours or below. That means that we can use it as a real-time monitor and handle on the disease and see if we can use it for monitoring the disease burden after, for instance, chemotherapy. So how can we use this? We can actually use it for early cancer detection, to molecular prognostication and profiling before surgery. We can use it for especially detection of residual disease after surgery, and for monitoring of treatment relapse and clonal evolution during treatment also. It's important to notice here that the tests that we use before surgery, where we have no idea of the disease biology, is less sensitive. This is tumor-agnostic approaches. So it's less sensitive and less specific because we don't know anything about the disease biology yet, and that means that it may be more difficult to use screening tools, for instance. But the tumor-informed approaches are highly sensitive and specific, especially for identifying minimal residual disease and metastatic disease. So ctDNA and cell-free DNA is not a new thing. It was actually discovered here in 1948 in the blood plasma. But it's really been driving forward by using, for instance, new technologies, digital droplet PCR and next generation sequencing, where we see here the last 10 years, where we saw some retrospective studies indicating the potential use of cell-free DNA, and recently we have prospective studies ongoing and now clinical trials also I'm going to touch upon. So first I'd like to talk about MRD and metastatic relapse detection. We did a study a couple of years ago here where we looked at plasma samples taken at diagnosis during neoadjuvant chemotherapy before cystectomy and at these different time points after cystectomy. This was a collaboration with Natera where we did whole exome sequencing of the primary tumor and then identified a panel of 16 mutations and used that to sequence the plasma samples really deep, 105,000 times coverage here. And when we did that on this cohort of 68 patients to start with, prospectively we obtained results like this. This is from one patient here. We can see the cell-free DNA is positive. The test here during neoadjuvant chemotherapy, it goes down to 0 before cystectomy, indicating that the treatment is actually effective for this patient. It's then rising again here after cystectomy, and this is actually 245 days prior to detection on a CT scan, indicating that we can actually start treatment of these patients earlier if we use ctDNA. This is the result of this study. We saw that it was highly prognostic already before chemotherapy in the patients, before cystectomy, after neoadjuvant chemotherapy, and also especially after cystectomy. We can see the accumulated data here where we have a very high sensitivity and specificity of the tests. So importantly here, what we found in the study was that we saw that ctDNA has had a positive lead time of about 3 months over CT scannings, indicating that there may be a window for earlier treatment. We've now done a larger follow-up of this cohort here, and again, using full-time follow-up, clinical follow-up of the patients, we still see that we have a high prognostic value of this test before neoadjuvant chemo and before cystectomy, and also again here after cystectomy for the cohort. But again, we start to see some relapses here occurring very late in the ctDNA negative arm, indicating that there may be tumor evolution ongoing. In this study, we also tried to look at a cohort of patients that didn't receive any neoadjuvant chemotherapy. And again, here for this cohort, when we looked at the ctDNA status before cystectomy, we can see there is a high prognostic value of the test and also after cystectomy. But what happens then if we actually correlate the results from this when they're ctDNA negative, the patients that received neoadjuvant chemotherapy and the patients that didn't receive neoadjuvant chemotherapy? We can see we have a higher recurrence rate in the patients that are NAC naive here, but it's actually not a significant difference. Excuse me. And this is the results from patients that are ctDNA positive. But these results indicate that we should probably go into different clinical trials where we do randomization of this to figure out if patients that are ctDNA negative actually need neoadjuvant chemotherapy. So what I've been showing you now is results from patients where we use 1 or up to 16 different markers. But what happens actually if we go from single mutations up to multiple mutations using, for instance, whole genome sequencing of the tumor instead of exome sequencing and digital PCR, for instance? So what we know here from this theoretical overview here is that if we go from single to tens of thousands of mutations, we actually have a higher probability of detecting ctDNA in the samples already at low sequencing levels here also. So we have been investigating that in a collaboration with C2I Genomics, where we do a whole genome sequencing of tumor and germline, build a model based on all the different mutations we find there, and then apply this model to plasma samples from the different patients and figure out if they are positive or negative. This is the result of this analysis, and what we found here was actually that circulating tumor DNA, that's the red circles here, are detected very early on in patients that have metastatic disease later on. And these are patients that don't show any signs of metastatic disease later. And again here, ctDNA is highly prognostic before chemo, before radical cystectomy, and after radical cystectomy here. So this is a simpler tool. We can just do whole exome sequencing, tumor germline on all the plasma samples, and don't have to make any specific assays per patient. Again, here we see using this approach, we have a positive lead time of ctDNA over CT scanning also for most of the patients. So what about response, treatment response evaluation, and when we use ctDNA for that? So we've been looking into that also, and then looked at the samples we took here before, during, and after neoadjuvant chemotherapy. And when we did that, in this first study we did, we could see that there is a high correlation in the dynamic between pathological downstaging and the ctDNA levels. But for some patients, we saw no correlation between pathological downstaging and circulating tumor DNA dynamics. So what is then better? If we then compare to outcome and look at patients that have pathological downstaging here versus patients that show ctDNA changes, we can see that the ctDNA dynamics is actually a better indicator of outcome compared to the pathological downstaging. Of course, it makes sense that we look at a systemic disease here compared to a localized change in tumor burden. We did that in the whole genome sequencing study also. Again, here we can see if patients are positive pre-chemotherapy and before radical cystectomy. We can see that there is a correlation to no downstaging of the disease during chemo. And if we look at the dynamics here also, we can see if ctDNA remains during a chemotherapy, we have a higher percentage of patients that don't show any response to treatment. And this is again the ctDNA dynamics here. We see if there is clearance or all are negative, we have a lower recurrence rate compared to if ctDNA remains. And we can see that in the Kaplan-Meier plot here also. So what about combining urine and plasma then? So we tried to look at that also and use this information I already showed you with information we obtained from urine samples. This is a slightly different approach where we use 50 mutations per patient instead of 16 or whole genome sequencing. So here we have the plasma results first. Again, if all are negative, we have a high complete pathological response rate. If there's clearance, it's also good, and if ctDNA remains, it's a poor outcome, and we can see that on the Kaplan-Meier plots here also for recurrence-free survival. This is the results from the urine supernatants. When we take the same approach, if we see clearance, there is a higher probability or higher percentage of patients that have a pathological complete response compared to if we have remains, if there's still mutations in the urine at cystectomy. And again, we can see that in the recurrence-free survival here also. If we combine that, now we're down to really low numbers, and we need to validate this in larger studies, and we are doing that now. But if we see that ctDNA is remaining in the urine and plasma, we have a very poor outcome for these patients after cystectomy. And if there is no mutations in the plasma and urine, we see a very good outcome for the patients. So it may be something, as we heard about in the previous talk also, that we can use, should be tested more. Can we actually use this for bladder-sparing approaches? If both are negative, then the patients may be eligible for bladder preservation. If it's still positive in the urine, then maybe it should have a radical cystectomy, or if both are positive, the treatment regimen may be changed for the patients. But that's something we need to investigate further. Also like to highlight the dynamics observed in this study of IMvigor010 trial. This was actually a negative trial on the primary endpoint, but when the investigator looked at circulating tumor DNA in this trial, they could actually see that patients that were ctDNA positive, they had an increased survival benefit of receiving atezolizumab over standard treatment, observational treatment here, indicating that ctDNA is a powerful tool to actually identify patients that should have treatment. And if they look at the reduction during treatment, or the dynamics in ctDNA during treatment, they can see that there is a reduction. If there is a reduction of clearance, they have a better outcome compared to if it increases or if there is no clearance of the ctDNA. So all of this should really be investigated in different randomized or clinical trials where we do intervention based on the ctDNA. And different studies are ongoing now. There is the IMvigor011 trial ongoing now with Tom Powles as PI. That's a study where ctDNA positive patients are randomized to atezolizumab versus placebo, and the primary endpoint is disease-free survival in patients that are ctDNA positive. We have in Denmark an ongoing trial called Tombola. It's a trial where ctDNA positive patients receive atezolizumab. It's a non-randomized trial. The primary endpoint here is complete response defined as ctDNA negative status combined with the normal imaging after the treatment also. This is an overview of this study. It's Tombola is short for treatment of metastatic bladder cancer at the time of biochemical relapse following radical cystectomy. So it's 5 major clinical sites in Denmark where we're recruiting patients for this. And this is the overview scheme of this. We have right now 168 patients recruited for this, and approximately 50% of these are ctDNA positive after cystectomy. So we sample plasma and urine samples also here at all these different time points, and when patients are ctDNA positive after cystectomy, we start atezolizumab treatment for these patients, disregarding imaging status of the patients also. This study is actually based on whole exome sequencing, first of the primary tumor and germline, and then we develop 4 different digital PCR assays that we use for monitoring the disease burden throughout the disease course here. Hopefully, it's been taking a little bit longer than we expect to recruit the patients here. We started the trial just when COVID hit some years ago now, but we expect to be able to present an interim analysis here in 2024 at ESMO. This is another trial I want to highlight also where Matt Galsky is PI. It's being launched here in 2024. It's called the Modern Trial, and it's a trial for all patients with advanced bladder cancer. And if they're basically guided to 2 different clinical trials. One, if they're ctDNA positive, they have escalation of treatment over standard nivolumab treatment. And if they're ctDNA negative, they actually go into a surveillance arm, and when they detect ctDNA, then they'll start nivolumab treatment. So that'll be interesting to see the result of that trial also. So with that, I want to conclude that ctDNA in muscle-invasive bladder cancer is a very powerful biomarker. We can use it for risk assessment before treatment and cystectomy. We can use it for early diagnosis, for minimal residual disease after radical cystectomy, and for monitoring response during, for instance, chemotherapy and immunotherapy also. We need to demonstrate the clinical value of ctDNA in treatment guided trials where we use ctDNA to guide the treatment, and studies are ongoing now in the Tombola and IMvigor011 trial and the planned Modern trial. And the overall plan is to investigate, can we actually improve overall survival with these new tools? Can we improve the quality of life, and can we reduce the cost also? That's also important. Urinary tumor DNA needs to be investigated in larger details and in larger studies also where we have more data where we can compare to the plasma data also. So with that, and I want to say also that ctDNA methods are evolving, as you saw with the whole genome sequencing approach, also becomes more accurate and commercially available also for easier use in the clinic. So with that, I want to thank my team, as you see here. I want to thank you for your attention.
Thank you, Professor Anderson, for your very impressive lecture, and congratulations on your great success in your research result. And personally, I'm very looking forward to your next step in your research. Thank you. 네, 그러면 좀
Thank you.
늦게 좀 시간이 지나.
Sorry that we are behind the schedule. This brings us to the end of the plenary session. Thank you.
시간이 돼서 오후 세션을
It's time, so we would like to begin the afternoon session. I am Seo Sung-il from Samsung Medical Center, and I'm Han Ung-gyu from Yonsei University. In this session, we would like to discuss renal cell carcinoma. The session will take about an hour. In the first half an hour, we will have a debate, and in the second half of today's session, we're going to listen to state-of-the-art lecture, and I will moderate the first part of the thematic session. The topic of the debate is the cytoreductive nephrectomy and its optimal timing. So when is the optimal timing? It is still a controversial issue that is drawing a lot of attention. And in this regard, and about this topic, we have Professor Park Sung-chan, who would give us the case presentation. So is it better to remove as many cells as possible and conduct systematic cell, or do we have to use drugs first to reduce the volume of the tumor and see the response and before taking nephrectomy? So about that, Professor Park will give us the case presentation.
Thank you. Let's move on. First case. He was presented with cough and abdominal pain. Echo score was 3. He was very slim but lost more weight. Recently, he smoked for more than 20 years. And on CT, there was water on the lung. There was a big lump in the kidney. PET-CT was taken. As you see here, T3 and 4 and OM1. I thought that it was a staging for this patient. And for this patient, ultrasound guided biopsy was done. So the diagnosis was CCRCC. This is the guidelines. And based on the guidelines, I applied this medication, PKI 800 milligram, and on second month, there was a smaller mass found, pleural effusion got better. And at 4 months, he was short of breath, and progression of disease was noticed. So second option that we got is this. In our hospital, nivolumab is what the patient wanted, even though it was not reimbursed. So it was administered every 2-week. Injection was given. Short-term follow-up showed that there was a little bit of a progress, but he wanted to continue to see the follow-up up to 3 months. So this was a rash or AE at 3 months. There was a regression achieved at T1 and OM1. It could be a T3, but it got much better, so cytoreductive therapy can be given, or partial nephrectomy can be considered as well. And in this patient, in the lung, we had this kind of 10 of them were found. If it was all gone, then cytoreductive therapy can be used again. So at 5 months, as you see here on the brain, inflammation was found. We want to show whether it's a metastasis or inflammation. And the neurology department said that left minimal seeding was a more possible or likely. So till 8 months, the medication was given, therapy was given. At 9.5 months, there was metastasis in the brain. Whole brain RT was done, but it progressed. So cabozantinib, the third treatment was administered. Since then, the patient was stable. At 2 years from baseline, seizure caught the patient, and then this patient was dead. I think it's one of the kind of typical MRCC. patient case. So let's move on to Dr. Che from Catholic University.
네, 일단
Hello. So my answer to this case is that the performance status is 3, so I refrained from taking surgery, but my topic is upfront. I was given the topic of upfront cytoreductive nephrectomy, so let me just discuss this issue. When it comes to cytoreductive nephrectomy, it had been a standard care in potentially resectable primary tumor mass. And as for the cytokine era, it showed good prognostic features and good performance status when there is less metastasis burden, of course. And in terms of targeted therapy as well, cytoreductive nephrectomy did a good job. In 2018, however, the Carmena study and third time study were published, and the result kind of changed our paradigm. As for the Carmena study, sunitinib-only group were not inferior to the surgery group, but the limitation of the study is that it was heavily weighted toward poor risk patients, about 43%. And the third time study compared upfront nephrectomy and deferred nephrectomy, but when it comes to the median OS, there had been no big difference. It was for the poor risk as well. It was smaller with 11%, so healthier people and patients were enrolled, but the population of the third time is 99. It's less than a quarter of the typical population size we see, so the study power itself is weak and it is not strong enough to assess the survival rates. And if you look at the risk factor, you can still see the benefit of the upfront cytoreductive nephrectomy. And if you look at the 2023 guideline and addition regarding cytoreductive nephrectomy, it goes like this. As for poor risk patients, the guideline is to refrain from CN. As for the intermediate to poor risk patients, the sunitinib alone is non-inferior compared to upfront CN in patients with MSK-CC, intermediate and poor risk who require systematic therapy. And deferred CN after initial systematic therapy in good responders, patients might be associated with good OS. And if you look at the role of CN in the immunotherapy era, the data came out in the 2021, and the population was 331 IA alone, and IO plus CN group was involved. If you look at the results, if the surgery was included, the OS benefit was statistically meaningful. If you look at this upfront and deferred nephrectomy, there was no statistically meaningful difference, but deferred group had better results. It had less upstaging and more downstaging. But when it comes to the timing of the CN, there had been no predictors of favorable outcomes regarding the CN timing itself. And this is the data that came out this year. The target therapy population is big with 437. And performance status was good. And IMDC risk was favorable and better in surgery group. And in two groups, we could see survival benefits, but there was no difference between CN and no CN group. And this is the result summary table of the CN data related to immunotherapy. It says the survival rate improves when surgery is added, and some of the results are statistically meaningful and some are not. In this study, this shows us sarcoma node and randomized renal cell carcinoma, the data was not that favorable, but in the surgery group, OS was better. And as was mentioned before, although not significant, deferred nephrectomy showed slightly better results. And if you look at the ongoing prospective trials, many of them are trying to conduct this deferred CN technique. So good responders will be randomized to conduct CN and use nivolumab. But then, despite that, why should we go for upfront CN? I believe that we have to look at the Carmena study. In 9 years, from 79 centers, 450 patients were recruited, so 50 recruited per year, and every center had 1 patient overall. And in France, about 300 CNs were performed a year. And surgery candidates were not included, and they got surgery somewhere else. And also, the poor risk patients were included a lot. This is something that we have to note. And also, if upfront, we can defer systematic treatments. If we can surgically remove the primary or oligometastatic disease, and there is no evidence or minimal evidence of disease, we can delay the next round of systematic therapy. In the luncheon symposium, Professor Chung gave us a case. For example, when a patient gets RN and IVC thrombectomy and enter metastectomy, and we can use 1 year in the meantime before we have to go to another systematic therapy. If you look at this case, this is a 66-year-old male patient, hypertension was there, and performance status was good, and IMDC was the intermediate. Renal vein thrombus and the huge missile, and we can see the changes in the imaging, and for infusion and lung metastasis are visible. To this patient, systematic therapy would be necessary, and we can consider surgery as an option. But the sensory motor polyneuropathy happened, and paraplegia hit this patient, and currently he is under care. And because of the very severe complication, the patient cannot go through additional rounds of treatment. So sometimes the drug cannot always be a benign method. And also we have to think about quality of life. The survival itself is really important, of course, but QOL is also important. When it comes to CN patients, 37% suffer pain and hematuria, and 27% suffer general symptoms. Through surgery, we can solve 91% of local symptoms, and through CN, we can also improve paraneoplastic syndromes as well. And after surgery, many say they could improve the anemia and so on and so forth. So the indication for upfront CN would be performance status. It should be good, and the disease should be resectable. And as for the drone, it should be primary tumor focused on kidney, and the patient should be symptomatic. These would be the ideal indications. So to conclude, in the metastatic disease, systematic therapy is very important. However, CN still plays a very important role, I believe. But as for the optimal timing, I believe that there can be multiple debates. Every patient case is different from one another, so we need multidisciplinary discussion as to the optimal timing of the CN. This encapsulates what I wanted to say throughout this presentation. So what we need is the risk group classification through a multidisciplinary approach, and we have to look at the symptoms and pathologies of the patients and include all of these factors in estimation assessment. And if the risk is poor, we have to avoid surgery, and we have to look at the if the performance status is good, and if we're going for upfront CN. If we're considering upfront CN as an option, the limited metastatic burden and symptoms related to kidney tumor, and patients with good performance status would be ideal candidates. Thank you. With that, I'd like to pass over to Professor Kim Jong-won from Seoul National University, who will talk about deferred CN case. We are afraid we are running behind the schedule, but if time allows, we will conduct some debate. Thank you.
펄드 쪽에서
As said, I'm going to talk about the deferred treatment. I think that what I'm going to talk about is about the same with what the previous speaker said. But let me have a look at the subgroup analysis of the camera study. After the sunitinib treatment, in 40 patients, deferred refractomy was done. And then it was compared to the one without it, and overall survival was much better in the group who got the nephrectomy later on. But as for this comparison, upfront and deferred was not compared. Rather, it was compared whether nephrectomy was done or not, which means that there has not been no head-to-head comparison made between the two. Deferred or upfront was now compared in conclusion. Here, the larger scale analysis was done. Sunitinib was treated, and then deferred CN was done. Compared to the other group, upfront or non-deferred, and this group got much better overall survival outcome. But it was only for those patients who were on the sunitinib, and now refractory, we need to redefine what refractory means. So when we have a look at the experts' review, they are about the same, but it says that for the patient selection, what matters is the IMD risk group and the metastasis burden. Systemic therapy should be used first in this group. Intermediate risk factor, if two of the risk factors are present, upfront systemic therapy need to be given. For the rest of the group, risk factor is only one or meta burden is low, then the upfront nephrectomy or cytoreductive nephrectomy is recommended. ASCO EAU guidelines, when I combine all of them, this is the combined guidelines or recommendations. Frontal cytoreductive nephrectomy, the definite indication include IMDC risk factor 1 or less, and metastatic site only 1. But personally, synchronous MRCC from the treatment and diagnosed treatment, it's kind of within 1 year. So I believe the risk factor could be not only 1 but also 2. After the CN, complete resection is achieved or very low metastatic burden is left, and active surveillance is recommended for this patient, and for this group, the surgery can be done. Systemic therapy is recommended for this group. IMD poor risk group, and among the intermediate risk group, if the major organs is metastasized, then the systemic therapy is recommended. And performance status of the patient need to be taken account, and surgical morbidity. And as for the case that we shared, IMD risk number is 2, and metastatic site is 2, which is kind of in the gray zone. However, the patient has a massive pleural effusion, which means that systemic therapy is favored for this patient. Systemic therapy, and if we have the patient which is in the gray area, what shall we do? It's not an easy case for us to make a decision. But for this patient, the patient progressed after the first line. And at that time, TKI was the first line option, to our regret. Let's talk about this patient, 69, male. There was a huge mass in the kidney and multi-metastasis. It was a clear cell type. IMD risk factor, he had 2, but it was asynchronous, which means that surgery is indicated. However, there was too much metastatic burden, and Infinip started to be reimbursed, so we decided to put the patient on the combi. And the follow-up, lung nodules were all gone. And the mass in the kidney, the size has declined. So in 2020, robot-based cytoreductive laparotomy was given at the first CT. He achieved the CR, which has been maintained up to now. Adverse event, from January, he stopped nivolumab because of the AE, but still the efficacy has remained, which is quite promising. And we have IO medications made available, and if we use the IO therapies, the CR rate continue to increase. In the combination therapy group, the CR rate has dramatically increased. And in all proper patients, they would have been converted to the patient group that can receive surgery once we use IO. If you apply systemic therapy, such kind of delay, we tend to concern about the patient once they are delayed for the surgery, and this shows the mortality risk, which increases if the surgery is deferred by about 1 month. So that kind of fact concerns us. That's why we wanted to put the patient on the operating table without delaying. And this is a table that shows different group. CRPRSD, the percentage of that, remibrutinib, pembrolizumab, it was above 90%. What does it mean? Even though the patient is put on medication first, the progression is witnessed in a very small number of the patients. So you don't need to worry about losing the chance to do operation in the patients because the IO therapies have a very good outcome these days. So in the clinical setting, we can use a systemic therapy based on IO first and then do the deferred nephrectomy later on. So we check the response to the medication first and then do the deferred surgery. That's the widespread trend of these days. So since we use IO first, so for those patients who are in this gray group, they move to the left of the low-risk group. And personally, I believe that that's the right time for us to have the operation. And for the poor risk group and very, very massive tumor patient, in those groups, once we put them on IO medication, the size may be reduced and may be possible for us to do operation once the tumor reduces. Another case, a 35 male patient. When he was presented to the hospital, the presentation was about the same. The first case, there was a huge mass on the left kidney. There was a thrombus in IVOS image. Very young, performance status was good. So in the past, the thrombectomy might have been given to this patient, but when we have a look at the profile, IMD risk was 3, and surgical mobility was concerned. So we put the patient on the ipilimumab first. 4 times combo therapy was given, and then there was a dramatic PR. and he was put on maintenance for this. A CT follow-up image showed that on the long axis, the size has been shrunken to less than 1 centimeters. So later, in February, the patient got the operation. IVC thrombectomy was done too. R2 resection was done, which means that CPB was not done. Liver mobilization was minimized. IVC was amputated to get out the thrombus. We were able to do so because of the recent literature says that IVUS thrombus in the CT, if there is a visible change, we have to check the final pathology. IVUS pathology, in 70% of the cases, it was negative in the end. So we did the IVC thrombectomy, and here we see there was no viable tumor cell in the IVC thrombus. By doing so, we were able to minimize the complications. Then what about the IVC thrombus? The leftover, it may progress. That's what you might be concerned. When we have a look at the series of the studies, SBRP is quite effective. In such a case, SBRP can be used. And SBRP and other ablation techniques are very advanced, so you can use it after the nephrectomy. And multimodal treatment can be used, and one of them is SBRT. And as for this patient, CR was achieved in the first follow-up. In July, the whole body PET, there was no abnormal hypermetabolic lesion found. In conclusion, in some of the patients, cytoreductive nephrectomy is indicated, but for the rest of the patients, we are not sure optimal deferred nephrectomy supplied or not. SWOG and Nordixen, such other clinical data should be accumulated to get the answer to the question. Avengers was released years ago. Back then, what was hot was a second generation AR targeted agent, and docetaxel, the front line, has been put on the second or third line. AR targeted new generation agent would replace the first line treatment. That was what we discussed back then. And MRCC is an area where we can talk about this. We have immune therapy, which has much less adverse event with much better efficacy. So now, cytoreductive nephrectomy can be applied in the later stage, not in the early stage. But from the surgeon's perspective, cytoreductive nephrectomy, it's a kind of a last puzzle or weapon for us to achieve the CR. So its importance still remains. That's what I want to say. Thank you for listening. Thank you very much. Sorry that we do not have enough time for us to have discussion.
네, 지금
We have listened to good presentations from IOI medicine is being used, and at this regard, about the role of the CN, I believe that we have to rely on a lot of data from the retrospective studies which show that CNs do play a role. And when we talk with a lot of doctors, this, after all, CN is necessary. But it is about when we perform CN and to whom we perform CN. If the patient is not poor risk, we can combine drugs and surgery. And as for the right timing for CN, I think it is always a controversial topic among doctors. I believe that your presentations gave a hint as to what is the optimal timing of the CN. With that, we would like to wrap up the first half of this thematic session. Thank you.
To the state-of-the-art lecture. The first lecturer is David Nikolai Shivili from American Hospital, Tbilisi, Georgia. He was graduate from Tbilisi State Medical University in 2000, and now he is a vice CMO of American Hospital in Tbilisi and head of the urology department. He will give us the lecture about surgical treatment of the renal tumors. Please.
Dear chairs, dear colleagues, thank you for the possibility to give me a chance to make a presentation in such a wonderful audience. Previous presenters were focused on very locally advanced disease, and my talk will be about local disease and the surgical treatment of the kidney tumors in local disease. As you know, I'm from Georgia, from capital Tbilisi, and in our very historical city we have American Hospital more than 2 years, and me and my team are working in this place. The renal cell carcinoma, we know about this very detailed information. We have a very detailed information, and there are only mentioned that annual increases the incidence of worldwide in Europe more than about 2%. Vast majority of among these tumors are RCC, and based on the TNM classification, the 5-year cancer-specific survival for renal cell carcinoma, especially in early stages, T1 and T2 is much higher, and even when the tumor size exceeds 10 centimeters. Before the surgical treatment, I would like to mention the role of renal mass biopsy. The rationale is the revealed histology of radiological indeterminate renal mass and can reduce surgery for benign tumors and associated short-term and long-term morbidity. The indication is prior of active surveillance of small masses, before ablative treatment, selection the most suitable medical and surgical treatment strategy in the setting of the metabolic disease. Role of renal mass, as I mentioned, in experienced centers and in experienced hands, the diagnostic core biopsy for the diagnosis of malignancy is very, very high, about almost 100%, but it could be not diagnostic, about 20%. In such cases, repeat biopsy or surgery is mandatory if it is non-diagnostic. Surgical treatment outline, I would like to talking about nephron-sparing surgery versus radical nephrectomy and localized RCC, partial nephrectomy techniques, partial nephrectomy in solitary kidney, and nephrectomy in multifocal renal tumors. Partial nephrectomy, the same and equal NSS, nephron-sparing surgery, and the absolute indication is synchronous bilateral tumor or multifocal tumors. A tumor in an anatomical solitary kidney, presence of a poorly functional contralateral renal unit. And other indication, all T1 and T2 tumors, whenever technical, this is feasible. This is a history, and everybody know that Cherney, Winfield, the names of Getman, who firstly did this open laparoscopy and robotic, and by me and our team in Georgia first was done laparoscopical partial nephrectomy in 2010. Most studies comparing the oncological outcomes of these diseases are retrospective. The oncological outcome in the term of the cancer-specific and overall survival following partial nephrectomy equals that of radical nephrectomy in T1 RTC. Partial nephrectomy preserves kidney function better, and the long-term potential limits the indication of cardiovascular disorder and development of end-stage renal disease. And small mass in the presence of normal contralateral kidney can be performed safely with slightly higher complication rates than after CC. Nephron sparing in T2, this is more unclear right now, and we have no enough data for this. Estimated blood loss and postoperative complication during this surgery is not favorable, but there is more favorable tumor recurrence and cancer-specific mortalities. These Kaplan-Meier charts show us that partial nephrectomy versus radical nephrectomy, their overall survivals and cancer-specific survivals is much better. Based on this data, we have recommendation in European Association of Urology guidelines, and the recommendation is that we have to offer partial nephrectomy all T1 patients, surgery achieve cure in localized cancer, but there is very weak recommendation that T2 tumor and solitary kidney or chronic kidney disease, you have to perform partial nephrectomy if it is feasible. And now about techniques, open versus laparoscopic. There is no difference in progression-free survival, no difference in overall survival. The main estimated blood loss lower with LAP. Postoperative mortality is similar. Operative time longer LAP. This is nowadays very discutable because in skillful hands, it's quite different results. Warm ischemia time is shorter in open. This is also very discutable. Long-term effect on kidney function is very debatable. Open versus robotic, lower estimated blood loss and shorter hospital stay in a robotic manner. And warm ischemia time, operative time, immediate early and short-term complication, variation of certain levels on the pathologic margins are similar. And now laparoscopic versus robotic. Perioperative and short-term oncological functional outcomes appear comparable in experienced hand. This is literally similar. Robotic may have a lower rate of conversation to open surgery and radical surgery, shorter warm ischemia time, smaller changes in estimated GFR after surgery, and shorter lengths of hospital stay. This is a technical difference in lab. This is approach trans or retroperitoneal. No difference in postoperative complication. No difference in positive surgical margins. No difference in early and late GFR levels. Complication rate slightly higher in transperitoneal. This is also very discutable in this case. Operative time lower in transperitoneal. And also based on this data, we have a very strong recommendation. Offer laparoscopic radical nephrectomy to patients with two tumor and localized masses not treatable by partial nephrectomy. Don't perform minimally invasive radical nephrectomy in patients with one tumor, and don't perform minimally invasive surgery if the approach may compromise oncological function of the perioperative outcomes. Partial nephrectomy in solitary kidney. Tumor and anatomical and functional solitary kidney is an absolutely indication for nephron-sparing surgery. Optimal preservation of kidney function and complete oncological clearance is a key. If performed minimally invasive, should be restricted to select patient performed by expert surgeons. Ablative therapies with a partial nephrectomy may be an option in selective patients. And in this chart, with this trial, we show there is shown that current radical partial nephrectomy is favorable than other techniques in terms of outcomes. Partial nephrectomy in multifocal renal tumors. As we know, there is metachronosally incidence about 25% in patients who present initially with sporadic ipsilateral renal mass. And more than from this value and cohort of patients, more than 75% of multifocal lesion may be missed on perioperative imaging due to the frequent small size of the satellite lesion. Multiplex renal nephrectomy requires exponential surgical expertise. Technology such as intraoperative ultrasonography should be available. It is not technically feasible to achieve a wide margin for every tumor. No clamp technique needs to be applied whenever this is possible. And partial nephrectomy in multifocal renal tumors. Most studies show that partial nephrectomy does not increase the rate of tumor recurrence and does not adversely affect cancer-specific survival. This take-home message is the same which we mentioned above in our recommendations. And I would like to also mention that laparoscopic management, surgical management of renal kidney tumors, localized tumors, are very prominent in our hands and in our clinic and in our set. Thank you very much for your attention.
Thank you. We have 5 minutes to discuss of this.
자, 그러면 이 주제에 대해서 5분 정도 토론할 시간이 남은 것 같습니다. 질문 있으십니까?
Dr. David, I have one question about the multifocal tumors. I think there is a very several important point or the biggest hurdle for the multifocal tumors, and I think a limitation of a number of tumors and the kidney function, pre-op kidney functions. Do you think of what the important things in multifocal tumor resections?
Multifocal resection, you are quite right, and we have to evaluate the patient. This is very important comorbidities. And kidney function evaluation of the GFR at the first and evaluate the second normal kidney also. After that, we have to evaluate morphometry. How big is the tumors and where they are situated, and how we can make a strategy to resect these tumors. And also there is a main role they play the experience of the surgeon. If you are more experienced, you can take more difficult cases. And the type of surgery, there is a resection, a nuclear resection, or wide resection. Also, in such cases, I strongly believe that in multiplex tumor and lesions, we have to use nuclear resection because the results with nuclear resection, a partial enucleation and nuclear resection, the data and results are the same.
Thank you. If the patients have a VHL disease, and then you usually do a multifocal partial nephrectomy?
Okay, and in such case also we have to prepare patient for the previous time and dialysis because it could be happened with this ischemia time. If there is possible to use non-clamp and clamp-less technique, this is much easier for preserve the kidney function, but this is difficult and anytime it is impossible. And so we have with us any armamentarium, technical preparedness and skillfulness to do this complex surgery.
Thank you very much.
Thank you.
Thank you.
now move to the next topic. Next lecturer is Yoshihiko from Niigata University, Japan. He was graduate from the Niigata University Medicine, and now he is a director of Niigata University Medical Dental General Hospital. Please.
Okay, thank you very much for your kind invitation to the KUA annual meeting. So on behalf of the KUA, I congratulate the great success of the KUA 2023. Thank you for moderating this session. So, Dr. So, that's the long time no see. Hi. So, I'd like to talk about some systemic therapy of the kidney cancer, KUA. Niigata City is located in the west coast of the main islands of Japan that is famous for some very good cuisine, including Japanese sake and sushi. And also they have a good shell and yellowtail, that's shabu-shabu, that's very nice. So, thank you for the some Korean there. That is get started again. That the direct flight from Seoul to Niigata City. Welcome. Okay. Anyhow, so in Japan, that is the 2008, the cytokine era, the 2008 to the 2015. That is we have a bunch of these targeted drug, and cabozantinib will come a little bit later. But that is right now that is the combo therapies, tablets and TKI that's available for the clinical scene. So we have to choose the proper way that this is some first-line treatment for each patient. So content is like this, but only the 15 minutes, so that I may skip some part. And we make sure that some present the status of the overall survival. So this is the very small size that is some clinical data, so the Japanese patients. That is but it turned out really clear. If we subject to this nivolumab as the second line or later, that such patients can survive at over than the 70 months. 70 months. And nivo-ipi as a first line, median survival is not reached at this moment. So we can conclude that maybe we have to think over that this over than the 5 years for the patients for that systemic treatment. We frequently talked about the life expectancy of the old patients, but maybe that we have to count for that is 5 to 6 years. So the meaning that is that if the treatment is good for 3 years, doesn't mean nothing. I mean, we have to think about it 5 or 6 years later. Okay, if we talk about the duration of the response, so there's some brand new that is the combination therapy. The things we can say is that it differs from one to another. I mean, IO doublets, nivo-ipi, did not reach the the duration of response median. And the other hand, that is IO-TKI, this is around deep into the 24 months. So that the ASCO meetings, I really, presented at the keynote 426 and also the 5 years analysis and also for the PenLen, that is the clear trials, that is 4 years. And it turns clear that is the median, duration of the response is not elongated. That is similar to the previous reports. That means the only 2 years is good for that, maintaining the efficacy. So if we talk about this PFS, I'd like to tell you about this, how to evaluate PFS, not only the numbers. The figures of these survival curves is very important. If we put some numbers for these kind of tables of these median PFS, in such case, okay, that this treatment is good for because it's a very larger number. But if we take a look at the shape of this PFS, so for example, that the nivo-ipi, that is 60 months, 5 years survival, 5 years they follow up. So you can see that right here and right here, that says, left arrow has located the 24 months, that is 2 years. And the right side, that is 66 months, meaning that is around 4 years. 4 years, this curve doesn't drop. Yeah. But on the other hand, if we take a look at the IO-TKI, you can see that right here and right here. The left, arrow has located at 24 months, and the right side, DSM 42 months dropped. You can see it. So that if we think over such a status of the patients, no progression is very good. Right tail of the PF curve is very important. That is the right tail plateau phenomenon. It's observed among the other types of cancers, like melanoma or kidney, lung cancers as well. Besides that, is interesting things is observed in the IO doublets right here. This is the Siemens burst in the left side, and that you can see it is all over the bars, the meaning that there are some CR patients. In the right end, you can see that there's a very tiny arrowhead right here. So meaning that is the efficacy continues. Meaning that is almost all, let's say that 70–80% of the patients can, continue such a response at the end of this observed period. In addition to that, this is a blue line, meaning that it's no treatment at all. So meaning that no treatment, without treatment, that is such efficacy can prolong it. So hazard migration, this is another issue we have to take care of. Because this is the runners, some tables which presented the 2021 ASCO meetings. You can see that this the pembrolizumab, the first report is the hazard of 0.53, but the second report 0.68. That is the third report 0.78. That is the this year's meeting is 0.84, meaning that is the some efficacy that the some systemic therapies that decreased, right? So in the other hand, Ivo-Nipi IO doublets maintained at the similar, that is the hazard ratio, that is the around that is 60 months. If we put that is such a hazard ratio according to this median follow-up, the prolongations, this is the x-axis, it is the median follow-up, and there's the y-axis, it is the hazard. So IO-TKI, that is the tend to increase, that is the, that is the hazard going up. But in Ivo-Nipi, this is, this plateau. So we have to think about that such, how can I say that there's the quality of the response. In addition to that, the CR, that is the complete response is very good. However, that is rate. You can see that there's a figures, every kind of figures right here. But if we think about the DSM, how can I say that the quality of the response. So we have to be careful about this kind of CR rate. CR rate is the based on the best response, meaning that is if the patients have the DSM recurrence after the CR, in such case that is we defined such patients CR. So we look into the some details about the clear publications. That the CR 13 out of 61 CR turned to the PD, and 3 out of 61 that is subject to the new treatment, meaning that that's maybe real CR rate is there around 12%, 12.7%. Another doctors talked about this that the systemic therapy in conjunction with the surgery, that's the talk. And so you have to be very careful with the quality of the such a response. So a little bit on the other hand, Nivo-Ipi CR continues. So rapid progressions. I'd like to talk about the rapid progressions. If there's some patient appeared in front of you, that is, of course, you'd like to control that is tumor enlargement. So let's take a look at the 6 months after the initiations of the treatment. Right here, you can see that this drop, that this is Nivo combinations, that identical for their comparator, meaning the sunitinib, meaning that that this no superiority of Nivo-Ipi to sunitinib for the cases of the progressing by 6 months after the treatment initiations. On the other hand, if we take a look at this IO-TKI, you can see that the gap right here, this is the PEN-LEN combinations right here. and nivo-carbon combinations right here. So the gap of the such survival PFS curve, meaning that that's the IO-TKI combo have efficacy to prevent very early stage progressions, possibly due to the some potential difference of the sunitinib and other TKIs, but that is the reality. So how we decide that that's the choose of the some first line? So comorbidity or background of each patient is a very, very good point, and we have to consider it. History of the autoimmune disease, in such case, we have to avoid the IO doublets because of the higher percentage of IRA. And so on, and in a higher age, in a Caucasian or that is 65, that is even higher age, but East Asian, this is completely different because we are, our average, the life expectancy is much longer than that. So I conducted this, analysis about the 75 of the age right here, VAXI, that is the Javelin Lena 111, that it did not turn out really clear the VAXI combo is good for this, even that the patients in a higher age and over than 75 years. And in addition to that, you have to think about this, whether or not tumor is immunogenic or angiogenic. And in such case, that this, you can choose the proper way of the IO-TKI or IO-doublet accordingly. So I just skipped the contents, but we conducted some investigations and reported in the scientific reports in the last year. That's using the multi-modalities of the analysis system. It turned out really clear that the CD8 and the CD68 positive and the CD4 negative is good for some prognosis patients subjected to this IO therapy. Right. And I'd like to show you the two cases. 75-year-old male, that is the CAT scans for the anemia that revealed the left side, the kidney cancer. And the IBC thrombus, and here it is, that there's some CAT scans right here. So this is the high risk and the poor risk, and both of the score. What would you like to do? Our choice is that to choose that the IO doublets right here. And this is the first biopsy right here, that you can just take a look at this pathology right here. So, and then that is we subjected these IO doublets and shrink some primary site, and also the lung messages disappeared. It's good. However, 12 months, 24 months, and 30 months, and 33 months, new regions appeared besides of these primary tumors. What would you do? Would you like to do? Salvage nephrectomy, of course. We are the urologists, so that it turned out really clear that is the pathology is completely different from primary ones. You see that it's from your experience of the cancer recurred in another part. In such case, that the histological grade is going up, but opposite side. So primary side is grade 3, 4, but there's a recurrent side, grade 1, 2. So our hypothesis is that these clones is resistant for the immunotherapy, but on the other hand, very simple kidney cancer, angiogenic. So that is this is the very indolent findings. So that yes. So this guys is very good for the over than the 6 years, and this is free. Okay. So case 2, that is the right here, sarcomatoid, 56 years, and subject to this nephrectomy from another hospital. And then that is, you can see that the local recurrence right here, 3 months after the nephrectomy. So what would you like to do? Goes that the pathological report that the primary site that the representing that is some sarcomatoid features. So we think about that sarcomatoid is good for the some Evo and EP combinations right here, because higher response, better prognosis, and so on. And the subject to the Nivo-EP combination therapy, and this 6 hours later, so the beginning of the Nivo-EP combinations, my phone, cell phone is rung, and there's proof that still awful things happened. That is shock vitals and went to the ICU. Yeah, 6 hours after first dose. You say that. Drastic, increase of the some pleural fluid and also mid-shift to the mediastinum. So thanks to the intensive care, that he returned, but died of the day 18 because of the IRA, opposite side of lung. Okay, so the things I'd like to say that is that don't believe that the paper data to choose that the practical treatment. You have to take a look at this patients. So unfortunately, the time is running out. So that I discussed a lot. I'd like to discuss a lot, but I'd like to end up. But I'd like to show you that this one figures which proposed is that is the Dr. Brown. That is the this year's 2033 the ASCO meeting, very close to our thinking. So if the local therapies is good for this such disease, oligomets, do it. And then that the second thought that yes, IO doublets, choose IO doublets. This is the very dangerous part, as I told you. And no, in such case, require rapid response like backbone mets close to the spinal cord. In such case, that you have to choose the IO-TKI. But like to have that's a longer period of the response. In such case, that is you choose the IO doublets. Patient like to have that this free of disease and the durability of the response. Not very transient responses mean nothing. This is the last slide takeaway that the use of the doublet. So I'll take eyes that he has a higher response and promising results. However, we have to be very careful to the look into the some data which appear in the not only for the papers but also the conferences as well. So surgery, as the former speakers mentioned about it, we have to choose the best timing. Thank you very much.
Thank you. Now we close this session because of the time limits. Thank you very much for joining us. Thank you.
네, 안녕하십니까. 바로 진행을 하겠습니다.
Hello, we would like to swiftly begin along with the Professor Che from Aja University. I will be moderating the session. I am Yoon Sang from Gyeongbuk University. So the first topic for the semi-life surgery is robotic simple prostatectomy for large BPH, and we would like to have a lecture from Professor Bae Ung-jin from the Catholic University of Korea. Hello, I am Bae Ung-jin from Catholic University of Korea. Today, I would like to talk about robotic simple prostatectomy for large BPH. As for the robotic simple prostatectomy, it was first reported in the year 2008. The voiding dysfunction specialists are not involved. Rather, oncologists are doing a lot of robotic surgery, and they are familiar with this, so I believe that they were the starting point. Experts in the voiding dysfunction are not involved in the robotic simple prostatectomy that much, and I believe that is because of the HOLEP, which is another big weapon that they have. Open prostatectomy and HOLEP are chosen as the first-line treatment for the more than 80 centimeters, so that is the guideline. But then we're increasingly talking about robotic simple prostatectomy, and I believe that cost is the biggest reason behind this. HOLEP is a good surgery and surgical technique, but it is not reimbursed in the surgery. So, and also the minimal invasive treatment is increasingly becoming a thing, and patients who would be confused to have this BPH surgery with this cost. Now increasing though, the robotic system can be used for BPH, and indeed the patients who want to get robotic simple prostatectomy for BPH is increasing. So I'd like to talk about the history of the prostatectomy, robotic prostatectomy, and I would like to compare this against HOLEP to see the advantages and disadvantages, and I would like to discuss the potential patient indications as well. When it comes to simple prostatectomy, it was first introduced in the 1800s or 1900s. There was this gentleman called Arthur McGill, and he is known as the first surgeon. And Prayer's technique is known as the first technique. He published a document, and that is why we know Freyr's technique better than the McGill technique. And as for the Freyr's technique, we go transphysical approach. As for after dissecting abnormal tissue, in the past we didn't have laparoscopic or robotic systems, so using our finger, we hold the dissected part and try to cut that out so that we can remove the prostate. As for this, we open the bladder, and we need some time to wait for bladder to heal, which is one downside of this technique. But to complement this technique, a surgical technique came up, and which is retropubic approach. This is oftentimes called Mullen's technique. This way, we can avoid opening up the bladder. Radical prostatectomy before laparoscopic robot system has robot RP. So we secure space first of all and open anterior capsule of the prostate, and once again utilize finger and the clockwise direction and the counterclockwise direction to manually see and remove prostate. In this open technique, we have to do multiple incisions, and with the hospitalization days for patients increase, this is the downside of this technique. But these two techniques can be assisted by robots. When it comes to Mullen's technique and Freyr's technique, both of them, in later stage, we can use laparoscopic system to go for transperitoneal approach and retroperineal approach. I have prepared two cases which utilize Freyr's technique. I have 78-year-old male patient, and because of severe LUTS, he did not respond despite repeated medical treatment. The residual urine was not that big, but voiding symptom was very significant for this patient. The MRI showed 80 grams of size, and PARAS was 2. Aside from BPH, there was no findings regarding cancer. When it comes to transphysical approach is taken in Freyr's technique. So we bladder filling with saline, and we apply incision in the dome area. Transverse cystostomy is oftentimes applied in the vertical line, along the vertical line. And to make sure we can see the bladder neck, we conduct cystectomy, and after that, utilizing Kiss needle or Kata Thompson needle, we suture it to attach it to the abdominal wall so that we can make sure we can see the inside. Professor Bess, sorry to intervene. It's semi-live. And the panelists are invited to provide a simultaneous comment. So I would like to invite panelists up to the stage in the meantime. Then I will carry on. Thank you. So we apply incision in the bladder neck, and between adenoma and surgical capsule, we have to dissect them and get a space. Normally, bilateral urethral orifice from the 6 o'clock position, we begin. As for this patient, medial lobe was not that big, so for the enucleation, we started from the upper part. Adenoma and the boundary area are enlarged here in this video. As for HoLEP and enucleation surgery, if you are known to this, you can avascular plane, and you do not have to rely on energy devices that much, and you can clearly dissect this area without relying too much on specific energy devices, I guess. And counter-traction is very important. So sometimes third arm is used, and adenoma tissue is sutured to pull it in the other direction. This is one thing we can try. And sometimes we use Kettle-Thompson needle to provide a traction using needles so that we can lift up the adenoma tissue and pull it in the other direction. This will help us to identify the boundary between these areas. Professor Bear, so you're not using third arm that much? Yes. No, I don't. I'm showing the two cases where I didn't use third arm. For the surgical convenience, it helps, of course. But as for the simple prostatectomy, we have to think about the cost aspect as well. So if we can do surgery without third arm, I think it helped. I think not relying on third arm helped. Going on, so starting from the 6 o'clock position, we start incision and we approach it laterally. As for this case, it was actually smaller in terms of size from the one we identified from MRI and TRUST. So the boundary between the edema and the capsule was not that big. So I used energy device quite much and quite a lot. So it feels like I kind of dug deeper. In the back, you can see that the boundary is getting less and less clear. If you visit apex, you get near the urethra and poly is in there. As you dissect your way in, you can expose poly and urethra, and you can identify the tip of them. And at the sphincter part, you can identify sphincter. Here in the apex, a poly is exposed, and we're dissecting areas surrounding them. Normally, minimal application of energy device around apex helps to prevent incontinence. So if you reach apex, I believe that cold seizure would be a better idea in this area. Whereas the bleeding is severe, so I couldn't find the indication here. After specimen retrieval, from the 5 and 7 o'clock position, usually we find a lot of bleeding. If coagulation does not happen well, we have to suture them so that we can provide bleeding control in the 5 and 7 o'clock position. And before trigon, we pull urethra and do anastomosis. Trigonization basically takes place in area between 5 and 7 o'clock position so that we can reduce and remove that space and do blood control, bleeding control. We can do traction suture this way. Starting from the 7 o'clock direction, I'm going toward 5 o'clock direction to do continuous suture. Let me fast forward a bit. And Vlog suture here. I didn't tie because it is fixed already. I'm about to show you some reports done in overseas cases, and to minimize the space here and the lateral sides, 360 degrees anastomosis is sometimes conducted. And to close the bladder, we suture muscle layer and mucosal layer in the continuous pattern, and we use Vlog suture here as well so that we can easily close the bladder. And after continuous suture and after closing the bladder, we once again close the peritoneum with suture. This is how I finish out. As for the consult time, it was 85 minutes, and as for the estimated blood loss, it was 150 milliliters, and he was discharged on the 4th day, and as for the Foley, it was removed 10 days after the discharge. And as for the second case, he visited me because of the AUR and hematuria. Sorry, why did you leave Foley for about 10 days? Is it usual? No, as for the next case, actually, he had 5 to 10 days, and we consult with the patient to decide when to remove. As for the second case,
오픈 수술을 한 경력이 있으셨고 PSA는 8.4 정도 체크되었고 AUR 소견이 계속 반복이 되었습니다. 트러스에서는 캔서가 의심되는
The cancer was suspected. No, there was a hypoechoic, and the volume was 88. Sigmoid colon cancer OP history was present. So extraperitoneal approach, perivesical space was dilated and secure the space inferior in front of the bladder. We open it. So Milling's technique, transcapsular, we may use that approach too, but we may do dissection on the bladder only, and once we do that, cystostomy can be done. That's the approach that I used. Carter-Thompson needle was used to do the direction of the Foley. Once you do that, median lobe, ureteral orifice, between the two, you can find the border. Ureter orifice and median lobe, between the two, you find the border. You have to confirm it before you access adenoma tissue and capsule. The border between the two can be found too. This is avascular plane, like you do in the HOLEP, and access laterally to gain an easy access. From here, capsule and anatomy between the two. When you do dissection, do you have any good tips on working it? As for me, lateral pubic is I use for the most of the cases because it's much easier for me to do dissection. Yes, I know. Yeah, you can find the border much better. So when you do take this approach, it's going to be difficult for people to, or doctors to find the border. As for lateral pubic, I saw other doctors do that. I have not done HOLEP that much. I did it a few cases, but as for the HOLEP, surgical plane was confirmed, and they go to the bladder neck, or from the bladder neck from 6 o'clock, you go along the line to get the very good plane. So anatomy-wise, the access is similar. So this is what I prefer for the reasons that I mentioned before, with the Foley in apex down to apex. You just follow it. Once you find the border, you can just proceed. In fact, intraperitoneum approach and retro approach, whenever I have a look at that, I think that suprapubic approach is more intuitive. When it comes to post-op care, retro is better because it has a shorter hospital stay. What do you think? Based on the anatomy understanding of that, what do you think is more intuitive? I agree. That's why I kept saying you that this is similar to that of HOLEP. And when I was resident, laparoscopic surgery was what I observed, and my mentors and senior doctors did it this way. That's why I prefer this approach, because this is what I have seen and learned. And inferiorly, between 5 and 6 o'clock, trigonization is done, and bleeding should be controlled before you complete the surgery. And other than those points, there is a little difference between the two. Surgery-wise or skills-wise, and CIS-port, you have only port, and you have 2 robot arms. I did RIFE in the past. I used third arm and assist port as 12 and 5 millimeters. With those, I can find that the excision plane much clearly, and I can see the urethra clearly. It has a lot of ups or good points. And can you tell me the reason why you have less ports? Is it the cost only reason? Yes, that's cost is the only reason that I minimize the number of ports that I make. The more ports that we have, the better view we have. When you do the traction, before that, do the scoring, then you can minimize the opening of the bladder neck. I do not have that many cases, but I will just try based on your advice next time. This is the case. As for the operation time, it was 65 minutes. A nucleation was done well. And on day 3, poly was removed. There was no problem after that. As I said, last year, Daniel Eun, Professor Eun, presented lecherous prostatectomy. He made a video presentation. Transvesical approach was used, and bladder was not dropped. So he talked about the benefit of using that approach. Once we minimize the prostate, then we have enough space and there is a room for bleeding. But he did full running suture and did the watertight anastomosis to prevent that from happening on apex. Sphincter injury, to minimize it, we need to go along the line of the apex of the prostate. So we have to pay attention to the angle. That's what he said during his presentation. That's quite impressive. As he said, retropubic milling technique. Recently, urethra preserved so that ejaculation will remain. And benefits of a milling technique is not, we do not need to maintain Foley for long. And we have a data on that, and Dr. Zhou is doing in this video. This is like a Milling's approach. Anterior commissure around that urethra can be preserved. In order to do that, adenoma on both sides, he removed it one by one separately using the third arm. Sutured adenoma is extracted the opposite side, and the urethra in the middle is preserved. Contralaterally, urethra has some laceration. That's why he is doing suture. When we spare the urethra, the paper says the ejaculation function will be maintained much better than the standard approach. Let's just skip. And Dr. Zhou recently published this paper, which says that continuous bladder irrigation and polycatheter insertion time is much more reduced once we take this approach. And robot-based SB and HOLEP are compared. In 2020, European Urology published this paper, which is interesting. Endoscopic enucleation compared to the robot, this is better. Or the robot is better than the HOLEP, and the cons and pros were presented in the same paper. Endoscopic enucleation, those people who prefer it says that less invasiveness and shorter stay of hospital, and then natural orifice transluminal surgery. Those are the benefits of using that approach. And you do not need to do robot. That's what they said. But those people who, or doctors who prefer robot-based approach, said that endoscopic enucleation can be done without injuring the urethra. So as for the robot, simple prostatectomy, catheter time-wise, you have to maintain it, stay longer, but learning curve is kind of shorter. And cost-wise, this organization or medical center says that it's about the same, which is different in Korea. Robot and HOLEP is compared in this meta-analysis. Functional data, IPS score is improved and flow improved, and both of groups had a better outcome in those parameters. There is a little difference between the two. However, as for the RASP, it has a longer stay of a hospital, more expensive, and it can be a burden on the patient. Urethral structure and sphincter injury rate is lower for the RASP, so compared to that, it has such benefit. I have shown you the videos, so let me summarize. Transvesical approach, after that, when you do the suture, bladder neck bleeding should be controlled well, and then triagonization was what I mentioned. Apex and urethra thermal injury is just something we try to avoid as much as possible. And litigious sparing surgery, it can minimize damage to the urinary sphincter and improve the postoperative continence outcome. Once 360 anastomosis can be considered to minimize the dead space. And urethral sparing simple prostatectomy, it can preserve or help us preserve ejaculation function and shorten the time until Foley catheter removal and shorter hospitalization days. When it's compared to HOLEP, both of them can improve the outcome, but cost-wise and hospitalization stay and urethral stenosis, incontinence, and bladder stone and diverticulum, if the patient has comorbidities, you have to choose one out of two, taking all these into consideration. Thank you for listening. UDS, you didn't mention no abnormality to report. You do HOLAP, right? Robot 2, you do both. That's right. For which patient do you use HOLAP? For others, RASP. What are the criteria on which you make a decision? I started to do HOLAP not long ago. Green light laser, we had one of them, and then the machine went broken. That's why we introduced HOLAP. Recently, I'm not used to doing HOLAP. So after enucleation, the oscillation risk should be taken into account. If we take that into account, robot surgery is simpler and easier for me to do. Yes, HOLAP has a concern about oscillation. We usually up to 80 gram, HOLAP is okay, but above that, we are afraid of using HOLAP. Yes, comorbidity. If there is a bladder stone, you may believe that you can remove it with the HOLAP. As for the bladder diverticum, using the robot approach, you can remove it. And as for the transvaginal approach-wise, and robot is better. Urethra sparing for the case, medial lobe, it's very difficult to remove it. That's right. I asked the same question to the senior. MRI and image should be taken first to check the median lobe, where locate the median lobe. Laterally, you have to remove laterally and then go inside to find the median lobe and do the suturing and pulling it. And before you have to pull in order to take it out. Thank you.
Any other questions or comments from panelists? Yes, let me just offer my thoughts. BPH and LUTs and their benign diseases. And minimal invasiveness is really important when we think about surgical technique. When it comes to robot simple prostatectomy, we do not know completely if it can be categorized as minimally invasive, but in BPH and LUTs, many compare HOLAP against robots. And minimal invasive technique that is mostly used is TURP actually, but we don't compare TURP against robots. We sometimes compare TURP HOLAP or HOLAP versus robot. So in a nutshell, what I think is this. Although not clearly set, if larger closer volume, we are going HOLAP from TURP and from HOLAP to robots. I think that is the tendency. If it is 100 milligrams and above and reach 150 or more, HOLAPs can be used. And when it comes to TURP, experienced surgeons, I can do TURP for 120 milligrams and above. But minimally invasive techniques on a step-by-step basis are becoming a thing and getting upgraded, especially for patients with large prostates. And the prostate volume of BPH, I believe, is getting larger and larger. Maybe that is because I'm at the general hospital, university hospital, but I believe that in the past, we thought that 60 milligram was the medical treatment threshold. But having said that, I believe that robot simple prostatectomy would be preferred over to HOLAP because the prostate size is getting larger and larger. And also, let me just add my thoughts on that. Principally speaking, the robot technique is a good technique to me. It can mimic open surgery, and that was the biggest benefit of HOLAP. And we can remove adenoma from the area that is closest to sphincter. However, in terms of the size, I know that there might be controversies, but I don't think the size is the only threshold or criteria, be it 150 or 200. I don't think that should be the criteria on which we decide whether we have to go for robots or not. I believe that we can use HOLAP for like 200 milligrams. I believe that the biggest indication for RASP is the patients where it is very inappropriate to go through urethra. In this case, sometimes urethral stricture can be big and when you use HOLEP, and when the patient has a penile prosthesis, the approach itself is very limited. And in this case, I think RASP can be used. Rather than I go for Miller's technique, usually, because I believe that that way, when we spare urethra, we can maximize the benefit of RASP. It is not that I have published the paper or something, but I believe that that way I think we can achieve much more stability. Now, I just wanted to offer my observations, but having said that way handling median lobe got trickier. But removing medial lobe means that we will open urethra, and it will create a whole lot of problems to me. So I did apply this technique to those people who had big lateral lobe, but I believe that your technique that you have shown us would be beneficial going forward. But I have a question to Professor Bang, actually. You provide this report and AP dissection was clearly done, but when you got near to sphincter, what was the margin? Sometimes sphincters are more visible and less visible depending on cases. So I try to be very conservative even when I use HOLEP. And Dr. Kim, I'm sorry. If time allows, I can give you the microphone after listening to the next presentation in surgery. But when you do urodynamic VP 150 or 200, when there's a risk, we conduct RASP. And if the patient is old and we have to think about incontinence risk, I believe that RASP would be helpful. That is my thought. With that, I'd like to go to the next presentation. So as for the second presenter, it is Professor Jung Sung-jin from Seoul University under the title of Transurethral Inoculation with Bipolar Energy Using Spatula Loop. This is similar to HOLEP, but then instead bipolar energy was used. Over to you, Professor Jung. Hello. Thank you for being here. I'm not used to sitting down and speaking and giving a lecture. I thought about standing up, but it would be weird and I didn't want to stand out, so I would just sit myself. Anyhow, I conducted 200 HOLEP cases and then started to use tube technique using spatula loop. Let me share some of my experiences regarding this technique. As you're all aware, the TRP is the gold standard, but when it comes to inoculation, in terms of HOLEP in particular, it is a size-independent gold standard, and bipolar energy is increasingly used to do inoculation. We are seeing a report about this case. Bipolar generator, or depending on the loop used, multiple terminologies can be used, and we do not see a clear consensus regarding how we should call this technique. But generally, when we use spatula, I believe that tube, TUEB, is used a lot. And if we use plasma kinetic energy, PKP is also used. When it comes to tube, it was first introduced in 1912, and the bipolar energy is used. And the cutting loop, on top there is a spatula, and we push with this spatula to do dissection. In the early days, the population size was small, and follow-up duration was low, but the efficacy was turned out to be good. And after that, we conducted longer term follow-up and conducted the study, covered larger number of population. 2-year follow-up showed us good results. And as for the complication, 1% and less hemorrhage, and at 3 months, transient incontinence, 3%. So complication-wise, the result was good enough. Depending on the electrode loop or the generator device, sometimes you can use oval button loop or plain plasma loop. And there is this Herman bipolar system which uses cuneiform probe. So there are multiple names. So I tried to sort things out and give you a neat summarization. But when we compare tube against polyp, we are used to TRP. So with that, since tube is similar with the movement that we have in TRP, it is a merit to us. And in terms of bleeding control, TU has a merit over polyp. And also we can do resection in the middle of the procedure. So we can do a better job in managing daughter adenoma. And also when we encounter a problem doing tube, we can just directly convert to TURP. So let me show you a case, 69-year-old male patient, and despite medication, the symptom score was high, and there were 3 times of retention, and trust size, it was 105 and 82 cc. And in the urodynamic study, the bladder capacity was small, and the terminal end was big, and pressure flow study showed obstruction with the index of 60. The technique itself is similar. Similar issues found in HOLEP are the issues that we can find from tube as well. The bladder and the anatomy of the prostate should be first explored. And we have to see the distance from the sphincter and mark urethra. And so we believe that this is the sphincter, and there and in the 2 side lobes we mark the 2 lobes and the sphincter. And after marking is done, we start urethra incision. We go to the area where are believed to be the distal end of these lobes. In the past, I just dissected all my way down to the visible area, and my incision was deep, but transient incontinence got prolonged when I did that, so I stopped before getting too deep and marked there. As for this patient, it is not the case, but if the size is too big and if the pressure is too strong and irrigation is poor, in this regards, we use a 6 o'clock and 12 o'clock direction and do trans-enuclearization just like we do on flaps. And if the median lobe is very big, we do median lobe enucleation. But this was not the case for this patient. So utilizing spatula loop, I am beginning to do enucleation. It is important to find a plane. I'm going deeper in this case. I think I did wrong here. I think that is the right plane that I have to go. So I push my way in. Movement-wise, I'm trying to sweep my way in or rotate my way in while rocking, and that way I can see the capsule plane. In the 3 o'clock direction, I move up and continue to dissect. I once again push my way in to expose the plane. I'm not a good surgeon, but I think I can ensure better visibility than I was doing whole-lip. And better visibility means better wiggle room during operation. So I think that is one merit. I think that is the median lobe. And utilizing one lobe technique, I'm just pushing my way on and getting in, sweeping. So you apply 2 loop. No, in this case I did 1 loop. You see, you covered left, right, and median. Yes. If the size is too big and if the irrigation is poor, that way I apply longitudinal incision and apply this separately. But if you look at the vessel, you see perforation, and you see vessels from capsules, and you see some vessels embedded in capsules, and sometimes they would bleed. We just target that vessel and do coagulation, and it works better that way. When I did whole-lip, coagulation was always difficult. I sometimes failed after multiple attempts, but I think it's way better when I do tube. Is there any limits in size, in terms of size, that you learned from your experience? 120, 150, and I think size-wise the limit is the same from flap. But what I want to tell you is that if the size is larger, angle-wise it gets steep, and that means larger possibility of urethral tract, and that means higher possibility of incontinence. So if the size is larger, I think we're gonna have to spare urethra and maybe try robot surgery. And I think in that regards, we're gonna have to build more experience in research. And I'm approaching bladder neck. This is the 5 o'clock position. If you look at the bottom part of the bladder neck in the position between 5 o'clock and 7 o'clock position, I didn't know about the clear anatomy about this structure, but transitional zones and the central zones overlap. As your work way in, you can find this overlapping area. And sometimes you can remove central lobe altogether. And after removing central lobe, the capsule is quite thin. So when worried, when there's a concern, I believe that you have to resect and remove some of the central lobe so that you can keep this thin area intact. And you have more perforated vessels found here. You have the fibers all tangled, which means that you block the plane. And also it makes it difficult for us to do enucleation or dissection. In such a case, you have to do insection before you do dissect. Sweep movement is what I'm doing right now. Going all the way, bladder mucosa is what I encounter. As with whole-lip, size-wise the bigger, and if the shape
When I do the endoscope surgery, I believe the shape is important too. Inferior to the bladder neck, if it's stuck, then maintain the bladder neck and do the dissection upward. And doing it is quite difficult. You have to do a lot of traction. Even though you apply some force, it's going to be difficult. Then you have to take the antegrade approach using robot. On bladder neck, the mucosa is being removed. When you do that, sometimes you may have bleeding. First of the cases, I got the bleeding, which was originated from the bladder neck. So before you do the mucosa dissection, you have to do coagulation. And then do the cutting. Up to the 3 o'clock, right side and left side were done. And on the right side, I'm going into the bladder neck using the same approach. When you do the hold-up, if you do not feather the plane, you just push it. But now, if you are lost orientation, what do you do? That's the difficulty that I had in the early days. Hold-up has their strengths. Vibration allow us to get a sense, but we do not have vibration. So if you have a wrong entry, it's going to be complicated. If you do not have a right plane, you have to push gradually. And if it's pushed gradually and smoothly, then it's the right plane. So it has some learning curve. Yes, it's quite some long learning curve. 4 o'clock, 7 o'clock, and 8 o'clock, I believe that you can find the bladder neck. When did you work on 12 o'clock? I will. Do you think that I have done it? So do you work on 12 o'clock first? With whole left, right, and 12 is the marking that I give first. And then I draw the line, for the 3. The bigger, if the size is bigger, I do that to take the approach, but otherwise, this is what I do. Bladder neck, 6 o'clock. And now the 6 o'clock, physiological curvature. In this direction, you have to maintain it as much as possible. That's what I have learned in school days. There is some kind of sphincter too, so maintain the physiological curvature as much as possible so that you can help the continence to be maintained. 9 o'clock, bladder mucosa is dissected right now. Bleeding, whenever you do find bleeding, do coagulate or cauterize this way. Tissues are mingled or tangled. In such a case, do the resection and dissection as I do right now. As for me, I do hold-up mostly, and other doctors do TUEB, but there's a difference. As for our doctors or surgeons in our hospital, they move around very frequently, but as for you, you do not have that much movement. Here, I do not have that much bleeding. I have only some of the embedded vessels that leads to bleeding, so I didn't need to move that much 12 o'clock, apex area is where I am doing dissection right now. There is a big major vessel, which means that I have to do coagulation before I move in further. Resection I have shown you, and I'm doing resection right now. Enucleation plane, if I have a clear of that, resection is not required that much, but as for the bladder neck, if the tissue is tangled, I have to do some resection. After coagulation, bladder mucosa is cut. From time to time, tissue and adenoma and capsule are all tangled, intertangled. In such a case, resection should be done. Sphincter, 12 o'clock, you haven't worked on it. I'm going to work on it in the last leg. Okay. Apex coagulation, when I do coagulation, apex, I tend to be very alert. I try to coagulate the bleeding point as much as possible. I went to the to the right side. Starting from 9 o'clock, I go to 12 o'clock. Bleeding point is coagulated. Bleeding control is being done. We have 5 minutes to go, so can you wrap up? Yes. Enucleation is almost done. At the end of that, 12 o'clock and 6 o'clock, mucosa is all is left behind. So 12 o'clock mucosa is being worked on right now. 6 o'clock, the mucosa is attached to that, so I am just working on it. After the enucleation, the adenoma and mucosa, it's all linked, it's all connected. Apex-wise, urethral mucosa, I try to have it maintained as much as possible intact so that it can have a better impact on the continence. So here, I remove some of the tissues only, and this is done. Enucleation is done. This is the usual approach that I do. What I wonder most after the surgery is incontinence. And the papers say that you have to apply the pressure and check. If the stream is stopped right away, then continence will be better post-op. This is what we have published and reported. In conclusion, I have shown you the TUAB surgery procedures, and as for different procedures, they are similar in terms of efficacy But depending on the energy, the outcome may be affected. So we have to study or do the clinical study on that. So complication-wise, which one will be better? That's another area that we need to look into in the future. With this, I'd like to conclude my presentation. Thank you. You do TUEB, not HOLAP anymore. In 2017, I did the last HOLAP. I see. I think that you are at a different level of performing TUEB, right? You are very good at. What about HOLAP? I forgot how to do HOLAP. As for the TUEB and like the TURP, if you remove all the chips, you can finish the procedure very much quickly and early. Yeah. I try to finish with the oscillation. And let me ask you this question. When we have a look at the case of the second one, PSA was very high. The baseline was high. PSA went up to 12, but it left untreated. It may go up to 18. What do you do before you operate? Do you do biopsy first? Biopsy and procedure may be done at the same time. If you find a cancer later on, it's going to be a problem too. So what do you do? Before the operation, I do biopsy all the time. And PMRI, I take it from time to time. What about PSA? What is the cutoff point? Biopsy indication. If it's a biopsy indication, I do biopsy. I do MR all the time. And if it's a gradation between 4 and 14, I do biopsy too. I do it at the same time. At the same time, yeah. On the operating table, you do it at the same time? Yes. What about you, Dr. Jung? I have all the patients referred from other doctors, so they have done it beforehand. But if a biopsy was done years ago, and then if the cancer does not change my plan, then I do it at the same time. But if not, I do biopsy before the operation. I do take MRI image beforehand. So check the image. And depending on the reading, I will do biopsy if it's located laterally. If it's transient, then I will do just operation right away. Thank you so much. With this, I'd like to conclude this session. Thank you. Thank you.
반갑습니다.
Hello. Good afternoon. So we're slightly behind the schedule, so we will jump right in. So semi-life surgery 2, pediatric part is about to begin. We have invited 2 surgeons who provided us with their surgery video, and I am Lee Sang-dun from Busan National University. Hello, I am Baek Min-gi from Sungkyunkwan University. As for the panelists, we have Mr. Song Sang-won from Osan University, and Professor Lee Jun-young from Gyeongbok National University, and Professor Kim Do-sung from Soonchunhyang University. So let me introduce you to the first speaker and moderate the first part of the pediatric session, and the second part will be moderated by Professor Beck. As was introduced, the first presenter is Professor Park Kwan-jin from Seoul National University. When we do hypospadias, the QWERTY becomes sometimes a big problem. And after puberty, we have to consider the changes and corrections about QWERTY, and we have to carry out operations considering diverse elements. First, we would like to look at the video first, and while we watch the surgery, if panelists come up with a question, please do not hesitate to throw them. And while we watch the video, we would like to stop and answer the question as necessary. So we would like to begin. First of all, thank you for giving me this opportunity to share my surgery with you. This is 12-month-old boy. Testicle were available for me to touch. I mean, they were available. And as for other diseases, they were negative. We injected testosterone twice and got surgery. Gave surgery. Let me just play the video and give you some more explanation. If you pull the penis, you can see the hole here, orifice here. And as for the pegging, I just go in the middle, horizontally. If I go vertical, that means opening is asymmetrical. I do calibration first, multiple times, and insert the catheter of appropriate size first. Before surgery, did you measure the stretched penile length, or did you do measurements of the penis? Yes, usually I do, but I was filming, so I was running out of time, so I couldn't. Normally I do, but size-wise, the cutoff rate is about 13 to 14 centimeter. If it is smaller than that, I sometimes inject hormone first. Proximal types do not actually give a boost to size. So when it comes to proximal, I just go and jump right into the surgery sometimes, skipping the hormone stage. So we can see the urethra. I'm inserting the catheter. As for the scrotum level, you have to find the urethral at the scrotum level to make it visible. We're making pegging suture to wide open the scrotum. And I sometimes mark for primary incision. When we mark, this podium can be hurt. So we do installation so that I have enough space before cutting up here. And sometimes I try to use the bobbin to hit and find the urethra. Saline epinephrine were used at 1 to 100,000 ratio. I'm making incision. If possible, I always try to be mindful of urethra and stay away from it when I make incisions. Extra sharp Colorado tip is used to start dissection. And holding skin, when assist hold skin, sometimes they do a poor job, so I do pegging suture. With the pegging suture, I lift this up and until I can see sponge area, I hold up the urethra and slowly do dissection. I do not start from the up, but start from the bottom. Finding healthy urethra is easier when I try to go up. Because if I go down, starting from the up, sometimes it bleeds. and it gets very difficult. And following this white line, I go and make a shallow dissection. So as for the bobbin, it's cutting current? Yes. The size is about like 8 to 10 centimeters. You can see urethra, and following this line, keeping this intact, we are trying to go in, but here it bleeds, so it is okay for you to just use bobbin right away. And this is the area where chording is the most severe. You can see healthy urethra, penis, and the area where the hypospadias took place. This is the area where the chording is severe, the most severe, so we have to do an extra work. And in the dosum size, we do a marking, and when you just hit with a bobby, you can just cut too much sometimes. So you make sure you create a space first before hitting the spot with a bobby. In the field, I am surprised because you are doing the surgery without this bleeding. When you use knife, sometimes it bleeds a lot. Just try using bobby. Actually, it can help you like minimize and control bleeding. And you do not have to heat it very quick. Take your time and do this slowly. So you are doing chordectomy, and we are going down from up, keeping urethra and cutting this part. Using scissors, you hit up here, and it can sometimes hurt the penis. So in this case, I try to use knife and provide a sharp dissection. And in case it bleeds, I use bipolar to control bleeding. And here you can see healthy urethra, and you can see spongiosum. And here in the middle of this area, you go in and do dissection. You are planning for PRP surgery? No, be it TIP or be it staged, it is same. I always start dissection, and I look at erection and curvature, and then I decide for the next step. I start with the exposure and then decide what to do. I do not plan before I go in. I sometimes start dissection with the urethral opening, but you are starting from the scrotum side and trying to get deeper. I think that this would have its own advantage. So in your opinion, dissecting from the urethra and the dissection from the video, are there like surgical like techniques, surgical benefits you can expect? When you start dissection from the urethra, you have to find an opening and start dissection from that area. That's what you do commonly. But if you find wrong spot, bleeding will occur, and troublesome bleeding can happen. And this is one downside of this. And also, in the hypospadias urethra means it's defective urethra, and that means since it's defective, it is very thin and weak, and sometimes tissue is lacking there, or they're insufficient. So when you do TIP, you have a very hard time. So I first try to find a healthy urethra and follow along the healthy urethra, and that way you can save your time not doing marking. Be it distal or be it proximal, you can do the same. Instead, if it's distal, you can start from the middle of the penis. That's one thing. From the dorsum side, you can see carbonosum, and along this line, I do dissection with bobby. Mr. Che scolded me when I use bobby, but I think bobby is still my preference. You can see carbonosum here and skin, and you dissect this area in between. For this dorsum side, vascularity is all longitudinal. So separating all this and doing one by one is beneficial. When you just use it, when you use mass and hit it all together, you can just remove the vascular altogether. So I prefer to hit one by one. We separate all these longitudinally and just handle one by one. This usually takes about 30 to 40 minutes. In tough cases, maybe an hour. But after an hour, in most cases, this part is over. And to pull out the penis, as for the hypospadia, if you think about it, that means chances are there will be problems regarding migration. So at the scrotum level, many of them are stuck together. So you add some more dissection here in this area. And sometimes that way you can pluck out the penis. And that way you can stretch out the penis slightly more. As for the concealed penis, you can try the same approach. Spongiosum, carbonism here, and this is the dissection line. And while doing so, you can reach muscle. This is the proximal extent of mine. So if I see the muscle, I see that, oh, that is it, and I do not go further. So I open the remaining area in the dorsum part. So the box should be remaining here, and abdominal dermal tissue should be left here.
이런 경우는 페니스
In this case, ligament should be dissected a bit more, and 12 o'clock pachyparalenx should be prolonged. We do it from time to time. Do you apply that to 12 o'clock fixation, dorsal side fixation? I'm scared of doing that because we have a neurovascular bundle. You may injure it. So I do not fix it at 12 o'clock. I do fixation ventrally, very deep, down there. I'm going to show it later on. Curvature is evaluated with the tourniquet in. What matters most when you insert the tourniquet is this. Normal spongiosum, you have to go near that, not above it. If you go above, it's going to be okay, but it's going to have a problem later on. When you do the curvature test, you may see that this is straight, but later on there is a curvature. As you see, there is a curvature, right? It's curved down. And using the gonometer, you check the angle. It was about 60 degrees. Urethra is cut. This is the first approach. Defect by urethra, spongium is cut off. Transection, you go very near to the glans. When you do that, very good question. If you do it very close to glans, then when you cover the tissue, then it's going to be wrinkled too much. That's what I did in the past. Once you cut it, you have to move it upward as much as possible. That's what I thought, but it was not good. So I do take the middle approach. I do apply in somewhere in the middle, not too upward. This is box. Dartos is removed, box together, and then inside it, you have a very, very slimy or smooth tunica exposed. you have to go down as much as possible so that the curvature is removed 100%. Urethra, laterally on both sides, it's attached quite tightly. So you have to cut it like this. Along the line, you have to cut the tissue as much as possible, and it's going to have a significant bleeding. 30 degrees is a kind of a cutoff point, or acute angle of a 30. Personally, 36 degree, I do not believe in any angle or number. What you need to do, check is a ejection. How much curvature is made at time of ejection. If it's too curvature, you have to work on it more. Those are flexion. If you do that, it will get shortened later on. So as for this kind of small genital, then I do only the distal, not the proximal. Rather, you have to cut here and then widen the ventral side as much as possible. That's the right approach. Dissection is done quite well. There was a bit of bleeding. Proline is used to do the suture to prevent bleeding. Another option is bipolar. You look very clean now, but from time to time I get major bleeding too. Ventral sap is curved a bit, so I believe that it's much better to go downward. But at that time I thought that it was enough, so I completed the surgery. Penoscrotal transposition is what I want to show now. After operation, when the patient complained, I did it. But I believe it was much better to do it when you do the first stage operation. The reason is this: you have to get the shape when it is on. And the patient or parents do not want to have another surgery. After the first operation, if the shape is not happy or pretty, they are not satisfied. So you have to get it in the right shape and educate the patient to do so. The approach that I take is this: the penis and scrotum, penile skin should be mobilized and make a hole and then move it upward at once. Penoscrotal transposition is done this way. Usually it's pulled down, but I pulled up. I pull it up. This is the skin, and abdominal skin and scrotal skin are visible there. And proprietary skin, dartos, is shown, visible. And then you can extend it. Extend the line and find the line carefully. Here, dartos is shiny. And a bit by bit, it can be movable and move upward to the abdomen. Can we speed up? Dartos is clearly visible, so using the same approach, I will proceed. Contralaterally, I do the same. Here I make an incision. Penis, proprietary skin is going to be moved up to this point. Or it's going to be relocated. If you make a too big hole, you will have it pull down, and then you have to do emergency surgery again, then you will not have a good outcome. So make the right size of the hole. Here, the peripheral skin dartos, you have a separate bloodline for them. And with that in mind, do the dissection. PST is corrected in the middle. Why? If you make the urethra first, you do not have skin or tissue enough. You have to use a flap or buccal mucosa. Graft should be made to cover it, which does not have a good outcome in the end. I do not use a flap anymore. That's why I use this kind of two-stage approach. Philadelphia scholar said that the flap outcome, the long-term outcome is not good. 70% complication can occur. So post-op success is not the end. As for this case, in order to prolong the length, corporotomy is not done. No, I didn't do that. Verrica should be done first, and then if it does not work, open it, and peripheral skin grafting can be done. Corporotomy, once you do the corporotomy, the defect is around 1 centimeters. As for this kind of defect, do you use a dermagraft approach or allograft or other approach? In most cases, these days, tacocom is what I use to cover it. And with that, diabetic formation, the ejection may be affected. You may wonder that, but no. Erection, no, it's not affected. I don't know. We haven't followed up until adulthood, but vaginal graft, I used it before, but as for the tunica, it is basically closed, so that cannot be used anymore in the future. So in the second stage, tunica vaginal flap cannot be used later on to cover it. So tunica should be left as a last option, last resort. So tacocom is the first option that I use all the time. I'm gonna speed up because we don't have enough time. The remaining dartos is sutured together, and then you have to cover the skin. Urethral opening was used to create this, and I'm doing the fixation. And the rest of it is a tedious skin covering process, which is not that important. You have to cover it 100%. What matters most is that you have a very big hole, which means that you have denture here. How to improve it? You may use an inverted suture to lift it up or make the right size. Wherever we have a scrotum, wide scrotum, you can cover both laterally, but it's not pretty. So, as for me, I make a big incision and take this approach. This is a two-stage, right? This is a two-stage approach. As for you, one stage and two stage, how can you tell one stage from the other? The different proximal hypo, I do not take one stage. In most cases, I go for two stage because, to be honest, the complication rate is 40 to 50% when I do one stage approach. Once we have a fistula, you may do resurgery, but when you do have a fistula, the skin melts down. it's going to be very complicated and hard to fix. That's why I'm taking this two-stage approach. If possible, flap, bias flap was used. In my case, clicking suture is what I use. So at the bottom, you just attach it at the bottom, like a graft. That's right. As for the flap, I believe that it can survive, but it's not pliable over time. It lost the pliability. That's right. But I think a flap will be okay. It will survive. That's right. Yes, in most cases. But if it's stuck, 12 o'clock, it's going to be easier for the second stage operation. This is what I'm doing. What I'm doing is a tie over dressing. Double bond is what you apply right now. Yes. Wound complication on the scrotum, I do not use a bond that much. I'm concerned about it too, but as for the dermal bend, it's very good. It's very effective. It has less complication. 1 month after the op, it looks like that. It has been maintained. The shape is good. This one is a bit rotated, but once you apply the ointment, it can be flattened. As for the dressing, how long do you maintain? 5 days. And then ask the patients to take a bath and then discharge it 2 to 3 days later. And ask the patient to take the bath once a day, and after 2 weeks, I stop the antibiotics and apply ointment to control the scar. As for this patient, pre-op, you did the injection 2 times, right? And TIP was what you planned. I thought that you would go for 1 stage, but this is 2 stage. And before the first stage, do you take the testosterone test? And or for this case, for the first stage, testosterone is not used, and then use it in the second stage. What is your strategy for that? For the scrotal hyperplasia, I do take the 2 stage. Sometimes I skip it, skip the test, skip the testosterone.
But if the urethra stretches out and if 1 stage is possible, if glans is small, the success rate is really low and you cannot just close it down. So after 1 or 2 times of trial, I'm not that active in trying that way. But even when you plan for stages, you give testosterone before 1 stage. If it's small, if the size is small, I inject testosterone. The total number of injection and administration is important. I don't think the timing matters that much. And I think if the total amount of number of administration is okay, it will work. Yes, we have 1 more minute to go. We began late, so we will take 1 more question before we move on to the next video. Thank you for this clean video. Be distal type. If I believe that I thought that it was corrected, and if these kids hit puberty, sometimes this recurrent cord can take place. When you did follow up, sometimes these kids see bending, and I come to worry about if I have to go revision or not. And these kids, puberty kids, do not have to worry about like sexual life at that stage. So in this regard, how do you decide if you go for revision surgery or not? And that's a good question. In the spine position, this is the angle you will see. This is not the right angle, actually. This is not ideal. When lying down, the angle should be 80 to 90 degrees. And this is the first month post-op, so the contracture came, and that is why we are seeing that angle. And if you just address buttress by urethra, it will just pop up and straight sit up. But if the angle remains the same in follow-up, he would not be able to urinate while standing up. And even when erection, the shape itself would be dangling down, so we have to correct it. And sometimes kids, their penis is straight with the tip curving down, only the tip curving down. In that case, we just conduct observation and see if the curvature gets severe if the kid hit puberty. And as for the recurrent curvature in hypospadias, in many surgery cases, suture creates contracture in the suture site, and this creates anchoring, and with this anchor site, the curvature takes place. And sometimes we can fix this problem by hitting the area, but when you just tackle that in the puberty, it's very difficult because you have to cut that out. So I think it is better to tackle this issue before the kid or patient hit puberty. Yes, thank you. We would like to wrap up the first video and move on to the next one. And the next session, I will be the moderator. The second video we're about to see is about the single-port robotic pyeloplasty in pediatrics, and the surgeon is Professor Lee Yong-seung from Yonsei University. When it comes to laparoscopic robotic surgery, he is the most active surgeon in this area for pediatrics. And when it comes to single-port robotic pyeloplasty, I think he was the first one in the world to report the case. Thank you for the warm and generous introduction. I am Lee Yong-seung from Yonsei University. It is not that I'm doing a new surgery. I am just trying the old technique with a new device or equipment. So rather than this surgery video, I thought that it would be better to show you docking and how we can apply this to kids. That's what I would like to focus on. And as for this case, it's a 3-year and 9-month-old kid. This was the youngest patient I have ever had. As for the SP surgery, as for the multi-port surgery, actually, I conducted diverse MP surgery on diverse patients, but when it comes to SP, it has limitations. So he was the youngest case of mine for SP case, and I added some incision site, and that incision case is for another patient because I wasn't able to film the incision stage of the surgery for this young kids, so I did incision bit from other patient's case, just a note in advance. This differential renal function has been maintained, but in the recurrent right flank pain came back and the surgery was planned. After general anesthesia, RGP was conducted, and in the UPG area, pinking is noticed. So we are trying to mark the incision site. The 2.5 to 3 centimeters of long incision would be needed. Rotating the umbilical cord, and we often say we split it. And in that case, we can get 2.5 centimeters. We use SP ports, and on top of the ports, I place diverse equipments before I go surgery. So I open peritoneum, and I try to put the device into this cavity. And after insertion, I remove the device. This is SP access port. This blocks the airling. In the attached area outside of the abdominal cavity, it is attached, and we can get fixture from the two sides of the abdominal wall, which means we can reduce the airling, and the red mark will remain, but after 1 or 2 days, the red mark will disappear. So you see bowel being pushed out, and on top of that, you attach this device. What is the diameter of this device? It comes in two sizes. What I'm using is about 7 to 8 centimeters. For adults, I think I'm using the larger one. So I docked the robot. I wanted to tell you about this floating docking system. In order for the SP equipment to work properly, from these protruding parts, we need 13 centimeter long space. And in pediatric patients, we cannot get this much space. So we have like external space about 3 centimeters or 4 centimeters outside the abdomen, and that is called floating docking system. Because the maximum length we can get until UPJ is about 6 centimeters. That is why we use floating docking system. When we do laparoscopic system, we measure the length actually from the navel belly button to UPJ. It was about 9.5 centimeters or above. We did some calculations, and even utilizing floating docking system, we can make sure that SP systems can be applied to kids over 7 years old. And as for kids under 4 years old, I think SP cannot be applied. And in between 4 to 7 years old, we have to look at each case, because in some kids, applying SP can be tricky. So I usually use SP surgery for kids above the age of 7. So you can see the airing and collapse of the airing of the floating docking system. I will skip this. So you can see that the device is literally floating. From the umbilicus to UPJ, the distance is short. We cannot help it. But pubic area, sometimes we created ports so that we can decrease the distance, right? Can we try this? You mean hardest technique? Yes, we can have a suprapubic approach. But when we do SP surgery, the biggest advantage comes from cosmetics. So applying incision outside of the belly button, I think this kind of decreases the merit that SP can provide. So I go for laparoscopic if I have to do that way. When it comes to assist port, you can see the assist port located outside. You can keep the video on play and you can take questions. Is there any question from the floor as well?
Ask the floor.
So at the cobra angle, you created head. I'm trying to just enlarge my visible area. As for these tools, if I'm pushing these tools out, there's no problem. But if I'm trying to pull these devices in, because of the short distance, I'm facing some difficulties. So this light UPJ obstruction, so I'm trying to take down the UPJ colon. Thank you for the video. At my hospital, I have a SP device, but I'm using MP only. My biggest concern is this. As for adults, over time, the collateral damage on the organ or the needle escaping out of the system rarely happen. But as for kids, they're unpredictable. even when we apply multi-port, if we do a bad job with the needling, sometimes needle just disappears, it flops out. And needles are tiny and very small. And as for small SP, we're gonna have to struggle a lot physically with the patients. Is there any like nightmare experience you experienced with the kids or doing SP? I actually spent more than an hour trying to find a needle while doing MP. I actually remember that. As for the SP, I haven't had any like interoperation difficulties. And when I tried to docking, I found out that the incision size was too small in the belly button. So I once again reopened the incision and enlarged it to be 3 centimeters, and that's it. So docking wise, when compared to multi-port, SP is a bit more difficult, but outside that, I think overall it's fine for me. For me, I always take RGP, and I place ureter catheter to reach UPJ before getting into the surgery. So the catheter is reaching UPJ, and I'm trying to use some water and see the UPJ bending down and try to see and identify problematic area in the OR. The way I see it, I think these are some thin areas, and starting from that, I think this is the healthy area. So if I can, I was planning to make some dissections from this area on.
You are using 2 robot arms, and below that, you have your assistant going through the port. That's right. Have you used a 3rd arm? Yes. Whenever I have a skilled assistant, 2 arm is better. If the assistant is a novice, it's better to use a 3rd arm. Using 3rd arm, when I use assist port, there is a room for collision. So, as for this patient, liver traction can be of help, and holding the pelvis will be of help if I use that. But the more I do, the more I feel that 2 arm is best approach with the help of assistant. Anchoring suture, do you do that on pelvis? I did use anchoring suture all the time in the past, but personally, after the operation, what does the UPJ look like? That's what matters. Anchoring suture is easy, but the shape is not that pretty. The angle is not right. If you do the anchoring on SB, is it difficult? Isn't it? No, I don't think so. Assistant is doing irrigation ureter so that I can check the area which got very restricted. SP seizure is curved as well. That's right. As for the conventional multi-port, the scissors is more straightforward, the straightforward needle, but this is curved. What do you think? When you do spatulation, does it help? I'm going to show you spatulation. As you said, the straighter the better. I agree. But one of the downsides of SP is that compared to multi-port, it takes time to change the instrument. So I get lazy. I do not want to change instrument. Once I use a certain instrument, I just keep using it, even though it's cumbersome at some point. As for SP, I did use it for the adults only. It's rare to use it in pediatric patients. Spatulation is of great importance, but sorry that I'm not doing smoothly because I want to do spatulation without holding the ureter with the left hand. I try to find the right angle, but as for the instrument, I cannot pull anteriorly, so I'm just having some trouble. We do have some bleeding during spatulation, so assistant, once they spray the water, it helps the procedure. Vicryl 6O is used for the suture. I'm changing the instrument. Whenever I do change instrument, we have to set the angles from the beginning, which takes time. It takes such a long time. I just didn't add it in order to tell you that it takes time to exchange instrument. Cobra head. I adjusted the camera angle. When I did Laparo in the beginning, one port was what we used. When we did one port, you need patience. And there is a collision and fighting. And as for the Laparo, there are angulated instruments to help it. Can you compare SP and XI? What do you feel? Is it like switching from surgery to LAPA? Or do you think that this is much easier when you switch? As for the robot multi-port, XI and SI, I didn't use it that much. As for the laparoscopic, I did some LAPA operations myself when I was resident, Dr. Han, and that when they did operation, I assisted them. And until we have the single port, I just avoid doing the suture. But as for this single port, suture is not that difficult. As long as you have the space, you can do a good job of suturing. When you do the suture, when you pull to the left and right, you do not have enough space. So you have to pull it anteriorly and posteriorly, not side to side. After the spatulation, you are using it as a handle for the robot arm. Without cutting it right away, when we do the single port, can you compare the fatigue? Is it better? To be honest, it's more difficult to do the single port. When I did laparoscopic surgery, I was not under that much stress. But when I do single port, I just wonder how much space I can get in child. So that was the main source of stress. Whenever I do the suture like this, how much should I pull the thread? As for the LAPA, it allows me to pull as much as possible, but for the single space, SP, I find it difficult to realize how much should I pull. What kind of thread do you use? Bicrete 60. I think that you may find it comfortable using Bicrete 502. As for the arms, sometimes they might collide. And switching from multi to 6-port, when we do the partial nephrectomy, the arm collision causes the biggest problem because you can move like 2 centimeters to have a scratch on the tissue. So that's my experience. Thank you for sharing your experience. As Dr. Bach said, this is what happened. This is what he mentioned. Right. When the patient is too young and severe hydro, then when we do the laparo, we have the camera in the belly button, and then the port is located near that, and UPD sometimes went down too much. And if you work with SP, you don't need to worry about it. Working with SP is different from LAPA. LAPA has that kind of drawback in children. UPJ, the younger the children, the location may vary. So when you have the image, you can see the relation between the belly button and UPJ so that you can realize where to locate the trocar. But as for the SP, you have to access this way, no matter where the UPJ is located. So it doesn't matter that much. SP system for the pediatric patients is difficult for us to use. There are many medical centers which do not have SP. Even though they have SP, you may not find a chance to use for children or pediatric patients. But as for you, you have done many pediatric cases. How come? Does your department help you to use it for pediatric patients? OBGY is doing much more operation using SP, so I have to wait about 2 months before I had a chance to use it. But as for this patient, we cannot ask the patient to wait 2 months in this condition. So it's kind of varies case by case. So sometimes I can get the chance to use it at the right time. This video was taken 4 years ago. At that time, I didn't find it difficult to use it because other doctors did not use SP that much. The age of this patient is younger than 4, about 3.9 years old. Yes. If you found it very difficult of using it in the first case, you will not use it anymore. So can you share your tip? What will be the kind of ideal age of the patient that we can start trying it? 7 years above, no difficulty. But between 4 and 7 years, you will find some challenges and difficulty, but it's feasible. But patients younger than 4, there will be some contraindications. So those younger than 4 do not have good indication for the SP. As for the double J, you did insert it through the same channel. Yes, through the assist port. And when you press the bladder, you have indigo coming out through the volley. And this tip, the bladder, you've just confirmed the location before closing it. You are doing anastomosis now. One of the strengths of the robot is suturing. LAPA, when you do the LAPA, do you use the same approach, interrupted? Yes, interrupted suture. If the pelvis is too big, I do continuous for the pelvis, but as for this lesion, I did use what you have mentioned. Bleeding, I want to check the bleeding right now. Draining? Do you do the draining? No, I do not use a separate draining system. Does the person discharged on the first day after operation? No, second day. As for Dr. Beck, stent, they place it outside, so remove it very easily. What about you? Do you take it out after 2 to 4 weeks? I do not have any training system left behind. Just 4 weeks later, I put the patient under general anesthesia before I take out the stent. I see. Thank you. Midazolam ketamine is used for the pediatric patient. In such a case, you do not need to use general anesthesia. For the big children, you can have it up to 4, but for the younger patients, as Beck said, you just take it out earlier. Yes, stent can be clogged. It may cause infection. That's right. The younger the patient, you have to take it out earlier. Thank you. Dr. Scola?
Beautiful video, and I was hoping to comment on both. I didn't know when the question-answer session, but as to your the single port, when you use this the floating dock system, does Intuitive make that, or is it made by a different company?
Yet I use the port Intuitive Surgical product.
Okay.
It is called, the official name is SPXS port.
Okay.
Yeah.
And, you know, this is the first time I actually saw someone, you know, such a good video, very clear video showing. It does look like there's a learning curve, you know, and you've used the traditional three-port technique. How much harder is it? How many cases before you feel comfortable with this one? Maybe you're going to show a video.
Yeah. Yes. Thank you for the important question. The red line is my learning curve for multi-port pyroplasty. And the blue line is the SP system. So because I felt some comfortable after 15 cases of multi-port robotic pyroplasty initially, and after accustomed to multi-port robotic system, SP-XS port SP system requires, I think, only 4 or 5 cases. Yeah, because only the docking is different, and the other thing is almost similar.
And if I could discuss the hypospadias one after your slides are done.
Thank you.
Thanks.
예. 이 소중한 비디오를 준비해 주신 연자 두 분 선생님 그리고
Thank you for the great video and the panelists and all the questions from the audience. With that, I would like to conclude this session. Thank you.
네. 아주 재미있는 비디오를 봤는데
The videos were very interesting, but unfortunately we are a bit tight with the schedule, so we like to skip the introduction part and jump right into the videos. So over to you, Professor Park. Hello, I'm Park Sung-hoon from Seoul Prosthetic Urology Center. Can you use the microphone, please? We cannot hear you. Oh, thank you. Once again, I'm Park Sung-hoon, and I am the owner and doctor of the Seoul Prosthetic Urology Center of Excellence. I have prepared a video regarding the implants. So first of all, the first video is reservoir placement. And I'd like to discuss options for reservoir placements. Traditionally, we put reservoir in space here and through the subcoronal approach. Intratubic or scrotal approach are used. As for the subcoronal approach, it was published about 10 years ago. And the approach itself, when compared to others, I'm not saying that they're better than other approaches, but I use local anesthesia mostly. So when using this approach, surgical field itself is not hampered or disrupted that much. So that is why I use this approach. When we do the local injection for scrotum, the surgical field itself gets bloated. So that is why I avoid and try subcoronal approach. A key is here that as for the tartorial fascia, it has superficial layer and deep layer. As for the superficial layer, you dissect, and when you do degloving only on the superficial layer, after repair, the wound adhesion rate increases. In this case, we have to make sure albuminuria is clearly visible when we do dissection. And I believe that it is very important to do dissection on both of the layers. And I think that is the lesson I earned hard. When it comes to peripheral nerve, you don't spare and save the peripheral nerve. Or it is okay because you do not go deep. When there is a fracture, you do degloving, right? And it is basically the same. You do not get to the box fascia, you only get dartos fascia when you do dissection. Sometimes the post-op uralgia comes, and maybe more often when the patient is diabetic. 2 weeks post-op, they come back. And in that case, administration of the gabapentin, about 150 millimeters, it can help them recover better. As for this, in the curved area, it is okay, but as for the expanded area, the proximal dimension approach is very difficult. So, were there any difficulties regarding handling the proximal cross? That was one of my worries as well, but as you could see, as for the doctor's layers before the proximal corpus, if you just make them move away and keep them away and hang together and create a scrotum septum and dissect, supratal layer can be more visible. The proximal layer gets more visible. As for the soprano approach, the surgical technique itself, that is a combination of the 2 different approaches, soprano approach and interpuvinal approach. You do local anesthesia most often, and what is the case for this patient? As for this, I think it was local as well. Under the operation, don't patient report or complain about pain? Yes, they do. What about lidocaine? Is it 1%? Yeah, 1% lidocaine and bupivacaine of 0.75 or 0.5 of dopamine. But pain is subject to different people. So some people say they are okay. Some people complain that they it hurts a lot. And on average, how much do you use? 30 cc's on average. But if the 35 cc's or above, you can get systematic reactions, some disorders, some disturbance in the sensories and so on and so forth. So I try to keep the amounts below 35 cc's. I didn't do serial dilation here, and I did dilation and measurement at the same time. Subchronal approaches, another concern is that coprom itself gets more so distal, and in that case, after surgery, tubing can be popped out, and this can make patients uncomfortable. But after looking at some studies, be it scrotal approach or subchronal approach, the location itself doesn't change a lot when compared against the length of the spongiosum. So I don't think the approach affects the location of the coprotum. So after these processes, in the glands, the complication might happen, maybe necrosis on the glands, and they may partly because of the infection, but sometimes it is because of the wrong measurement of the length of the implants, because people want it to be a bit more ambitious. Then when you measure the length of the implant, do you have any tips as to deciding the right size of the implant? Measuring length, it cannot be rocket science. I'm currently doing state suture, and I measure the length, and at the same way try to extend the penile shaft, and at that time I try to measure the length, and I do not go beyond that because it does not mean the longer implant means longer penis, and longer is not necessarily better, right? So, and here, didn't you do additional laser approach? If the proximal corporate dilation or distal dilation gives me the feeling of fibrosis, I use Brooks dilation up to 12 or 13. As for serial dilation, I think there is a controversy regarding this. As for serial dilation, putting a cylinder can be made easier, but this can enlarge the possibility of other injuries. So if without fibrosis, I do not go for that. As for this, we're trying to reduce space. I'm creating the space here and putting in the device. In the past, I wanted to be sure and used clamp and forceps. I used forceps, but external injury came in, and sometimes this led to reservoir herniation. And I thought that after that, going atraumatic is the best. Once teared up, and once reservoir herniation can happen. So I try to keep the opening minimal as possible. You can put reservoir first or cylinder first, but for me, after measuring, you can know how long, cylinder you can put, and after that you can measure the size of the cylinder. So I usually go for reservoir first and then cylinder. I'm using the product of Coloplast. As for the Coloplasts, the 22 centimeters are available. And here in this case, 70 cc's of reservoirs can be used. And beyond that, you have to go for way larger reservoirs. So you have to measure the cylinder length first and then choose the size of the reservoir. That is what I do. As for this case, this is the atopic reservoir. No, this is the conservative reservoir. So I created this video to compare this against atopic reservoir as well. When putting in reservoir, actually it is very difficult to explain this through video because in many cases this is blind procedure. So I tried preparing diverse videos, but I thought that it is important for you to see the differences. So I prepared this video to give you some basis. I'm using a stage suture. After operation, most of the bleeding comes from the corporatum. So for some surgeons, they try continuous suture to close this up. But for me, after putting in the cylinder, I avoid from suturing this, but because one movement of needle increases the 3.2% of perforation rate of cylinders. So we cannot check if the cylinder is like floating or not. So after putting in a cylinder, I try to avoid from making additional sutures. So the incision of spongiosum, it is very small. It looks small. It's actually 1.5 to 2 centimeters. But usually it's about 2 centimeters and 3 centimeters for me. And this incision size is small and the injection must be difficult, but you're doing a good job. Yeah, I managed to do this. I wanted to minimize the use of threads actually. In Europe, corporatomy stage suture are used twice. So 4 in total. In the States, many were using 2 as long as I found out, so I'm trying to copy their techniques. So in the subcoronal approach, I think the most important aspect is this, pinorexis. When it's rotated and gets dilated, the other corporal will be punctured. And after operation, crossover can happen. So after multiple cases of crossover, I came to pay extra attention to this. So the spongiosum irrigation, it took place, right? Here in this case. Yes, and we could see urethral injury as well, and proximal corpora, Gulf sign should be identified. I mean, we had to check, but I got lazy. Sorry. I kind of skipped. Is it only from this video, or did you skip that in the procedure? Yes, I'm not doing that actually. If I'm suspicious, I do, but if I'm not suspicious and feel okay, I don't do irrigation.
Any difference in terms of infection? No. Irrigating the inside of spongiosum, rather than that, you have to pay attention to contamination. That's what matters more. The source of the infection is the skin. So when you do the draping, you did a very good job. No touch is the approach that you have taken. As for me, I did use wider drape. By looking at your video, I thought that I should minimize or reduce the draping. Antibiotics, we use vancomycin. What do you use it for as antibiotics? The same. Vancomycin, gentamicin is given IV, and once the operation is begun, suggestion Jetta is used. Intramuscle injection is given. Peanut implant after the surgery, antibiotics effective when you give before the surgery. So after the surgery, no prescription required, but patient feel uneasy if I skip antibiotics, so I prescribe antibiotics for 3 days after operation. I use drain in all cases. In subcoronal, it doesn't cause any problem with the hematoma. I thought that draining is not required at the beginning, but there was a big hematoma and there was a big pain causing the pain. And since that case, I use draining all the time. And if you take it out within 1 day, it does not raise infection. That's right. And Dr. from Florida State University, he did some clinical trial and says that, let's say that they did the operation on Friday and did the follow-up on Monday. you just keep it drain. Like on Friday, you did operation and then took out the drain on Monday, but in the drain there was no culture and there was no difference in terms of the infection. So up to 72 hours, it was safe to maintain the drain. If the patient may likely to develop hematoma, then I keep the draining for 1 or 2 days. Otherwise, I just take it within 24 hours. We do not have enough data yet, but I do it based on my personal experience. You do give antibiotics 3 days. I prescribe PO 3 days, but IV anti is given for 1 day. Penile root laterally. Other than scrotum, I believe that's much better, because scrotum, if I do it there can be a wound adhesion. This is what I do, and then the dressing is removed next day. The longer it takes the operation, the longer chances that the patient may suffer from pain. So what is the optimal operation time? There is no study that shows that the longer the operation, the higher the infection rate. But when we have a look at the expert opinion, it says that it's better to finish the operation within 1 hour. This is not my case, but another case in the US, extra vein was ruptured. As you see, you didn't press it that much, but there was a rupture. And tried to stop it, which failed. The vascular surgeon was called in to take emergency measures. Once you have the vein rupture, the patient may die within a few minutes. So the other approach is much safer. Scrotal approach was done. Scrotal approach. I have about 1,700 cases, and among the patients, 60%, they got the enlargement augmentation surgery from another hospital and referred to me later. And those patients who got the enlargement augmentation, I do not take the subchronal approach. I did it once, and there was wound adhesion, which led to infection. Since I experienced that bad case, I didn't take the approach. Scrotal incision, you are doing very down, much more down than I do. As for the scrotal incision, from the penile junction, 1 finger breadth lower is the right position. If you go upward, it can bend and it can lead to the wound adhesion. Incision is lower, but we pull it up to expose it. This is a penile scrotal approach. We have a scrotum incision, but we want to see or expose the penile shaft. That's why we are pulling it. So that's the important point. Incision. Let's say that we have a pure case and longitudinally 2 to 3 centimeters incision. Did you compare that? Without the retractor, longitudinal incision is a good approach, I believe. It depends on the preference of the patient. Just I happen to prefer this approach. Once you have it exposed and dartos tissue is dissected and cut off, but scrotum has a huge supply of the blood, it can lead to bleeding. So I just widen the window using the retractor. I have it settled. And scrotal approach surgery, retractor is what I use most. In more than half of the cases, I believe that retractor does its work. it reminds me of the surgical steps, and the view field visibility is much better. One of the strengths is the proximal papilla is clearly exposed. The most challenging case is proximal dilation. When you try to insert it, it's blocked. That's the most important, difficult case. You have to have a very good exposure in order to do insertion. So this approach has a very strong, very good advantage of having a very good exposure. Vicryl 2.0 is used for the suture. UI6 is the needle that I use. If the needle is too thin, then when you do this suture, it may just bend. UI6, when you do have one suture, it's 1.5 centimeters, so UI6 is my favorite. Corporal stay suture. Laterally, if you go to laterally, there is much more likely to have a bleeding. It can lead to the complaint of the patient. So corporate suture, please do it close to urethra, but not too close. If it's too close, it's going to be difficult for you to do the resurgery. So not too close, but optimally close. And as for the needle holder and scissors, it has two functions. Yes. Olsen-Hega, it's the name of the needle holder. You can use it for the suture and for cutting. Bundangcho Hospital doctor used it, surgeon used it, so I started to use it after I saw him using his operation. Retractor, we do not have that many imported, but suture is cut. I made a mistake. Fibrosis was not severe. You can just go in right away. Fibrosis was not that severe. And serial dilation can be omitted in such a case. It was another case with a severe fibrosis, and he scratched deeply. But if it's severe, what do you do? Do you do dilation? I use carbonatum first. Carbonatum Uramix and Rosella carbonatum are available. For this, metal carbonatum is available, so proximal it's better. For the distally, Uramix carbonatum is better for dilation. Once I do the dilation, it works, it's okay. If not, then we need to open. It's like opening the belly of the fish. Fibrous tissue should be removed in order to make a track. Otherwise, you cannot close it. Bobby, you can bend it and scratch it like you are doing the bobby to remove the tissue. I do not use TR, but use bobby. Coloplaster company Uramix dilator, it's what they produced. Rosella has a patent for that. And that company, they came up with the Uramix only. It's very good for distally. For the proximal, it cannot be applied. So you have to have both of them. One for distal, the other for proximal. Some muscular placement is done. The clamp, the longer one is used, and two wrist or joint, one is used. As for this patient, radical prostatectomy was done. He has received radical prostatectomy, and then in such a case, the fascia is very strong, which makes it difficult for us to do dilation. So use it as a backbone and go perpendicular when you work on this kind of patient to have a space. This is not the anatomical space, which means that you may feel a strong resistance when you go in. Some muscular placement, it was available about 7 years ago. Angor and other research study teams released their paper. Some muscular, they thought that they did some muscular, but 1/4 of them was not submuscular. So submuscular place was developed by a certain company. They do not do the blind procedure anymore. Rather, they have a clear visibility first. Ectopic reservoir is what I expect for this patient. This radical prostatectomy, is that what the person received? That's right. And space reticulus was gone. In such a case, you may insert it in the reservoir into that if you try harder. But if you do that, extra-iliac vein, it's located much closer. As for the external iliac vein, it's 3 centimeters away on the average, but in the compromised case, it can be 1.5 or 2 centimeters. And if you apply some more power, there can be a vessel rupture. So space reticulus you have to avoid as much as possible. Pelvic fracture or radical cystectomy. And if the patient have a radical surgery in the past, I try not to use that. Pelvic bone fracture is the most serious situation that we face. Space reticulus, I try to insert it in such a case, which was very, very difficult. And after that, I go for the ectopic.
다 시도가 되고 있는데, 좀 전에 얘기한 서본 머스큘라가 있겠고, 그 다음에
So next to the reticulus, there are a lot of approaches. Then what do you prefer the most? Subrectus, I would say, among the submuscular. For most Korean patients, they're not that fat in most cases, unlike me. They do not have a lot of belly fat or abdominal fat. As for these patients, if we try oblique, the reservoir would stand out. It would look like a floppy bread. So I give a warning to patients before surgery that they can be visible and they can be touched. But then giving a previous warning does not mean that we can feel safe and we are saved from potential complaints. So we are trying to make sure that the reservoirs are hidden, and that is I try to put it under the muscle based on the experience from the angular ring. And to the median side, you are going in with the suture. If you look at the good video case, maybe laparoscopic vision is used to double check, or if you did a great job, right job, do you feel different to the touch of your finger? If the reservoir is put in submuscular plane, the patients feel pain. But sometimes if the place is in subcutaneous plane, it doesn't give pain to patients. And also when we feel the reservoir and we touch the location of the reservoir, and if the reservoir does not swell up, it's okay. But if it gets swelled up, it landed on subcutaneous plane. And even when it's subcutaneous, you can touch it, but after 2 to 3 weeks and after 2 to 3 months, it just goes down. And rectus is way thicker. And the reservoir goes down to abdominal wall. So that is why I go for submuscular. If you use implant from the copulus, the AMS use concealed reservoir. Coloplus 125 cc is very shallow and narrow and thin. So it's low profile, and when concealed, it's flat. When it comes to AMS conceal, I do not use it for active reservoir concealment because I had 2 cases where after 3 years, reservoir failed actually. So I placed them well, and I did 100 cc's filling, but it somehow teared up. It was torn up. And I requested the headquarters, and I was told that I1 was the only case, but it was actually not. As for the vendor I mentioned, I don't recall the cases of listening to failure cases, so I recommend that. If you go too deep in the reservoir, you cannot touch it, and it's too shallow, pump-wise, if it goes too deep, you cannot touch it. So you make insertion of the pump so easy. You made it look like so easy, so how do you do that? I expose the corporal through the dartos layer, and we go sub-dartos layer and make another hole. So we approach it from the back part of the scrotum. If inserted like this, pump manipulation is difficult in the initial stage, but about 1 or 2 months, it looks okay. It works fine. So although the initial training can be difficult, but I think that it is better to make sure that the pumps are not touched. So I prefer to have a thick layer of tissue before the pump. We are a bit behind the schedule, so since you're gonna have to show a similar video, maybe we can skip some of the parts and move on to the next one. Yes, this is not my case. Marco Capucci, professor from Italy, did this surgery. Extraperitoneal placement is being conducted, and here, right ASIS, like 33 centimeters right next to it is the surgery spot. When you do high valicosectomy, this is the incision that is used. And after this incision, you do muscle dissection. And after opening up peritoneum, and in the lateral peritoneum space, you put reservoir in. In most cases, patients do not have an experience of having this radical surgery. So on top of the ectomy, maybe some patients have adhesion cases, and some come to do the implantation after multiple surgery, and in these cases, lateral retroperitoneal approach can be a good way to go. So that is why I prepared this video. I only had 1 case about this, and I didn't film a video. So I borrowed Professor Capucci's video. So that's how you insert this, and using tonsil graft, you extract the long tubing and link it with the penile implant pump. In this case, it doesn't matter if you use 125 cc's or 75 cc of reservoir. In this case, when you use AUS, it works better. As for AUS, balloons should not be pressurized. That is why I say in terms of AUS, this method is easier. When you try to penetrate a thick layer, doesn't it bleed? I do not have experience of seeing bleeding, but I'm actually approaching it through subcutaneous layers, so I think it's going to be fine. Doesn't this increase the risk of infarction or reserve for failure? Yes, the reports say that it doesn't matter if it's conventional or atopic, but we're trying atopic in difficult cases and in difficult patients. So the atopic, complications rates may increase, but in terms of infarction, the rate is not that different, be it conventional or atopic. The next is the revision surgery for mechanical failure. So you are doing subchronism. Of course, it always comes down to who the surgeon is, but sometimes you rely on the same approach, and sometimes you rely on alternative location. Then how do you decide? Do you use the same approach, or I try to use the same incision from the first surgery, because we might have to go for another revision after this revision surgery, right? So if possible, I try to use the initial incisions made. In case of revision, what I do the first is to identify the tubing or implants, and after that, I dissect the capsule and try to go in. When you do revision surgery, because of the previous surgery, adhesion is there and tissues are not healthy and they have changed a lot. If you are a newbie, or some surgeons try to identify the pump first because they're easy to identify and try to go down from that on. But some surgeons say that we have to go for corporal right away. What is your take? I identify pump first and then try to approach corporal, because urethral damage is something that we're trying to avoid the most. In many cases, pump is located near the urethra. If we just try to find out the cylinder and pull out, identifying the location of the corporatum itself is not that easy as well. So this is a simple mechanical revision. And if the surgical field, the surgical field is well visible and guaranteed and secured, but in most cases, in some cases, this is a luxury. So we find out the pump first and then try to sort out and clean some of the capsules that obstruct my surgical view and try to find corporatum next. The biofilm from the previous surgery would be there and infection rate will go up accordingly. And some literature say that infection rate can go up to 18.8%. Unlike the initial case, do you use the same the combination of antibodies in the revision cases as well? Yes. In case of the simple mechanical failure, we remove the implant and put back the implants in, and then the infection rate was about 15 to 18%. And as was said, as you put it, the biofilm was the issue. So bacteria might be hibernating there. So biofilm was being created there somehow. And at the revision, we touched the biofilm, and maybe this activated bacteria and led to infection. And after that, Dr. Wilson and Dr. McKay tried wash-out methods, and I'm trying to mimic that technique as well. 50% peroxide and 50% betadine and antibiotic solutions are used. So this is the anti-solution, and I do irrigation for every space so that we can create antiseptic effects. After this mini washout, the infection rate goes back, and the level is quite similar to the initial first surgery. And in my case, from my case as well, I don't think the infection rate is particularly high when compared to the initial first-time surgery infection rate. Now we are trying to move the capsules. We do not necessarily have to, but the pseudocapsule was sitting really close to the urethra, and I was suspicious that this might cause stricture, so I decided to remove this. In all revision cases, you try all these, or as for this patient was particularly risky, or do you find any cases where the revision surgery is particularly risky and you have to give up? So my question is, do you do revision surgery if patient wants, or sometimes do you have any cases where you had to reject some patient despite they want it? As for the simple mechanical failure, no. But after infection, or 3 or 4 times of repeated infection, and corporal fibrosis was very severe. And I remember a particular case when the patient was old, and I just tried to delay the operation, maybe come back to me after a year, because it is not a life or death problem, right? If that's too risky, we might as well not do this. mechanical, like revision surgery. Here I'm trying to approach and remove the reservoir. And removing reservoir is the largest and the biggest headache in this procedure. Oh, sorry, it is not reservoir. I'm trying to remove the cylinder. Sorry, yes. Yes, as you pointed out, removing reservoir is very difficult. Sometimes the tube would be cut off. And I took a look at this video beforehand, and the reservoir was cleanly removed. And is there any tip you can use for the clear removal of reservoirs? After removing reservoir, actually, in case of the simple mechanical failure, if difficult, many say that you can leave the reservoir, and a report says that in 98% cases, it's okay to leave reservoir, but I don't think that's actually true. But if the reservoir removal is that difficult, you can just leave it that way, but sometimes this can migrate and lead to complications. So in this case, you have to cut the tubing short, and bicletor or non-observable suture should be applied to fix this reservoir so that it does not migrate and cause any more problems. And if you fail to remove, I think I try to do fixation for the remaining reservoir.
저는 예전에
In the past, I had it left behind. It causes a problem, so I removed it going through inguinal. Yes, it can cause infection and other problems. That's right. So I try to remove it if I can. But if not, we cannot. So conventional devices, some of them may go malfunction, but you remove all of them. That's right. Yes. What is studied is that if the pump is the only problem, single component exchange, if we do that, what happens? Then it can cause complications and other problems. So cubic fracture and any problems, if there is any problem, then I just remove all of them. And I believe that tubing is said that it's fractures, then other things might have the problem too. Yes. If one component has a problem, then you have to remove them all because the other components might have problems as well. Yes, and then they have also biofilm. So in that aspect, it might be better for us to remove them all. That's right. In the floor, we have senior doctors, Dr. Beck and Dr. Kim. And we have our senior members and surgeons and colleagues. So you can ask kind of questions or make comment. I am doing mini washout. Reservoir was removed, and we are trying to use the space where the reservoir was placed. That's why we are doing the irrigation this way. Why? Because I can use that later on. But we cannot use the same space all the time because from time to time, so the capsule, it may go shrunk. So if it does not work, I may go retro side. Did you do washout? Yes. After washout, I had the reservoir removed. And for the rest of the procedures, it's about the same. You put in the reservoir cylinder and do the suture. What is different is remover. And the rest of the procedures is about the same. For the revision surgeries, there were some studies done. And when you do the measurement, cylinder 1 or 2 centimeters or longer. So you have to check all the time and find the right size before you insert it. when you do the ectopic placement, Dr. Wilson came up with the long grasper forceps, which is not available in the Korean market. The rectal subnum, you can go that way, and it does not cause any trauma. Yeah, no, it doesn't cause any problem. Or long grasping forceps is available, so you can use it. Long grasping forceps, the joint is located on the tip, so it does not cause any rupture or tear. So you can prevent trauma. This is a revision done doing scrotal approach. Dr. Kim, do you have any revision cases? Anything? Any comment that you want to make? Can you hand over the microphone to him? For the revision cases, in mechanical failure, it doesn't cause any problem. What matters is an infection. Once you have an infection, the operation can be complicated and challenging. Because of the infection, if you had to do revision, then corporectomy need to be handled completely. That's why I make a long incision in the first place. I see. Thank you. As said, I'm trying to use the same space, but it got shrunk, so I entered the contralaterally, the opposite side. Dr. Kim, as Dr. Kim said, infection case revision is the most challenging. The outcome can be worse. As for you, do you do salvage technique right after that? Or do you get the rescue surgery deferred or delayed? I do not try salvage because no matter how good you are, the success rate is only 70 to 80%. And you have to have the patient hospitalized and put the patient on antibiotics for about 1 week, which is difficult for me to do because I run my own clinic. So I have it removed and wait for 3 months and then do the delayed approach. That's what I use. If I fail again after a first failure, it will be very kind of difficult case. I cannot explain. How can I explain it to my patient? Any question? Can I ask a question? Sure, yes. Ectopic. You did the ectopic. If the retrus is in the normal position, do you take a conventional approach? When do you take the ectopic placement approach? Can you explain? Unless pelvis is compromised, space latches is where I approach. Korean patients tend to be slim. If once it is protruded, I have nothing to say to the patient. I have re-surgeries. That's why I go for ectopic, external lingual, and around the fascia. We have to create a space, which is quite difficult. Once you fail that, you have to make a separate incision and try again. And now I make a separate incision from the beginning. And below that, I do not go for the lateral approach. But as for you, you are doing a very good job, even though you are approaching below the spot that I usually do. And the forceps that you use looks very good. And it seems that the ring forceps seem to be very expensive. I wanted to borrow from another doctor. He didn't let me use. Okay, as for the ring forceps, do you think that it's very useful when you do the operation? Yes. Forceps, it cost 8,000 per set. It was too expensive. I didn't afford it in the past. As for the forceps, what matters is the adhesion. If you want to do dilation with the blunt tool, it's going to be very difficult. So you have to secure the ring, and then upwards, you have to use a Kelly to do the approach and make some kind of channel or pathway. Then you have a better access. If there is a strong resistance, then Kelly mosquito is what you need to use to do the dissection and then do access. Thank you. Dr. Bach, this is a very time-consuming procedure, but you have done it very efficiently. It was very impressive. You have reduced the operation time a lot. As for me, I have more cases of infection cases, not the virgin or fresh case. And this patient is on the supine position. But as for the infection cases, I take a different posture. And I want to know the right level of the power or force that I should apply. For the infection patient, what will be the best position? Supine is best for them? Yes, I continue to have the patient on the supine position all the time. I wondered whether prone will be better or not, but in Germany, I had a discussion with Dr. Wilson. They talk about the difficult case. And proximal dilation, when I do it, I was very careful, but they didn't hesitate. They did the very rough dilation, and I asked, how come? What about proximal perforation? Aren't you worried? And he said that once we have that, we can solve it. Reducing the operation time is much more important. That's what they said. Since then, rather than doing the dilation too carefully, I just go with the rectum and then do the bone touch as much as possible. If perforation happens, and I do fixate with the butt sling. And supine position, butt sling suture. Can you do that? Do you have enough access to that? And the supine position? As for the perforation, you do not repair it. On the cylinder, we just fixate it through the cylinder, so we can access in the supine position. No worries. My name is Jo Sung-won from Myeongdong Clinic. I do run my clinic and then have some questions, a couple of them. After the infection and the revision case, the fibrosis is there in the lesion, which means that we cannot have the big size as before. And as for the tube available in the market is too big for the Korean patient. How do you solve that? Patient complain it's too big. After infection, the sponges some size shrink by about 30 to 50%. So you have to tell them, first surgery is the recovery of the sexual function? No, that's not that. That's just lay the baseline. You have the inflatable inserted, and 1 year later, the spongism is recovered. So 1 year later, you can exchange the system. So after 1 year, you can have the erectional function recovered. So that's what I tell to my patients before the surgery. What was the second question? Tube, yes. Coloplus, as you said, AMS is fixated. As for the Coloplus, the longer the cylinder, the longer the tubing. That's the downside of the implant. If it's too long, I just cut the tube, and then connect it again. Thank you. Dr. Beck, do you have any comment before we wrap up? Dr. Jung, you asked the question. Let me answer the question based on my experience. When I was with the teaching hospital, I had very difficult cases. Cystoprostatectomy was done, neobladder was created, and that case is very difficult. That means that all the bowels came down and peritoneum is not fully surrounded. So some muscular approach is quite difficult to do that in such patients because the bowels are adhered to each other. As for the submuscular, we can avoid many risks and secure some protection in the initial stage. But inside, as long as you do not go into the peritoneum, that's a good approach. Back in 2016, I had a paper published. Next to the belly button, rectus, above the rectus, the skin muscle, all of them are turned up so that we have enough protection. And below the peritoneum, I placed the reservoir safely. And then line got out. I took it out from subcutaneous approach. Dr. Jung, what you were worried can resolve by taking that approach. Submuscular placement, you do not need to stick to that incision. If it's a very, very complicated cases, you can take a different approach that I mentioned. Thank you so much. Time is up. So we are going to wrap up this session. Thank you for attending the session. I'd like to thank all the speakers and panelists, and I'd like to thank the audience too. With this, I'd like to conclude the session. Thank you so much.